Good morning, everybody. Some of you guys know who I am. If not, my name's Nate. I currently on C shift. I will be moving to A crew here shortly, so that I can do the. Thank you. No points for sucking up. Sorry. There you go. All right. And just one more handout. We have this little handy guide. Throughout the course, we will be giving you guys these like sort of handy little course materials. Sometimes we'll print it out for you. Sometimes it will end up in the Google Classroom. But yeah, there's just little supplementary things that we have found in classes past to be useful. There you go. All right, so today we're going to be talking about ABG interpretation. Our goals for this lecture, or objectives for today, is really just to get like the basics of what you're looking at when you see an arterial blood gas. And also, well, a few other things, but one phrase that I started using a lot last year, you guys will hear me say this a lot, it gets infinitely more complicated than what we're going to talk about today. When we get into renal diseases and disorders, what we're going to end up doing is we're going to take this a step further. This is not the end-all be-all of how to interpret an ABG. This is just like the sort of the foundation, the ground level, and we're going to build upon that a little bit later. Okay? So something about diagnostics, I feel pretty strongly about this when it comes to certain things, is don't get hyper-focused on just one part of your assessment, just one set of things. Something you guys are probably familiar with, or maybe you've even experienced it, that I see very often is like a lot of times people will get hyper-focused on the ECG and they kind of sort of forget other things. So it's like, oh, I've got this ECG, then this is now what my patient is, right? So all of your other diagnostics aren't really any different, okay? Then when Dr. Tan gets into his lab values lecture, you'll kind of understand a little bit more of what I'm talking about. How all of this stuff is related, and it's all just, you know, sort of one piece of the puzzle here, okay? So nothing is emergency or critical care medicine. In critical care, it's a little bit more. This statement is a little bit more true, just because we have a lot more diagnostics that we're looking at. So with ABGs specifically, so one of the things that I wanted to talk about, do like a little bit of sort of sacred cow killing, is that it was previously believed that a derangement, specifically acidosis, was like this super dangerous thing that we had to be extremely aggressive to correct. Turns out that that's not really as true as we thought it was. There's a significant body of evidence that exists to say that human beings actually do tolerate these things a whole lot better than we thought. When we get into mechanical ventilation, when we get into mechanical ventilation, one of the things that we'll use an ABG for is to sort of guide our ventilator strategies. And we're going to talk about something called permissive hypercapnia. You guys may have already heard that term, but it's sort of related to this. So I'm going to dive right in. What is pH? Okay? So pH down at the bottom is expressed as, in mathematical terms, is the inverse log of the hydrogen ions in your body. Okay, it's basically how acidic or how alkalotic are we, okay? As we move down, as the number gets smaller, we become more acidic. As the number gets higher, we become more alkalotic, right? So when we see a pH that is lower than 7 is technically in chemistry terms for the human body, it's 7.4 is what is true neutral. We would refer to that as an acidemia, okay? An acidosis is what is causing the acidemia, all right? It's like a small like mincing of terms, but just, you know, so you guys understand. When we refer to an acidosis, we are referring to whatever it is that is causing the derangement, right? Well, that value, it's just an acidemia, you know, conversely, and alkalemia if it's the number has gotten higher. So temperature and pH are intimately related. So why does the human body have a pH of 7.4 and a temperature of 37 degrees Celsius or 98.6 degrees Fahrenheit? It's because those two things, when those two conditions are met, that is the most conducive to all of our biochemical reactions. All right, so like that's basically gives you optimal, like everything is working perfectly when we have like temperatures and pH that are in those ranges. I mean, if you think about it, anytime that you've had a fever and your temperature is elevated, none of your bodily processes are really working very well. Okay, that's sort of why you sort of feel like that feverish feeling, like just things aren't doing what they're supposed to be doing. Okay, when we talk about specifically the ABG, we're looking at two values here, and it's a balance between CO2. Which is the inverse log of hydrogen ions. Hydrogen ions are always going to be attached to something, and in this case, in the case of the human body, it's going to be with CO2, right? So it's going to be the delicate balance between CO2 and bicarb. So those are the values that we're going to, or two of the values that we're going to be paying like close attention to when we go to interpret our ABG. So there's a few rules that we're going to be going over. This is one right here. So we just talked about CO2 and bicarbonate and how it's a delicate balance between the two. These two, like this is, carve this in stone, right? This is a change in the PaCO2 of 10 will produce a change in the opposite direction, the pH of 0.8. A change in the bicarb of 10 will produce a change in the same direction in the pH of 0.15. So for example, if we are at a perfect value of 7.4 for our pH, it's right exactly where you would want it to be, in the middle of that range, and we increase our bicarb by 10 milliequivalents, our pH will no longer be 7.4, our pH will then be 7.55, because we added 1.5, because we put a whole lot of base, essentially, we put a whole lot of bicarbonate into the system, and so it's going to move our pH pretty significantly. So you see that manipulating bicarb actually has a more profound effect than manipulating the PaCO2. The carbonic acid bicarbonate buffer system. So we're going to talk about, this is the first of your body's compensatory mechanisms to try to maintain that homeostasis. Okay, try to maintain that. Your body is always going to be fighting to get that pH of perfect 7.4. This is the first way that it's going to be doing it. This is a chemical reaction. The arrows that are pointing both directions means that this process can move in either direction depending upon what your body needs. So if we have, too much CO2 in the system, your CO2 will, it'll be interacted with by an enzyme called carbonic anhydrase. You guys don't need to learn necessarily all the chemistry terms. If you want to know specifically how it works, it's very useful, but we will go from water and CO2 get interacted with by the carbonic anhydrase. We'll go to our carbonic acid, which will then be turned into bicarbonate and a hydrogen ion. Okay, so it can move one side to the other. So if we have too much CO2, it can be turned into bicarbonate. If we have too much bicarbonate, it can be turned into CO2. Okay, and then those things, whatever we turned it into, can then be excreted or eliminated from the body, depending upon which compensatory mechanism is, or which system is causing our derangement, or which system has an issue where the derangement is coming from. This will move those hydrogen ions to the other side of the equation, and then eliminate it. So the first one is the respiratory compensatory mechanism. Your carbonic acid bicarb buffer system is the fastest. This happens instantaneously. However, it is only able to handle so much. Okay, you're only able to. This can only take care of so much in more or less, ideal circumstances. It'll be pretty effective. It'll be effective enough to kind of handle what we got going on. But when we start getting into more significant derangements, we need to call in some reinforcements here. And the first one will be the respiratory compensatory mechanism. Your body can either retain or repel CO2. You guys understand this sort of intuitively. If you think about a DKA patient, we know the DKA patient is that is sort of one of the classical examples of a metabolic acidosis. So what does your body do? You breathe very rapidly, very deeply, because you're trying to blow off all that CO2. Okay, we're trying to get rid of it. Conversely, you can actually slow down breathing to hold on to that CO2 if you find yourself in, or if the body finds themselves in a alkalotic derangement. It's faster than the metabolic system, which is what we're going to talk about next, the kidneys. However, it is not as effective as the metabolic system. The metabolic system is, your kidneys are really, 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 really good at mitigating the amount of CO2 that you have in your body, the amount of heavy, sort of strong acids that you have in your body. Your lungs aren't as good, but your lungs are faster. Okay, so we can have faster, not quite as effective, or we can have slow and steady but very effective, right? It's not that dissimilar to like if you're performing a skill. If you try to rush yourself, you're not going to be quite as sharp as if you really take your time and do something, and how effective you are. Yes.
So the carbonic buffer system, that's first what happens, right?
Yes, that is an
respiratory
instant chemical reaction.
Okay.
Yep, it is an instant chemical reaction. This reaction here, something that we used to do, we're still going to talk about it because it still pops up on tests, but the clinical utility is not very high. Like we used to do bicarbonate replacement, like we used to just we're just going to dump ampules of bicarb on you, whatever. And we weren't really accomplishing what we thought we were going to, and it's because of this. Because if you just dump a bunch of bicarb into the body, what's going to happen is this chemical reaction, right? Because you got to think about it like this. If a patient is in an acidemia or an alkalemia, like if they have this derangement, they didn't get there like that. Okay, so we really shouldn't be trying to fix it like that, right? It's like sort of slow and steady is going to like win, like they didn't, Rome wasn't built in a day. We're kind of living in the same here. So, and then the kidneys, okay? Kidneys excrete hydrogen, and they actually retain bicarbonate. It's the most effective, but it takes the longest. Like I said, it's nothing really more to expand upon. With that, your kidneys are very, very effective. They're very good at doing their job. This is like one thing that you guys will notice if you start doing critical care transfers, or if you already have, or if you just sort of notice it, like almost everybody in a critical care setting has a Foley, and it's like because measuring urine output is an incredibly useful metric that we can use to see how well our patient is doing, just in a number of different ways, number of settings. So this is what the ABG actually looks like. When you get your sheet, like when the lab values are spitted out on a piece of paper, this is what it's going to look like. You're going to have your pH, and these right here are the sort of perfect values. So this is the interactive portion where we're going to write down our ranges. So our pH, perfect, is 7.4. Your range is 7.35 to 7.45. All right, 7.35 to 7.45. You have that range in which your body can still do what it needs to do before things like really start kind of getting out of whack, right? Like before, I mentioned that on the slide previously that in chemistry terms, anything that is less than 7 is an acidemia. Anything that is greater than 7 is an alkalemia. With terms of the human body, it's anything less than 7.35 is an acidemia. Anything greater than 7.45 is an alkalemia. You need to figure out what your derangement is, what is causing it, what is the acidosis, what is the alkalosis, so that you can treat it appropriately. Okay? CO2, similar thing. It is 35 to 45. All right? It's just like your end-tidal CO2 is a wonderful analog for this. The numbers are exactly the same. Anything less, now this is where it's going to start getting a little tricky. Anything less than 35, would that be an acidemia or an alkalemia? What do you think? Alkalemia, very good. Anything greater than 45 then would have to be an acidemia, right? We have more CO2 in the system. So if we have more CO2 in the system, we know we have more hydrogen ions in the system.
Are those PaCO2 and EtCO2 interchangeable?
I would say no, they are not necessarily interchangeable. Like I said, that's why very specific, like it's a decent analog, okay? But I would not say that they are exactly one-to-one. Right? There are a number of disease processes that can be happening. Like for example, like if you have some sort of respiratory shunt, right, where like maybe your lungs aren't participating the way that they're supposed to, you're not going to get a good reading. Like you're going to have your blood and whatever you're exhaling are maybe very disparate numbers. PaCO2. PaCO2 and EtCO2. They are not interchangeable. I just said that like when things are working under perfect conditions, it's a decent analog. Okay? It is not one-to-one, but it can give you a pretty good idea. Okay? PaO2, that is just the amount of dissolved oxygen that we have in our blood. That one doesn't really have a range attached to it, nor does it really have any impact on what our ABG is, but it is a number that you're going to have to pay attention to. 100 is our normal value. Depending upon the reference material you look at, some might say it's like 120-ish is your normal value. That's another thing that can be a little bit frustrating when it comes to this sort of higher level medicine. If you guys have ever noticed this, if you look at paperwork from like SSM versus paperwork from BJC, sometimes their ranges for what is quote unquote normal are different. Okay, so we are going to do our best to point out when that happens. Luckily, this is not an instance in which that is the case. Like these numbers are like pretty well universal. So bicarbonate is again a perfect measure of, or a perfect number of 24. Your range is 22 to 26. So if I had a bicarbonate of 21, what do you think I have? Do I have an acidemia or do I have an alkaline? Acidemia, very good, yeah, because like something is eating up that bicarb. Something is taking that bicarb away from the system. The only thing that takes away bicarb from the system is a strong acid, okay? And then our base deficit or base excess, depending upon which one it is, right? If it is a negative number, that would be a base deficit. If it is a positive integer, that is a base excess. That is just how much bicarbonate do you have in the system versus how much do you need. A perfect base deficit would be 0, but our range is -2 to +2. Okay, you can have, you can be missing 2 bicarbonates, or you can have 2 extra bicarbonates before that becomes an issue. Again, the clinical utility of the base deficit really is to calculate bicarbonate replacement. Like that's the greatest sort of thing that we have. However, like I pointed out before, we don't really do bicarbonate replacement, at least in the way that we used to previously. We sort of have greater understanding of things that causes alkalemias and acidemias. We have greater understanding of the disease process, so it's not really something that's done a whole lot anymore. All right, there you go. I was ahead of myself. There we go. So that's what just a slide on the explanation for what base deficit or base excess is. Doctors Henderson and Hasselbeck. So Henderson, they came up with this equation right here because, believe it or not, the bicarbonate is actually not a measured thing. Like we don't like get a blood sample and spin it at a centrifuge and be like, oh, look at that layer, we got that much bicarbonate. It's actually this very complicated equation here. And for those of you who were suggesting our test was not difficult enough, this will be on the next test for you. But yeah, they take the PaCO2 and the pH. That was a joke, if you guys know. I didn't sleep a lot last night. Yeah. I can be a little too deadpan. That and I didn't sleep much last night, so I'm basically just going on Adderall right now. So, excuse me. So yeah, so actually, we don't actually measure what bicarbonate is. We plug it into this equation and we figure out what our bicarbonate is, okay? 2 very smart guys, Henderson and Hasselbeck. The doctor part is a bit of a trivia question, but it is important for you to know that the bicarbonate is not an actual measured thing, that it's a calculated value. There's a couple of different examples when we get to some of our diagnostics that we're going to be relying on that are also calculated values, that aren't things that we are directly measuring necessarily. So we're figuring it out based on other factors that we can measure. A venous blood gas. Okay, so an arterial blood gas is it's very accurate, and it is kind of sort of like the gold standard versus the venous blood gas's silver standard. The issue is that there are some problems with that. Cannulating an artery is a very painful procedure for a patient. I don't know if anybody's ever had an artery cannulated. I haven't.
Literally one of my first biggest fears.
Yeah, you'll know, like if you ever go to start an IV on a patient and you hit an artery, you will know immediately because it's very painful. It also represents a even greater sort of vector for disease transmission. That and we don't want to go around poking holes in people's arteries if we don't absolutely have to, because obviously poke a hole in an artery, it's a lot more difficult to occlude. That bleeding is a lot more problematic, a lot more dangerous, you know. So as one thing that we can do as an analog is we can have a venous blood gas, very easy. We just, you know, you already have a vascular access, just draw some blood out of it, plug it into the iStat, and it's going to give you your VBG. Now, you'll notice numbers are pretty close, but they're a little bit different. The pH is reliably 0.04 lower than your arterial blood gas. Why would that be? Why would your VBG be slightly acidotic compared to your ABG? Yeah, very good, because you're on the other side of cellular respiration, so there's going to be more CO2, so very good. Same thing with the PbCO2. It is reliably 6 millimeters of mercury higher, because remember with gases we're talking about partial pressures. So instead of having the 35 to 45, we're at 41 to 51, and the difference in bicarb is reliably 1 milliequivalent higher, okay? The PvO2, this is a value that they give you, but don't be super concerned about that right now. Now, one thing to take into consideration. I say that these numbers are reliably, you know, like these gaps from an ABG to a VBG. That alters the more acidotic your patient is, okay? The more profound your acidemia is, the less reliable that comparison becomes, okay? So that might present a scenario where if you shoot a VBG and it's like, it says that I have a pH of 7, these numbers have now become pretty unreliable, and I might want to consider at that point cannulating an artery to get a more accurate, numbers. So what am I actually dealing with?
Would it also change where you draw the blood at? So we do a central line versus like a hand IV? Would it change the numbers based on how high?
For the VBG, not significant, no. I mean, no. I mean, it's venous blood is venous blood, right?
I didn't understand it as like glucometers, they do.
Oh, no, no. Yes?
The SCCAD, critical care units of point of care testing.
The critical care units, no. The MIH units, yes. That is a discussion that's above my pay grade, so I will withhold my opinion of that.
Does the point of care testing do ABGs?
You can do VBGs on it. Yeah. Because so we don't, and that's our clinical guidelines sort of thing. Like we have a very narrow set of circumstances in which we can cannulate an artery, and just to draw an ABG is not one of them. You know. So, I mean, if it's one of those things, like if we did, like one instance in which we do cannulate, or we are allowed to cannulate arteries, would be like in a cardiac arrest situation. It has to tick a few other boxes, you know, before we can do it. But then if we did it, and then we got Ross back, and we had the ability to, I can just draw a sample off the sample port, and we would be able to, in theory, do it then.
Yeah.
But yeah, just the amount of circumstances in which that would happen are really, really narrow. Yeah.
Why are the numbers different on this versus the slide?
Very good. See, you just discovered, I said one of my points here, where depending upon your reference material, you might have slightly different numbers. No, I mean, it is one of the 4 venous values. Yeah. Yep. So.
I'm just like, I've been in a scenario, you know, like.
Right, and so here's the thing. This is how we're going to tackle that particular problem. Again, because this is like the bane of your like researching, you know, whatever. Like when we're making these presentations, we always try to make it a point to like probably, well, 3 different textbooks and a number of other resources like went into making this, you know, whatever. And it's like you do find conflicting numbers sometimes, and it's just really frustrating. So as far as that is concerned. We will clarify in the Google Classroom like which one that you guys are likely to see on a test, okay? Like if it's going to be handout versus what's in the slides. So that's how we'll tackle any kind of discrepancies. That'll sort of be the same like moving forward. if we find a discrepancy, because like for example, the IBSC test is written out of 2 different textbooks. One of them is the textbook that you have, and then there's another textbook that they use. I haven't found any yet, but I would not be shocked at all whatsoever if there's discrepancies between the 2 of them. And those are on your board examination. So we will, like I said, we'll do our best to be very specific, because there's a few other things where you might hear Brian or myself say the phrase "for this class," like this is what this is. Okay, yeah, very good. As like you said, I guarantee you, if you spent an hour searching, like in our library here, textbook, you could probably find 3 or 4 different, and they're all pretty close, right? I mean, it's not like they're not wildly different, like they're within 0.02 or so of one another, right? So. Cool. All right, interpreting the ABG. There's a few different methods that we can use. Some of them that we're going to use to make things a little more fun. One of them is the tic-tac-toe method. All right, you guys have all played tic-tac-toe. You were all children at one point, I'm sure, except for Russ. Russ was grown in a lab.
Still stuck in the children.
Yeah. So with the tic-tac-toe method, you're going to visualize a tic-tac-toe board, but the top 3 lines are already filled out. Okay, somebody has already made a straight line. Okay, so we're not trying to make that straight line, we're trying to make our own straight line. Okay, we have acid, neutral, and base. Or you can say that the middle one is normal, like if it's within our normal range, right, because it's not true neutral, whatever. And then you're just going to you're going to look at your pH, you're going to look at your CO2, and you're going to look at your bicarb. Okay, so the first one you're going to start with is you're going to look at your pH. And you're going to say to yourself, is my pH, am I dealing with an acidemia or an alkalemia? Okay, make that determination, and then you're going to put that one. So if I say like I have an acidemia that I'm dealing with, I'm going to put it under the A. I'm going to put it under that A column. Okay, we're trying to make a vertical line, right? And then I'm going to look, all right, cool, so that's what my pH is. And then I'm going to look at my CO2, and I'm going to make the determination, is my CO2 trending towards an acidosis, or is my CO2 trending towards an alkalosis? So I'm going to make that determination. We'll say that it is, that our CO2 is acidotic. I'm going to then put my CO2 under where I put my pH. Bingo, I just made a straight line. Okay, I have just determined that what I have is a respiratory acidosis. Okay, my pH tells me that I have an acidosis. The CO2 being out of whack, the CO2 being the source of my derangement, tells me that that is respiratory. Okay, because we talked about our compensatory mechanisms. We know that our lungs expel CO2, so that's where like if we're breathing, we've blown off too much CO2 or we've retained too much CO2, and that's how we're going to say. So respiratory acidosis, and then I'm going to look at my bicarb, and if I have a respiratory acidosis, it's probably pretty likely that my body is at least attempting to compensate. So I'm probably going to end up with a bicarb that is more on the alkalotic side, and then I'm just going to put that over here just for completion's sake. Okay. But if you make a vertical line, all right, on your tic-tac-toe game, you have that now figured out what is the source of your derangement. Is it metabolic or is it respiratory? Everybody understand? Here's an example. So we got a pH of 7.23. You would agree that our pH 7.23 is acidotic, right? So I'm going to put my pH then goes here, all right? And then I'm going to look at my PaCO2. My PaCO2 is 28. My PaCO2 is too low, right? Because our range for that is 35 to 45. So with our PaCO2 being 28, that is going to go over here in the base category. That's why it's a B, because 2A's would be too confusing. So it's going to go over into the base category. And then I'm going to look at my bicarb. My bicarb is 11. Okay, like we just discussed, if my bicarb is lower than it's supposed to be, that means there's a strong acid that's present that's eating up that bicarb. And so there we go. We now have a metabolic acidosis.
So could you also use this to determine if it's respiratory or metabolic compensation, depending on which side?
We'll get to compensation here in a minute. Okay, we'll get to compensation because compensation, that's where the plot begins to thicken. Yeah, because there's more to consider with compensation, whether or not it's occurring, whether or not it is appropriate, because we have a slide a little bit later. Well, actually, there's a slide a little bit later where we're going to kind of go over that. So But to answer your question, not yet. Okay, not yet. But I like where your head is going. Okay, the winner is acid. Okay, the pH and the bicarb, they're matching. That means that we have a metabolic acidosis. Metabolic acidosis. Cool. Everybody likes playing tic-tac-toe. That's a sort of like that's a great way to look at it. Okay, the color method. So I like to think about the color method because, so we'll get to the slide here. So blue and red come together to make purple. Okay, so here we see we have a color gradient. On one end is red, on the other end is blue, acid, base. In the middle is purple, neutral. Okay. If you have purple, right? So if we have that neutrality, right? And we add more blue to it, and we keep adding more blue, and we keep adding more blue, and we keep adding more blue. What happens? We no longer have a shade of purple, right? We have shifted over into a shade of blue. Conversely, same thing. If we remove enough red, we also end up with a shade of blue. Okay? That's why this method sort of came up with this, just to show that adding and subtracting things, right? We can either add too much of something, or we can take away whatever that thing's opposite is, and we're going to get the same effect. Okay, we're going to end up with the same thing, right? So like with an acidemia, for example, if I take away too much bicarb, I'm going to end up with an acidemia because it's all relative. Everything is a balance. Like everything in your body is trying to get balanced out, you know? Or if I add too much acid, obviously that's going to produce an acidemia. See, Prince knows what's going on. So think of acid as being red, think of base as being blue, normal being purple. All you got to do is just think about the colors, right? Just assign colors to the values. Look at the pH. If it's less than 35, we have red. 35 to 45 is purple. If it's greater than 7.45, it's blue. Same thing with PaCO2, and same thing with the bicarb. Now, the reason for the distinction is when we start getting into causes, compensation, derangements. It's like I said, understanding that the adding or subtracting of things can be either one can be the cause of your problem is going to be of paramount importance when it comes to treating things. All right, because remember, we're not treating the acidemia; we're treating the acidosis, which is the process that's occurring that's causing our acidemia, and that's what we need to treat aggressively, right?
And if we just love tic-tac and we just want to use that,
Absolutely.
that's cool, right?
Perfect. Yeah. Either method. You're not tied to anything. So we kind of want to give you a variety. If the tic-tac-toe method works for you just fine. I mean, even if you want to, get a piece of scratch paper, like when you take a test that involves interpreting ABGs, and you want to draw a little tic-tac-toe board, and do acid, normal, base, and you want to write to figure it out. If that gets you to the right answer, awesome. Yeah, this is not this isn't a math class. I don't care how you get to the right answer. I care that you get to the right answer, right? So, cool. So yeah, it's just color matching, right? So right here, like I said, this is another thing that I said if tic-tac-toe works for you, awesome. If not, if we just have our ABG here as it's written out, and I just write, oh, I know that's blue, and I know that's red, and I know that's blue, the two matching colors, just like the tic-tac-toe game, right? You've matched the two colors. Cool, I've got two blues. It's like when you were a kid, and or if, I don't know, some of you may be a little older or a little younger than this reference, but your underoos, your garanimals, where you just match the two animals together, and it's like, oh, here you go, it matches, right? So here we have an example of a metabolic alkalosis because we have a pH of 7.54. That's too high. If it's too high, we have an alkalemia. Our PaCO2 is 59. Okay, that's too high, but too high with our PaCO2 equals an acidosis. And then we look at our bicarbonate. Our bicarbonate is also way too high. That is going to match with a alkalosis. So the two of them together, we have a metabolic alkalosis. Okay, we have arrived at what our problem is. Now we need to figure out what is causing our metabolic. Okay, cool. I have a metabolic alkalosis. I can start my differential. What are the things that I know that cause a metabolic alkalosis? And I'm going to start eliminating them by doing more detective work. Right? You guys understand what I mean when I say that? Like when that's how you build a differential. Differential diagnosis. We get what we have, and then we start testing and eliminating things. Practice. And hey, what do you know? There's 12 of you, and I have 12 practice things. It's almost like I planned that. So who wants to start? Well, we'll just go to start. Russ, you down to start? Sure. All right, buddy, let's see what we got here. You can phone a friend, but guys, just only help him out if he asks you to help him out, okay? So pH of 7.33, what do we got? What is that? Acid, very good. PaCO2 of 36, neutral. Something's not doing its job. PaO2 of 80, not worried about that. And a bicarbonate of 18. Cool, so we have two, I heard you say acid twice. So what do we got? Metabolic acidosis, very good, top marks. All right, Kyle, what do we got? pH, what is that?
Our pH is on the basic side.
Okay, I'm glad that you phrased it that way. These numbers are absolute. There is no such thing as slightly alkalotic or slightly acidotic. It is a hard line. You are either in an acidemia or you are in an alkalemia.
Okay, so we're at alkalemia for our pH.
Very good. What about our PaCO2?
I think that's
Okay, well, talk through it. So what is the PaCO2 supposed to be?
35 to 45.
Okay, and it's lower than that, right? So what are we missing?
We have, what do you mean?
Does CO2, does that represent acid or base? Okay, so if that's low, then we don't have enough acid, right?
Acid is normal.
Okay, cool. And then PaO2, not worried about that, and our bicarbonate.
Bicarbonate is low, which means we don't have enough of our, it's more alkaline. We don't have enough base.
So if we don't have enough base,
Oh, my bad, then it would be acidic, yes.
okay, cool. So
Enough base, so it makes it acidic.
awesome. So then if this is what we said, this is base, this is acid, or no, sorry, this is base, and this is acid. What do we got?
We're definitely alkalosis.
Okay.
How do you tell if it's respiratory or metabolic?
Cool. All right. Awesome. So PaCO2, respiratory. All right. That's where we're living. If our derangement is PaCO2 because our lungs are responsible for mitigating or controlling our CO2 levels, right? And then our bicarbonate, which our bicarbonate comes from our kidneys. Okay. So think that we metabolize things in our kidneys, right? So metabolic. Right, and then we obviously respiration occurs in our lungs, so and that's where our CO2 is going to go. So with that, then we have an alkalosis with a PaCO2 that's too low. So if the PaCO2 is respiratory alkalosis, nailed it. Respiratory alkalosis. All right, and your body has eliminated some bicarb because it's trying to compensate. It's trying to get that number back to normal. It's trying to balance that equation. All right, what you got? Lay it on me.
So pH is alkalosis.
Okay.
PaCO2 is acidotic.
All right.
And bicarb is alkalotic.
Okay. So what do we got then? What does that mean?
Metabolic alkalosis.
Metabolic alkalosis. Very good. Very good. Also, we kind of gave you a hint with that. That's way too much, way above our base excess here. But no, absolutely nailed it. It's just a game of matching. All right, Brett. What do we got?
pH is acidic.
Okay.
CO2 is acidic.
Okay.
And bicarb is on the very precipice of still maintaining normalcy, so
Okay.
respiratory acidosis.
Okay. And remember, if it doesn't matter how close it is. It either is or it isn't. Like, I mean, it's either acid, normal, or base. Okay, so even if it is like on the precipice, that does count for something a little bit later that we're going to talk about. But just so you guys are get in the habit of like seeing it as just as definitive terms. Okay, for right now. Okay, until we get the basis. So yeah, very good. So we have a respiratory acidosis. What do we got?
Okay, so pH is normal.
Ooh.
Normal.
Okay.
PaO2 normal. 3 is low, so acidosis.
Okay. So our pH is normal. Now we're going to go into kind of what we were talking about with Brett. So our pH is normal, within the normal range of what we consider to be acceptable for human body function. However, in chemistry terms, right? If we use that 7.4 as true neutral, what is that trending towards? It's trending towards base. Okay, it's trending towards maybe maybe that there could have been an alkalemia present. All right, so that's the first thing that we got to look at. Remember, it is definitively acidemia, normal, or alkalemia, but I said when we're diagnosing it, okay? But then when we start to look and see that we have other things that are a little out of whack, that's when we can start like considering like, okay, my pH is okay, but there's other things here that aren't where they're supposed to be. So let's kind of see what we've got going on. So is there anything else up there that's not where it's supposed to be? Any of those numbers, either your PaCO2 or your bicarbonate?
I mean, the PaCO2 is like.
Just remember, it's either normal, high, or low. So yeah, so our PaCO2, that's low. Okay, that is outside of our normal range. All right, and if that number is outside of our normal range on our PaCO2, if it's outside of our normal range, low, what does that mean? With PaCO2, we have either normal, high, or low. Okay, so like we either have exactly the amount of CO2 that we want, or we have too much CO2, or we don't have enough CO2. So if we have too much CO2, what is it? Okay, so if we don't have enough, okay, so even though, like, and I understand what you're saying, that it's like, it's just like, it doesn't matter, it's crossed the finish line, right?
Yeah.
So it is across that line, so that is what?
Respiratory alkalosis.
Okay, that is,
And that's where it's like.
we're getting there. I said, like, and I'm actually really glad this one landed on you. And then so we have two things, right? We have something that is alkalotic, okay, something that is base, all right? What about our HCO3?
That's acidosis.
That's acidotic, right? It's not acidosis, okay? Acidosis is we're referring to what, like the cause of the derangement.
Acidotic.
Okay, very good. Cool. So what do we have here then? So because you mentioned a word earlier.
Okay, can I guess?
Yep.
Metabolic acidosis with respiratory compensation?
Uh,
Or is it the other way around?
Well, again, if what is our pH? Like I said, if 7.4 is totally neutral, where is our pH trending?
It's trending alkalotic. Sorry, yes, alkalotic.
Alkalotic, because it's getting too high,
Okay.
right? Okay. And then which one of these two did we decide was alkalotic? The PaCO2. So then that would make it what? Respiratory alkalosis.
And metabolic.
So then I said, I'm glad that we landed on you for this. So this, when it comes to compensation, you can either be partially compensated or fully compensated.
Okay.
Okay? What determines whether or not it is partially compensated versus fully compensated is what is your pH. Is that pH technically normal?
Yes.
Right? So what do you have then here? If that is, if the pH is normal, would you consider that, or just intuitively, would you think that that is fully compensated or partially compensated?
If you said it was like normal.
Your pH is within the normal range.
Yeah.
Okay?
But
So,
are you saying if it's trended up or if it's just normal? If it's normal,
okay, so would that be partial or full compensation?
partial, because it's not, if it's full compensation, then it would be out of range, right?
Nope. Your full compensation, so the pH goes out of range. Okay, the pH goes out of range, right?
Yeah.
It's either above 7.45 or below 7.35.
Okay.
Your body realizes that something is happening. Okay? So one system, either your respiratory system or your metabolic system, is out of whack.
Yeah.
So what it does is your body then says, I need to compensate for this.
Yeah.
I need to balance this out, because remember, if my temperature is outside of is too far away from 37 degrees Celsius, and if my pH is too far away from 7.4, all of my metabolic processes that I rely on to keep me alive are not functioning efficiently. They're not functioning at peak efficiency. So your body's like, something's wrong, I got to fix it. So if it determines that the lungs aren't doing their job, okay, the kidneys are going to kick in and they're going to try to help. If the kidneys aren't doing their jobs, the lungs are going to kick in and they're going to try to help. Okay, they're going to try and do their job. All right?
CO3, the bicarb was 22 in that whole range, then obviously the pH would be possibly outside the normal range.
Very good. Yeah, so if the HCO3 was normal, if the HCO3 wasn't doing what it's supposed to be doing, we know that that would eventually cause an alkalemia. Okay? So what determines whether or not it is fully compensated versus partially compensated is if your pH is within the normal range, your body's compensatory mechanism is functioning appropriately. Okay?
So if it gets out of range, then it's.
If it gets out of range, it's going to turn on one of those compensatory mechanisms. If the compensatory mechanism does what it's supposed to and it works the way that you want it to work, it is going to bring that pH back into the normal range.
Gotcha.
Okay? Yeah, so because it is being, like the reason that it's fully compensated is because it's actually accomplished its goal,
Yes. Okay.
right? It's accomplished its goal. Okay? Did you guys have a question? Okay. Yeah, so if you have something that's out of whack, and I mean, again, the reason that the clinical utility here, the thing that we need to figure out is there is something that is causing that, and we need to figure out what it is.
Okay.
That's why it's important for us to know that. We can't just look at the pH and be like, oh, the body's compensating just fine, whatever. We got to figure out what it's compensating for and help fix it. Okay? Because eventually, you're going to run out of ability to compensate. Okay? See, like it's doing its job right now, but there is still something that is causing this. There is still something that's making your patient, that's depressing your patient's respirations.
Okay.
Right?
Yes. Can I more time?
Yeah, absolutely.
All right. So normal range, but it's trending alkalotic.
Mhm.
All right. PaCO2 is slightly alkalotic.
Remember,
PaO2.
delete that word.
Okay. It's not slightly. It is alkalotic.
It's alkalotic.
HCO3 is 21, which is acidotic.
Yep.
So my question is it the PaCO2 that, okay, so now we have metabolic acidosis, or was it, no, respiratory alkalosis?
Respiratory alkalosis.
With complete metabolic compensation.
You would just say it's fully compensated. Like how you would phrase that, like just to streamline it.
Okay.
I have a fully compensated respiratory alkalosis. Okay. Yeah. Yeah.
Partial. Now, I guess what I'm trying to figure out, it's because the pH is trending alkalotically.
So think about it again. That's why
Basically, what I'm trying to figure out, what causes it, respiratory or metabolic?
respiratory is causing it.
Okay.
That's why I was very strategic with why I put this slide like this. Okay. Mostly for you to understand that within a human body, your true perfect neutral is 7.4.
Okay.
Okay. So going back to this guy here. Wait, which one was it? Yeah. So how you would come to this conclusion if I were interpreting this ABG, because like you said, you never look at one part of it and then you just move on. Okay. So I would look at this and I would say, oh, pH, cool. My pH is fine. But then I would look at like, oh, my CO2 is not right. And then I'm like, oh, but my bicarb's not right either. Okay? Do either one of these not right have any correlation with my pH? And knowing that 7.4 is true neutral, I found that we said this is wrong because this is out of range making an acid. We said this is wrong because it's out of range making alkalemia, right? So then I'm going to look at my pH and be like, okay, where was my pH? Like that's why it's relevant, because it's like if my pH, like I said, if this didn't happen, like Russ said, if this was normal, it's very likely that pH would be higher than 7.45.
Yeah.
And the body doesn't overcompensate, right? Nor will it.
We'll get to that later. Like I said, I was not kidding when I said this gets infinitely more complicated. Okay. So yeah. So just remember, go down the line and look at everything like in a vacuum first. All right, and then like once you've determined what your puzzle pieces are, then assemble your puzzle. Okay. So I'm looking at it. My pH, I'm not worried about that pH. Okay. Like when I'm first reading, I'm like, cool, pH is 7.42. Not worried about that. But then I look at my PaCO2. Oh, my PaCO2 is low. That's not like getting your. I think it was you asked like, is the EtCO2 like a good analog? If I put an EtCO2 probe on somebody and I see 34, I don't immediately like think like, oh man, like something. There's a number of factors. Like maybe the probe isn't picking up very well. Maybe like there's things that. But if I'm looking at an ABG, if I've pulled an arterial sample, like that's not the case. Okay, I've pulled an arterial sample and I'm just like I've run it through the labs and this is what it spit out. So like I know that I don't have enough PaCO2.
Yeah.
Okay, so something is happening to cause me to not have enough PaCO2, all right? And then I'm looking at it too, so I also then know something is causing me to not have enough bicarbonate, all right? And I know that the PaCO2, if it's low, that's on the base side, and the HCO3, if that's low, it's on the acid side, okay? So what that would tell you then, okay, forget about the pH for a second. Just looking at these two, you do know, just by looking at it, like, okay, I either have something that's causing an acidemia or I have something that's causing an alkalemia.
Right.
I need to know which one it is. Okay, I need to know, is my metabolic system screwed up and it's my bicarbonate that I need to be focused on, or is it my PaCO2, or is it my respiratory system that's screwed up and I need to focus on my PaCO2? Okay, you found those two things. Now, Those two things cannot happen at the same time. You can't have a metabolic acidosis and a respiratory alkalosis. Well, I shouldn't say that, but in the ground level terms, you're not going to have those two things occurring at the same time. They're opposites of one another, right? So you get to determine how you make the determination of which one is the problem here. What do I need to focus on? What do I need to fix? That's when you look at your pH. And like, okay, is my pH closer to the acid or is it closer to the base?
So if it was lower trending acidotically, then
Don't think about it if, just focus on right here and just interpret this one right here, okay? Well, once we get beyond that, then we can do the if, right? So we know this is a problem. We know this is a problem. We know this is acid. We know that is base, okay? So I'm going to look at that and like, which does that more closely resemble? Does that more closely resemble a base or does it more closely resemble an acid? It's higher than 7.42 or 7.4, so it more closely resembles a base. So then I know that this is my problem, this is my compensatory mechanism, and it's accomplished its goal. Now you can say, like, what was your hypothetical?
I was saying if in this situation the pH was like 7.36, that's trending acidotically, so the problem would be the bicarb, not the respiratory. See what
So then how would you say that? How would you say, like, if you were to say, this is my interpretation?
Metabolic acidosis with a full respiratory compensation.
Okay. That's correct. That's the correct diagnosis. But just to streamline it, you would say, I have a fully compensated metabolic
I'm still figuring
right?
it out.
Yeah, I have. You would just say, I have a fully compensated metabolic acidosis.
Okay.
Okay. Very good.
Respiratory alkalosis.
No, she was giving me a hypothetical.
Oh, okay, I'm like.
Yeah.
One thing and he said.
No. She was giving me a hypothetical just to so she could wrap her head around it. No. Yeah, she was. So like we said, I'm glad you pointed that out. If you look at, can we refocus? If you look at your pH, it's normal, and then we have problems down here. Okay, so we have a base problem and an acid problem. So what she was saying was, if that number were hypothetically 7.36, okay, then because that 7.36 is much closer to an acid, then I would say I have a fully compensated metabolic acidosis. Does that make more sense? Is everybody following me so far? I mean, you will be able to speak later, but so it's not exactly a speak now or forever hold your peace thing. But like we're here now, so I said if anything that I'm explaining isn't making any sense, just sort of let me know, okay? The takeaway here is that these two, your respiratory system and your metabolic system are constantly, hopefully, if everything is if all conditions are normal, they're working in concert with one another to keep everything nice and to maintain homeostasis. Okay, if one of them isn't doing their job, the other one has to kick into overdrive in order to try and get things back to normal. Okay. All right, Gooch, what do you got, buddy?
Your pH is acidotic.
All right.
CO2 is basic. Your
Okay.
bicarb is acidotic, so it's metabolic acidosis and it's partially compensated.
Okay. Metabolic acidosis. And we say that it's partially compensated because the other system is actually trying. The other system's actually trying to do something, right? If our PaCO2 was 40, they're like, okay, well the lungs just have given up. They're tapping out. They decided they don't want to participate anymore. That they're not going to do what they feel like they need to do in order to help fix our problem here. Okay. Cool. Lay it on me. What do you got?
So your pH is neutral, but it's trending alkalotic.
Okay. So when you look at it, just say my pH is neutral for right now. pH is neutral?
Your CO2 is high, so that's acidotic.
Acidotic, very good.
And then your bicarb is high, which is alkalotic.
Okay.
So you're in metabolic alkalosis, but it's fully compensated.
A fully compensated metabolic alkalosis, very good. Fully compensated because we have a problem with both our PaCO2 and our bicarb, okay? And then we have to look at our pH to see how is this problem manifesting, okay? Because they said it's one of them has to be the culprit. Very good. John, what you got, buddy? And I swear I will eventually learn everybody's name. Okay? Okay? Okay, so what do we got then? So how did you make the determination that it's fully compensated? Okay. what criteria need to be met in order for it to be fully compensated? What is the goal of compensation? For the pH to be normal. So if it's fully compensated, the pH would be normal because it would have accomplished its goal, right? Okay, so our goal has not been accomplished. You correctly identified that we have that what matches our acidemia is our bicarb. Okay, so you've correctly identified that we have a metabolic acidosis. So is it partially compensated? Are your lungs, is that PaCO2 number, is that within normal range or outside of normal range? Within normal range, so is it even attempting to compensate? Nope. So this is an uncompensated metabolic acidosis. Uncompensated. The lungs aren't even, for whatever reason, your respiratory drive, the brainstem is just like, nope, lungs, you can just keep doing what you're doing. 16 times a minute, normal tidal volume, that's fine. You know, but we know it's not fine, you know, right? So because we have that acidosis, what would we want that PaCO2 to be? What would you hope that it is? Would you hope that it's high or would you hope that it's low? Why would you hope that it's higher? So if our bicarb is low, why is our bicarb low? What's the opposite of base? So on that, so we have, say that again? Okay, so base and acid, all right. So if we have a bunch of strong acid that's eating up our bicarb, making our bicarb low, right, yeah, because if that number was higher, that would mean that our body would be retaining more, and it would, then we would have a mixed acidosis, and it's all kinds of bad at that point. Again, we'll get into like mixed acidosis a little bit later, but yeah, so very good. Our PaCO2 is what? Okay, so our PaCO2, what's our normal range for PaCO2? Okay, so what's our normal range? Is okay, and if it's low, that means that we, right? Because we're blowing off more, like we're losing more acid. Very good. And then what about our bicarb? Yeah, bicarb's normal. It's within that 22 to 24, right? Okay, so what does that tell you? What do we have here then? Okay, we have respiratory alkalosis, uncompensated respiratory alkalosis, because our bicarb, our kidneys aren't even trying, not even trying. Yeah. COPD, renal failure patient, or maybe this might be, this might be somebody, you're just breathing way too hard, way too deep. Is everybody with me on this one? Do we understand here? We have an uncompensated respiratory alkalosis. That's my fault. Like I said, going on maybe 2 hours. I was supposed to mention the compensated versus uncompensated a little bit earlier, but we're getting there.
Right,
Yep.
So this one is, for me personally, is easy to see why it's respiratory because your bicarb is good, but your CO2 is not good. But when they're both out of range, that's when I'm like, I have no idea if it's respiratory or if it's.
That's why it's really, really, really important. That's why I keep harping on hard lines. Hard lines. There's like none of this slightly stuff. Okay, it's hard lines. You're either crossing a line or not. So like how it's.
So put bicarb at 19, both
Okay.
out of range.
Both out of range. Yep.
So then is it respiratory or metabolic? Then I don't know how to tell which one it is.
Okay. So remember, it's the matching game. Like do your tic-tac-toe, right? So you're gonna, just like I said previously, we have to identify our puzzle pieces before we try to assemble them, right? So we're gonna look at everything individually. Okay. So go ahead and which slide is this? 7. Yeah. So draw your tic-tac-toe. So we have acid, neutral, base. So just look at your pH.
pH basic.
Okay, cool. Now move on to your PaCO2. What is your PaCO2?
Low on acid, so basic.
Yep. And then look at your HCO3.
HCO3. Well, that's what I'm saying. Like this, I get, but say that number's out.
Okay.
Pick a number outside.
All right, so yeah, pick a number. So yeah, like if it's 19, where would it go in your tic-tac-toe?
So 19, you don't have enough bicarb, so you're more acidic. So that's
Okay.
over here.
Okay.
Bicarb,
And which one has produced a straight line?
basic.
Okay, so we know that HCO3 is
get the
metabolic, and we know that PaCO2 is lungs, right? Is respiratory. Okay. PaCO2 is always respiratory.
Now-
HCO3 is always metabolic.
So in that scenario, with that being, the bicarb being 19,
Then you would have partial compensation because at least your body is trying. At least it's trying. All right? It's trying to do something. It's not succeeding, but at least it's trying. The clinical utility in knowing whether or not it is like partial, fully, or uncompensated, it can be a really good indicator of just how sick your patient is. If the compensatory mechanisms have stopped working, you know that you are like probably pretty far behind the 8 ball. They're probably pretty advanced in whatever disease process it is that's producing this state has advanced to the point where now your body systems aren't doing what they're saying, right? It's think about it in the same way, you guys know this intuitively, where it's like, what's worse, a sepsis with a fever or cold sepsis? Cold sepsis is way worse because your body is it's stopping doing what it naturally needs to do, okay? So that's how you would think about it. So like, what is the clinical utility of this? How do I apply this? If I have full compensation, awesome. Like, I can figure out what's causing my derangement and I can fix it. My patient's probably going to be just fine. If I have partial compensation, like, okay, like not great. Like our pH is still out of whack, but the body is still trying. We still have something here versus, the body isn't even trying to compensate anymore. Like this patient's really sick. Yep. Yeah. All right, this one right here. So we are on our pH of. So what do we got, Jen?
So this is
Just tell me what the pH is.
acid,
Okay. Tell me what pH CO2 is.
basic,
Okay. Tell me what my bicarb is.
acid,
Okay. So you said acid twice, right? What did you say acid twice on? So we have an acidosis. Is it being caused by your lungs not working properly, or is it caused by your kidneys not functioning properly?
I would say it is, I'm looking at my PaCO2 to tell me,
Well, you're looking at both. Okay.
but to tell me whether it's respiratory or.
Correct. You're looking at your PaCO2 to tell you whether or not your lungs.
PaCO2 is not within normal limits, that this is
Okay.
acidosis.
So we said acidosis. All right. So we correctly identified that we have an acidemia. Very good. Okay. That is lower than 7.35. We have an acidemia. There's too much acid in the system. All right. So if there's too much acid in the system, is the PaCO2 indicative of too much acid? What's our normal range for PaCO2? 35 to 45. If I breathe faster and deeper, what happens to that PaCO2? It goes down. Why does it go down? What am I breathing off? Breathing off CO2, right? Cool. If I stop breathing, for whatever reason I retain it, what happens to that number then? Okay. Do you remember what we said that we had that CO2 is, like when we go back to that carbonic acid buffer system, right? What is being bandied about there?
What is being what?
What is being traded back and forth?
Bicarb.
Hydrogen ions. Hydrogen ions. Hydrogen ions, hydrogen equals acid, okay? Hydrogen ions, like I said, like when it goes through that, whatever, CO2, think that your CO2 always has hydrogen in it. Always, okay? So that number's too low. So that means that hydrogen is being taken away, right? Hydrogen is being subtracted from the system, which would then produce what? If you take away acid from the system, what does that produce? Does that make it acidotic or does it make it alkalotic?
If you take acid away,
If you're removing acid, is it, yeah,
makes it more basic.
makes it more basic, right? Okay, since we decided our pH is acidotic, if our CO2 is then basic, is that causing our acidosis? Because an acidosis is too much acid in the system, right? Too much acid. And we just said that our PaCO2, acid's being taken away, right? Okay, so if acid's being taken away and we have too much acid, we know that's not the culprit. Because the lungs, the CO2, the PaCO2, they're trying to take the acid away, but we still have too much acid. So then there's only one other thing that it could be.
Oh, and the bicarb is so low because it's throwing.
Because there's a bunch of acid in the system eating up that bicarb, right?
Okay, yeah.
All right, so then what?
It's a metabolic.
It is a metabolic acidosis. Okay, what about our compensation? Like, are our lungs trying?
They are.
Okay, so what would you call that? No compensation, uncompensated, partially compensated, or fully compensated?
Well, for that, I look at and say it's uncompensated
Okay,
because it's too low.
the pH is still too low, but are your lungs trying?
Yeah.
Okay, so would that be uncompensated or partial?
Okay, partial.
Okay, so it would be a partially compensated metabolic acidosis, right? Okay, so no, we're all learning. So we have an acid, okay? We know that our PaCO2 being low means that our lungs are trying to take acid away, okay? So I have my body, my container here. There's too much acid in it. The lungs are trying to expel it, but they're just not quite there yet, okay? So we know the lungs aren't the culprit. The lungs are trying to fix it. Like, so they're not the one causing the problem. They're the ones trying to fix it. Our kidneys, on the other hand, like there's not enough bicarb going on, so we have, strong acid. When we get into causes, I think maybe this might make a little bit more sense, but for right now, Yeah, we have an acidosis, and because our pH is acidosis, and represents acid, our bicarb represents acid, those two things match. Bicarb is always metabolic, so that means we have a metabolic acidosis. And then we just look to see at the lungs, are you at least trying? You're trying? Cool, so that means partial compensation. If you're not trying, then you're uncompensated. No time for you.
So the PaCO2, if this was a respiratory, that would be
Much higher.
that's where I'm getting confused.
Be much higher. Well, because remember, so if you think about it like you're breathing in and out acid, okay? Sort of think about, or not breathing in and out. You're either breathing it out or retaining it. So we have like a certain amount in our body, right? Because there has to be, right? Because it needs to be balanced. The scales need to be, in harmony with one another. So your lungs or your brainstem really is telling your lungs to either hold on to some, breathe slower, don't breathe as deep, or it's telling you to get rid of it because, breathe faster, breathe deeper, okay? So based on that, it's like if you have too much, your brainstem's going to tell your lungs, breathe faster, breathe deeper, we need to get some of this out of there, okay? We need to get some out. And then conversely, if there's not enough, like, hey, we're running a little low, hold on to some of this because, because we need it. We need it to balance this out, right? Cool. Lay it on me. What do we got? pH. Okay, cool. pH is normal. Very good. PaCO2.
Is acidotic.
PaCO2 is acidotic. Awesome. Bicarbonate.
Basic.
Is basic, right? Alkalotic. Okay, cool. So we've discovered that our PaCO2 and our bicarb are out of whack. Okay? So we have acid and we have base. Okay? So you said that our pH was normal. Which one is it closer to? Is that
Alkalosis.
okay? Cool. So then, how would you? What would you tell me if you were interpreting the ABG here? How would you phrase that? What do we have here?
You would have to alkalosis.
Okay. Is the alkalosis metabolic or respiratory in nature? Okay. So with the respiratory, does that represent a lot of acid, or does that represent or not a lot of acid?
A lot of acid.
Okay. So if if we were going to say that we had an alkalosis of some sort, right, because our pH is trending a little bit higher, right? It is higher than that 7.4, okay? If we have an alkalosis isn't caused by too much acid, right? It's caused by not enough acid, right? Okay, so thinking about keeping that in mind, is that alkalosis, is that metabolic in nature or is that respiratory in nature? Metabolic, very good, okay? How would you describe that? So that would be a metabolic alkalosis. How would you describe the compensation?
It's trying.
Okay, so what is the criteria for uncompensated, partially compensated, fully compensated? Well, let's think about just fully compensated. What is the criteria for being fully compensated?
A normal CO2.
Normal CO2 or normal, it's normal something, but it's not CO2. What are we worried about? What's king? Like, what is going to affect our bodily processes? What is going to affect the chemical processes that happen in your body? Of these options, what is going to have an effect on that? Your pH, very good. So our criteria for if it's how well our compensation is working, because that's really what we're talking about if we use words like uncompensated, partially compensated, fully compensated rather, what we're doing is we're deciding how well is our compensation working, okay? Fully compensated, because it's accomplished its goal, okay? Your body realized, hey, something in my metabolic process here is out of whack. It is causing me to be alkalotic. Lungs, I need you to do me a favor, slow down your rate, don't breathe quite as deep, hold on to some of that acid. Lungs say, no problem, I got you, fam. And now, they actually did the heavy lifting, okay? It actually accomplished what it was trying to do. So it's fully compensated, but we still have a metabolic alkalosis. There is still a problem that is causing that. Something is happening in this patient's body. Either there's some sort of, there's either too much of something or not enough of something. How about that? That is, or a process is out of whack, that we need to figure out what it is, okay? But at least for now, okay, our patient is fully compensated. That means that likely what's happened is that we're kind of early on in whatever this disease process is, and our body's still working pretty well. Our body's still working good, okay? Make sense? Okay, so we look at all of our pieces individual, all of our constituent pieces, and we decide what they are on their own, and then we put the puzzle pieces together to figure out what we have going on, okay? Or to point us in the right direction. You know, we're assembling our compass, so to speak, to, you know, what direction do we need to look in for how do I need to, what treatments do I need to render? How, you know, what do I need to do to fix this patient, okay? All right, Adam, what do we got? ACO2 and bicarb. Cool, so what do we have? Perfect. You definitely took advantage of that being last. Yeah. It pays to, you know, what spot in line you have. Very good. So our pH, we see that our pH is low. It is outside of normal range. It is in acidemia territory. Our PaCO2 is much too high. It is outside of that, you know, 35 to 45. And our bicarbonate is just not really doing anything. This would be like an example of somebody like this would be like the person who just overdosed on fentanyl, right, or heroin or something, and their, you know, respirations are depressed, but they're not in really all that bad a shape just yet. You know, we can get in there, we can save them, because, you know, like that PaCO2, while high, is not like the highest I've ever seen, and that pH, while acidotic, certainly not the worst I've ever seen. We can fix this guy, you know, pretty quickly. Does anybody else have any questions about the interpretation, about the steps of the interpretation? Remember, we're gonna look at our puzzle pieces, plug them into our tic-tac-toe game, decide what color they are, you know, whichever method you want to use, individually, and then once we've decided what they are individually, we see how they interact with one another, okay?
Question on this last one.
Sure, well, lay it on me. Just give me your explanation, yeah.
The bicarb is 26, so it is uncompensated respiratory acidosis, but could you like take into any consideration that it is trending higher? Do you know like pH like?
Oh,
you see what I mean?
yeah, I mean, it could be getting to the point where it's like, okay, I got to wake up a little bit. I got to, you know, yeah, because you know, sort of, again, just like with the 12 lead analogy, this is just a snapshot. You know, like we've drawn the sample, we have you know, run the sample through the machine, and it's produced a number. It might be, you know, slightly different. Like if we shot another one half an hour later, we may very well find that yes, that our bicarbonate number has increased as our body begins to, or the patient's body begins to compensate. So yeah.
If you have metabolic and respiratory acidosis or alkalosis, can you determine compensation?
Yes, you can. There are, well, no, there. So we're gonna talk about a couple of equations that we're going to use here in a little bit. Again, like this is to sort of determine, guide us into. I'm trying to edit myself on the fly because, like I said, this gets very complicated, and I have another entire presentation on advanced ABG interpretation, where we're going to start putting a lot of other things, you know, in here. But for right now, what we need to really, we just need to focus on getting good at this, okay? Because it's, while that's awesome, that's great that you know that some of us are thinking about it like in like more advanced terms and like, well, what does this mean? What does this mean? I cannot overstate the importance of, we just need to learn how to interpret this first, okay? And like we just need to be able to do this, and then once we've got that down pat in, you know, 6 or 7 weeks, whenever it is, and you guys have been on ABG Ninja and you've interpreted 1,500 of them, and you just got it down to where you can just, you know, whatever, then we can start talking about the more complicated things. Yep.
I thought I had this all right in my head, basically, until right there at the very, just trying to determine between respiratory and metabolic.
Okay.
Because I was thinking that the PaCO2 is going to determine whether the lungs are involved or not. So, and it does, but also the bicarb, I don't know, like the opposite of what I thought was what happened. So I'm just like, where did I?
Well, no, I mean, that happens because there are a lot of,
What are the top 2 questions you ask yourself when you're
there are a lot of, the top 2 questions that I would ask myself if interpreting an ABG would be, where, first of all, is anything out of range?
Yeah.
Okay, that would be the first thing. But beyond that, it would be, Once I determine that things are out of range, once I've gotten past that step, would be my first question was like, what matches, or what is my closest match, right? That's why we talk about it in breaking it down in its sort of constituent pieces, or because it can only be acidotic or alkalotic, right? It can only be those two things.
It's the metabolic versus
Sure.
respiratory thing where it's getting me.
Really, hyper focus on CO2.
Okay.
Okay, hyper focus on CO2 because you know that CO2 is processed in the lungs. All right, you've known that since EMT school. All right, so just hyper focus on that. Anytime you see a PaCO2, it is in reference to the lungs. Okay, and then the HCO3, then there is no CO2 in there. It's CO3. There's something else. There's another oxygen molecule here hanging out. That is always metabolic. Okay, so if you think you only have two choices, it's either respiratory or metabolic, and CO2 is always respiratory. So that by process of elimination, that just leaves the only thing that bicarb can be is metabolic.
So, okay, so there will be scenario, like the bicarb, there shouldn't be, well, if the bicarb then is out of the 22 to 26 range, then that means it's metabolic. Because otherwise, if it was something, if it was not.
So just think about it like this.
that's metabolic.
It just means that it's out of range. Okay? That's what I mean by like break it apart. Like we have this innate.
Bicarb's out of range, that means metabolic.
Just we're going to break it down. Look at everything by itself and just decide whether or not it's outside of range. Okay? Like don't look at it and try to determine immediately like how everything is. Just look at pH. Is my pH within normal range? If it's outside of normal range, which direction is it outside of normal range? Same thing with your PaCO2, same thing with your bicarbonate. Just determine those factors first, okay? And then you can start determining if you have a problem, and if you do have a problem, what is your problem, okay? So like I said, we're always very tempted to try to want to gather all the information at once, you know, and like for some reason we're all, you know, and this is not at all, you know, exclusive to Jen Martin. This is everybody. Where like we seem to be in a big hurry sometimes, you know, and we don't want to, you know, be disciplined and okay, I'm going to do everything step by step every single time, right? And it's really important to do that.
If you feel like there's a piece missing in this, you're right, there is. What we're not giving you is what's happening to the patient, right? So that's purposefully. Nate's going through the mechanics of this so you get the basics down. If you knew this was a patient who has vomiting and diarrhea the past 3 days, that leads some evidence to what might be going on and help you do interpretation.
Right.
So ladies, we go through the course, we'll give you ABG values, but we'll also give you a patient. Lab values that you'll learn, everything, you get a whole picture. So now that will aid you in interpreting what's really going on. But today, we're just trying to get you to do the tic-tac-toe method and understand what the numbers mean. So there's a piece coming that'll help out.
So I think maybe I thought about the question that you were asking me. If you wanted to take like a stepwise approach, step one, look at everything individually, determine if there is a problem. Okay? Step two, if your pH is the problem, which value matches that problem? Okay? So you've determined that everything is it's either A or B. That's it. Everything is going to or normal. But in terms of it being a problem, it's going to be A or B, right? So we've determined like what we've applied that to all of these things, and then next thing is like the first thing is because pH is king. Is my pH the problem? All right, or is my pH out of whack? If it is, find what matches.
I think what you just
Okay.
said got me. What other thing out of whack matches the issue with the pH?
Yep.
That was it.
Yeah. So either way, it's a matching game. Like I said, just like match colors, tic-tac-toe. It's a matching game, right?
Yeah.
Right. And then conversely, like how you get to like the fully compensated part would be, okay, cool. I've determined that I have like that my PaCO2 and my HCO3 are out of whack, and then do you play that matching game again? And it's like, what does my pH more closely match? Does it more closely match an acid, or does it more closely match alkalemia, right, or base? Okay, make sense?
Got it. Yes.
All right.
Thank you. That
Cool.
connected.
Awesome. Cool. So we talked about compensation. All right. This is going to get into a little bit more complicated territory. You don't need to memorize these equations right now. I just want you to be aware of them, okay? That we're going to be able to figure out if our body is compensating properly. There's a couple of formulas that we can use for that. So there's a grouping of equations for metabolic derangement. And when I say derangement, that being that the metabolic portion is what your problem is. And there's a set of equations for respiratory derangement. For metabolic derangement, we have, the first one is if you have a metabolic acidosis, we have this Winter's formula, all right? What we're trying to figure out here is, are my lungs behaving appropriately? Are they doing what I want them to do, all right? It's very easy. We take this equation, 1.5 times whatever that number that your bicarb is, okay? So if your bicarb is 26, it would be 1.5 times 26 plus 8, okay? Within a margin of error of plus or minus 2, all right? You don't, like I said, don't worry about trying to memorize this equation right now. I just want you to know that there is a way that we can figure out. This is sort of going to be our next step of like, okay, I've interpreted my ABG. I've determined that I have a metabolic derangement. Now I need to see if are my lungs helping at all? Are they doing what they're supposed to be doing? Or are maybe they actively hurting the situation? Okay, that's how we're gonna, like I said, we're gonna figure it out by this. A shortcut, very easy. The two numbers to the right of the decimal point should match whatever the PaCO2 is. Meaning, for this one, if this were a metabolic acidosis, I would want my PaCO2 to be 34, okay? Because what we're looking for here is these are the two numbers that are to the right of the decimal place. If it's a metabolic acidosis, this number should be the same as the two numbers that are to the right of the decimal point.
That's if the body's compensating, that's what it should look like.
Correct. That's how you determine if the body's compensating appropriately, okay? If that number doesn't match, like, okay, we now have something else going on. Now we're a little bit more worried because now the plot has thickened and something else is going on. For some reason, they didn't give this one a name. I guess the doctor or physiologist, whatever that came up with this one, was not a very vain person, so they didn't put their name on it. But this would be for if you have a metabolic alkalosis. This is the same thing. And remember, what we're trying to determine here, the number that we want to get is the PaCO2, because we want to make sure that the PaCO2, we want to make sure that our lungs are doing what they're supposed to be doing. All right? And remember our order of operations. You guys ever see those videos of like Americans versus Russians doing math, like the hockey players? They ask about, and it's an order of operations questions, and none of the Americans got it right. It's pretty funny. So remember your order of operations, parentheses, exponents. Yep. Yeah. So whenever you do that, so yeah. So this is the equation that we would plug in to see if we have appropriate respiratory compensation. Remember, the clinical utility for this is we're determining whether or not we have multiple problems, because you can have multiple problems, right? Never forget that. That's another reason why, so that the first slide that we had, as far as like don't get hyper-focused on any one diagnostic, always look at everything holistically, because you can easily miss things. Sometimes we have secondary derangements that the hint is pretty subtle, so you said, but we're gonna get to that when we get to the more advanced ABG portion. This is for if you have a respiratory derangement. Okay, so our respiratory system is the cause of our problem here. Our pH is out of whack because our lungs aren't doing what they're supposed to be doing. And we can plug in these equations here, okay, to tell whether or not it is acute or chronic. So the clinical utility there would be, we know that some respiratory patients, some chronic lung patients, their homeostasis is not the same as what yours or mine is, right? Like I don't have COPD. So like my number, like all of my lab values, numbers, and sort of things, like my normal is going to be different than the 65-year-old who's been a 2-pack-a-day smoker for the past 40 years. Like there's going to be a difference here. So that's why we have acute versus chronic. So this is anytime you see the Greek letter delta, so the little triangle, that means change. Like that one's going to come into play a lot when we get into mechanical ventilation. It's changes in pressure, whatever. So that would be the change in the bicarbonate for what we would want our bicarbonate to be, and this is off of that middle line, that is off of that 24. So not the 22 to 26, it's off that middle line, right? Like whatever that quote unquote perfect value is. So if it's an acute respiratory acidosis, we would want the change in the bicarbonate to be plus 1 milliequivalent for every increase of 10 in the PaCO2. Okay, so if my PaCO2 goes from 45 to 55, I would want to see, and it's an acute respiratory acidosis, I would want to see a 1 milliequivalent increase in my bicarb to see that, to know that, like, okay, it's doing what it's supposed to be doing. If that number seems way off, like that's way more than 1, if you change the 1 to a 4 and you do the math again and it seems appropriate, you have just discovered that your patient is in a chronic respiratory acidosis. Okay, like that's just their normal, is they would be in a respiratory acidosis, or what we would consider to be, you know, a respiratory acidosis. Just the change has occurred for them over many, many years to where that is now their new normal. All right, and then the compensation for respiratory alkalosis, kind of same deal, right? So it would be a -2. So at the bottom there, change the 2 MEQ to 5 MEQ. Put a little minus sign there. That's a little editorial glitch on my part. So you would want to see some bicarb taken away in alkalosis, right? So I would want the change in my bicarbonate to be -2 milliequivalents for every decrease in 10 of my PaCO2. Okay.
-2 to -5.
-5 would be, it's not a range, okay? It's, if it's acute, it's -2, the change. So
Change of 2 to between 2 and 5. A change
correct. So you would want the change in your bicarb to be -2 milliequivalents for every decrease of 10 in the PaCO2. That's if it's an acute respiratory alkalosis. If the patient is in a chronic respiratory alkalosis, the effect is going to be more profound because it is their, you know, sort of natural state to be in that respiratory alkalosis.
It'd be less, you saying it'd be less profound, so it's going to change less because it's a normal?
No, if it's acute, the change is going to be less. If it's chronic, the change is going to be more profound. So think about it like this. If our patient, again, our chronic lung patient, okay, so our COPDer, right, like these people sort of live in, like with increased PaCO2s, okay, they just do, like that, you know, they have increased PaCO2s, they walk around with it, you know, it doesn't really bother them because it's been a very slow, gradual change. Human bodies are wonderfully adaptive, you know, given enough time. So if it's chronic, you would want that change to like I said, to be much more profound, okay, because they already are in sort of like a baseline, what we would consider to be acidosis. So if they have a respiratory acidosis, their body has to work even harder to compensate for it, okay, because they're just in that baseline acidosis. So now their kidneys have to do more work, you know, because they've, you know, like I said, been a 2-pack-a-day smoker for 40 years, right? That's all it's saying. Like this slide, the big takeaway from this slide is be kind to your lungs. Be kind to them. You need them. So yeah, and like I said, the clinical utility for those formulas that we just discussed is we have what we're going to be talking about a little bit later on when we get into specifically our renal disorders. Is we like primary and secondary derangements. All right, like you can have a patient who is in an acidosis and both systems are for one reason or another are contributing to the problem. Okay. Like I said, that's going to be a little bit further on. So some of you have had pretty good questions about that. So the bicarbonate replacement formula, like I talked about previously, this isn't something that's really, you know, used very much anymore. We're finding that, you know, from an evidentiary standpoint, that we weren't getting the results that we thought we were going to get. Like I said, it's good sound medical theory that if we have a base deficit, if there's not enough bicarbonate in the system, you know, your kidneys aren't producing enough. It's like, hey, we have some bicarbonate. I have it in this you know, nice little convenient vial. I'm just going to give it to you. Okay. The thought being is that we would be able to correct the pH using that. We found that it is much more worth your time and attention and focus to try and figure out what is causing your problem and fix that as opposed to trying to do this necessarily. However, we're still going to talk about it because the bicarb replacement formula may pop up on a test somewhere, okay? So you would want to take it's 0.2 times the patient's weight in kilograms times whatever your base deficit is, okay? And that's going to spit out, you would put that in there as a positive integer, and that's going to tell you how many milliequivalents of sodium bicarb that you would want to administer to the patient. If you don't have the base deficit, you can figure it out. So you're going to take 24, which again, 24 is that if everything is functioning exactly the way we want it to, that's like the perfect quote unquote number for our bicarbonate. So you're going to take 24, subtract whatever that serum bicarb is, and then you're just going to plug it into your equation. Only you're going to use 0.5 times your weight in kilograms times that number, and that's going to give you how many milliequivalents of bicarbonate that we're going to need to give.
Will we be tested on that formula?
Yeah, you will.
Yeah.
Because there are times,
Yep.
like Nate said, where you're going to have to replace a sodium bicarbonate patient.
Okay.
They're just primarily missing that, so it needs to be replaced, yeah?
So, cool. So now that we're gonna kind of touch on a couple things as far as some causes. Okay, this is for your metabolic system. This is something that we're only going to lightly touch on because typically this lecture takes place after your lab values lecture. So some of the important context is going to be missing here. But this is, like I stated previously, if we find that our patient has a derangement of some sort, our primary goal is going to be to fix whatever is causing that derangement. All right, like that's where we're going to focus the bulk of our energy, is to what put them in this state. Let's correct that. This is a way of figuring out how the patient got into that state. Okay, the anion gap is relevant if you have a metabolic problem. Okay, specifically a metabolic acidosis. So we can, like I said, what you will learn next week with Dr. Tan about like these lab values that we have. We have positively charged ions and we have negatively charged ions. Those are cat ions that are positively charged and anions that are negatively charged. By the law of electroneutrality, those two things have to be balanced. Okay, if they are not balanced, again, like your body will try to will actually sort of be forced to compensate for this. And it can have an effect on your sodium. You have a range of 135 to 145. Your potassium is 3.5 to 5. That's not, sometimes you actually will see this expressed without potassium, just because potassium doesn't really put its thumb on the scale very much because it's such a small value. But technically, it's a sodium and potassium minus our chloride and our bicarb, okay? Whatever is left over, okay, is what we consider to be unmeasured, all right? So this yellow portion here is our sodium, our sodium and our potassium. The blue part, those are the unmeasured cations, okay? The yellow part here is our chloride, the green is our bicarbonate, and the blue is our unmeasured anions. Okay. As far as what that gap is supposed to be, we have more unmeasured anions than we do cations. The number escapes me at the moment. Give me a second. So 112.
Under 12 is good for.
Under 12. Oh, actually, yeah, it's the next one. So next slide. So we have approximately 23 milliequivalents of unmeasured anions and approximately 11 milliequivalents of unmeasured cations. So the perfect value, quote unquote, is 12. So if somebody said 12, you've been doing your reading, good job. So the perfect value would be 12. We really don't start getting too concerned about this until it gets greater than 20, okay? So from 12 to 20 could be considered, quote unquote, normal range, right? 12 being the perfect value, 12 to 20 it's more, we don't really start worrying about it until it gets higher. If it's higher than 20, that would be what we would term a high anion gap metabolic acidosis, okay? it's important, again, the clinical, like talking about all these things, they're just diagnostics. So the clinical utility in this is if we find that we have a high anion gap metabolic acidosis, we have significantly narrowed down the list of causes for our acidosis. So now we can start eliminating things much quicker so that we can focus on what is our actual problem and correct it. Okay? Does anybody have any questions about the anion gap? We have things that basically, just think about this. We have things that we measure. We have positively charged ions that we measure. We have negatively charged ions that we measure routinely, right? The ones that are left over, they should have like a pretty narrow relationship with one another, right? And when they start getting out of whack, that's when we start running into problems, okay?
The anion gap more subjective in hospitals. So I feel like I've seen 17 for an anion gap, and they're like, oh, he's in DKA. I'm like, I thought I'd be over 20.
Well, like Brian said, and like I said, like we discussed previously, I sincerely doubt that somebody made a diagnosis of DKA based on that one value. Like that was probably a determination that was made from the whole picture. Okay. So yeah, that's definitely something that's not something that you would want to get into. For example, another thing another test, like when somebody shoots a lactate, it's not uncommon for you to hear somebody say, "Oh, their lactate's this. That means they're septic." Right? Like, do not do that. Okay? Like, don't make a diagnosis based on just a single data point. Okay? It's got to be much more holistic to that. What they probably meant was, like we said, if 12 is technically our perfect value, 17 would be elevated. Okay? We just don't consider that to be like, a high anion gap metabolic acidosis until we get into greater than 20. So what aren't we measuring? Okay? I had put potassium up there. We are measuring potassium, but like magnesium is not always routinely measured for. Calcium. Everything on this list, everything on this slide can be measured. Okay? We have the ability to do it. It's just some of them are more difficult than others. And these really just aren't necessarily, again, with the exception of potassium and calcium, these aren't necessarily things that we measure for routinely. Okay, so we just got to do a little bit of math. Like I said, so we can take just a basic metabolic panel and make a good determination for what we have going on based on that. Yep. But yeah, so the sort of light blue, guys, green, I don't know what color I use for that. Those are our positively charged ions, our cations, and in the purple we have our anions. So here's a visualization of it. So the system's been thrown out of whack. So we have too many unmeasured anions. We don't know what they are, okay? We just know that an anion has been, or a grouping of anions have been introduced into the body, and now it's causing our metabolic derangement because your body either doesn't know what to do with them or can't do with them, or it's overwhelmed your body's ability to do it. There are a number of things that can be the cause of this. So we're not going to go into too much depth. That's when we get into a little bit more advanced stuff. But we want to sort of lay the groundwork so you have at least an understanding of it before we get there. So the strong ion difference, you'll notice that this equation looks rather similar to the anion gap. The difference between the two is this one takes bicarb out of the equation. So where this came from was there were patients who were going into a metabolic acidosis in ICUs, and they didn't know why. This is sort of way back when. And these were patients that were receiving a whole lot of IV fluid, specifically sodium chloride. So this is what we would consider like a more sort of chloride centric view of it, because we basically were finding out that we were adding so much chloride into the system that even though that's something we measure for, we were adding so much that it was pushing that level of anions in general up so high that it was causing an acidosis. So we'd actually take all of our positively charged ions, so we take our sodium, our potassium, calcium, and magnesium, and we then subtract chloride and lactate. And it says normal range is 40 to 42. The lower it gets, the more likely of a hyperchloremic metabolic acidosis that you have. This is stuff we're going to revisit again a little bit later on, but just know that everything is interrelated, which is, again, goes to your point, or to what you mentioned previously. Never look at anything in a vacuum, right? Everything is always, we have to paint as complete of a picture as we possibly can. More information is never bad, right? Because at least if you gather information and it doesn't necessarily tell you anything, at least you can eliminate that from your differential diagnosis, right? So just know that there is, I guess I was saying again, our overall focus here when looking at an ABG, a VBG, whatever, anything that has to do with your patient's pH, is we are hyper-focused on finding the problem. We have to find the problem as quickly as possible. Like we have to find the problem as quickly as possible and correct it, okay? Because even though, like I stated previously, that patients can compensate pretty well, our human body does pretty well, being outside of our normal ranges, it doesn't do it for very long, okay? So we have to be really aggressive in our detective work, figure out what it is that is causing our problem, and treat it accordingly. Does anybody have any other questions, anything else that you guys would want to discuss? So one last thing I will tell you guys,
Can I just make sure I understand the respiratory versus
Sure.
metabolic? So you got the tic-tac-toe, whichever.
Go ahead and write one out.
So you got it here and you're filling out pH, whichever one matches with pH, if it's PaCO2 respiratory, if it's bicarb, then it's metabolic.
Nailed it.
Okay.
Yep.
Every time, twice on Thursday.
On base. So that is a calculated value, right?
Yes.
Okay.
Yeah.
So if the base excess is high, I think I'm like, what exactly
So just how much bicarb you have in the system.
is
Okay.
it like how much too much, or like if it's then if
Right.
it's plus too
If
high,
it's a positive integer, that's a base excess. You have too much.
too much.
If it's a negative integer, that's a base deficit. You don't have enough.
Okay.
Okay.
Because we weren't really looking at it, but I guess it's just more just to show you, oh, this is what.
Right. Yeah. So it said the clinical utility for it, like how you would use it, why we care about it, again, is for that bicarbonate replacement, right? Is because that is determinative on like how we're gonna perform that intervention. So one last thing, one thing that was really helpful for me, years and years ago. Brian and I were actually in the same class. When I went through critical care, was and you guys are probably the same as me. Like I fidget on my phone constantly. So I turn that into like an asset. I talked to Russ earlier. One thing that I would encourage you guys to do is make flashcards and make them on your phone. That way, instead of doom scrolling, TikTok, you can, put that time to good use. Another thing I want you guys to look up is ABG Ninja. Literally, just go to the website on your phone. It's just ABG Ninja. There's actually a number of quote unquote like ninja tools for it. And all it is it's rapid fire ABGs. Like, I mean, you can sit there and very easily in half an hour interpret 100 ABGs. And it's just repetition over and over and over and over again. It offers explanations for it. So like if you get like say if you interpret one incorrectly, it'll give you a little blurb like, oh, hey, this is maybe what you missed, okay? Incredibly useful. Definitely recommend it. It's the same thing. It's the same website. There's a number, like when we get into invasive hemodynamics, there's a section for that. There's a section for a number of things. It's very useful.
We'll have the web address for it at the end of the class. I'll have a slide that has it on there. So it'll be on your PowerPoint later this afternoon. All right, turn it on. So I'm handing out whole.
Lori tried to do the whole vegan thing for a minute, just because like all the evidence is there. Sure, okay. That lasted for a whole week.
So now we've left introduction. We've shown you 13 vasoactive medications for you to study to take up all your free time. If it hasn't yet, it will. So now we're into respiratory. And this morning we started with ABG, VBG. This afternoon, let's delve right into respiratory. Let's go over a lot of different things like the anatomy. Let's talk about the process of gas exchanging, the mechanics of ventilation. We're going to go through some VQ matching and mismatching and what that looks like and what that means. Ways to assess our patient's oxygenation other than just the SpO2. Then we're going to look at the oxygen hemoglobin association curve. And if you haven't put a fork in your eye yet for this course, you will. Matter of fact, I'm going to hand them out here shortly. And then we're going to go through the types of hypoxias and then with a little bit about respiratory dynamics. And that's going to lead you into Dr. Tan's lecture next week where he's going to go really deep into all the pulmonary conditions you ever can imagine. COPD, asthma, pulmonary hypertension, you name it, he's going to do it. So this is the foundation for that for today, okay? So when we talk about the upper airway, pretty basic. As paramedics, we're very familiar with it. But some things I need you to just keep in mind is that, your nose is connected to 4 sinuses. And it's a very vascular area, so we get a lot of epistaxis when there's trauma there. So that's an airway issue concern, right? We don't do nasal intubations anymore. How many have you done in your career, nasal intubations? None. I've done 2. One was successful, one was not. But the last time I did it, you know what stopped me? City brought in a patient, nasally tubed, and blood was literally pumping out of the nasal tube, ET tube, as they were wheeling him into the ER in a rush. And when I saw that, I'm like, I'm never going to do that again. And I never had to from that point on. So it can be very vascular. So be careful what you jam down there, right? We used to do it all the time. I've done 2 here, yeah. And I'm sure people have you done more than 2? You were pretty aggressive in the day. The breast was. So I'm sure you've done quite a few.
I probably did 3 a year.
Yeah, I believe it. Yeah, we used to do it all the time. And a patient that was breathing, we didn't have paralytics. We barely had sedatives. So nasal intubation was the way to go, but if you do anything like that, just keep in mind it's very vascular. The oral cavity, just remember salivary glands continually secrete. They don't stop. They just continually go. And so that's why when we get in there and we look, that's why we always want you to advance with suction first. And when we get to airway, we're really going to hammer that home. Advance with suction first because I guarantee, I don't care how dry you think that airway is, it's likely to be wet. And we want you to clean it out before you introduce an ET tube. We'll talk more about that in airway. And of course, the tongue is always a common obstruction, given its size, given angioedema, or whatever. When it comes to the pharynx, there's 3 parts to the pharynx, the nasal pharynx, the oral pharynx, and the hypopharynx, and that makes up what's called the pharynx. The thing to remember about that is when our patient is alert and orientated, has muscle tone, the pharynx structures actually provide a level of PEEP to our lungs. And it's designed to do that, right? Can someone tell me why PEEP would be so important for our lungs? Why do we need intrinsic PEEP if we're breathing just fine? Thank you very much. Prevents derecruitment, but how does it do that? What don't we want the alveoli to do? Collapse completely, because that would be hard on the alveoli to collapse open. And so physiologically, our airway structures provide PEEP, 3 to 5, that allows just enough so the airway alveoli don't collapse all the way, but go down enough and then open back up. So that reduces the wear and tear on them, and it provides good function in the alveoli for stretching and relaxing. Well, what happens if our patient is unresponsive, no muscle tone? No PEEP, okay? No to little PEEP. So then what do we have to do? We have to provide that PEEP for them, and how do we go about doing that? Positive pressure ventilation with what?
PEEP valve.
PEEP valve, that's where I'm going. So if you put a BVM on a patient at any time, this is why you should always have a PEEP valve. Because if they're unresponsive, unconscious, they probably lost their own PEEP, so you need to replace that. Good job. Love it. Okay, moving on. Below the pharynx is the larynx, and that's where we have our voice box, and that's consisted of several important structures like the epiglottis, the thyroid cartilage, and the cricoid cartilage, and also the vallecula when we look inside. Thing to keep in mind here, this is where the vagus nerve travels through. The vagus nerve's job is to provide strong sensory innervations which stimulate the parasympathetic nervous system, right, which is the opposite of the sympathetic fight or flight system, right? Stimulates that. So that's why when you get in there and you're screwing around, and your patient goes bradycardic, what have you just done? Stimulated the parasympathetic nervous system through the vagus nerve. So that's going to result in a decreased heart rate and a decreased blood pressure. So what do we do if that happens? Bail, get out, right? Yeah, if I see my patient start going bradycardic and I still haven't got the tube, I've probably been in there long enough. I need to get out. Let's let that system reset, and let's make sure we don't have to provide any further management for any problems we just caused. That's something to keep in mind. Talk about the trachea and the lungs. We know that the lungs split at the carina, right? Where's the carina? That right there, right? The lungs split, but they don't split evenly, do they? If we notice that the left lung splits more acutely than the right lung does, you see that? So that's why we have a high incidence of right mainstem intubations. Because look how easy it would be to put a tube through this way versus put a tube through that way. So it much easier slips into that right mainstem bronchi, causing you, if you go too deep, to have a right stem, mainstem intubation. But this is how it works. We start with the bronchus, it splits,
And each of the bronchioles go smaller and smaller and smaller, 23 times smaller. They decrease in size 23 times, your bronchioles do, before they finally are small enough to reach the alveoli. When you get to the alveoli, you have sacs that are made up of specific little alveoli. I'll show you a picture in a minute. And each lung has 300 million of these tiny little alveoli. A lot. Quite a few, right? What participates in gas exchange are just the alveolar sacs and the alveoli, okay? Sometimes the really smallest of the bronchioles will have 1 or 2 alveoli on it. There'll be some gas exchange there, but not enough to make a difference. Where gas exchange really takes place, Brett, you're fine. You haven't missed much. We just started. Everything good with the kiddos? So far, all right. The right lung has 3 lobes. Why is it, do you think, that the right lobe has 3 and the left has 2?
Heart's in the way.
Heart's in the way. But now that you may or may not have known that the right lung has 3 lobes, how many auscultation points are there on the right lung? 3, right? How many times do we listen to lung sounds and we go top, bottom, top, bottom? Okay, I listen to lung sounds. Did you? No, you didn't, because you skipped right over that right middle lobe. And guess where the most common place for a pneumonia to occur is? In the whole lung field. You better believe it. So we'll talk more about lung and lung displacement and things like that later on today, but just keep that in mind that the right side, you need 3 auscultation points to listen to all 3 lobes. All right, when we talk about the lung pleura, we know we have 2 pleura. We have a visceral that's attached to the lung themselves, and the parietal, which is attached to the chest wall itself. And in between that area is a thin space filled with some serous fluid that allows the 2 membranes or pleuras to rub against each other as you breathe. But what happens when we introduce air into the chest cavity? Does air go underneath the visceral or the parietal pleura? No. What it does is it goes to that space, and that space is called a potential space. And you're going to see that a lot in medicine, potential spaces. Like when we learn ultrasound and we do a fast exam with our ultrasound, we're looking at the Morrison's pouch, right? It's a potential space that can be filled. It's a space that can be filled with something, and this is what this is. The pleural cavity is a potential space for air, blood, or whatever to occur that's going to get in there and cause problems. So make sure you know your pleuras and the pleural cavity is a potential space. Might see that on a quiz or a test at some point, I don't know. Okay, the alveoli, this is what they look like. Not really, but kind of. Each alveoli is in contact with the pulmonary capillary. Each alveoli has at least 1 pulmonary capillary, and that makes sense because that's where the magic happens for gas exchange to occur. There are 2 types of alveoli. The most common is the type 1, and that's where gas exchange takes place. There are other less common types, I think like 5% or less are type 2. Their job is to manufacture surfactant. Who remembers what surfactant does?
Oh, it's the lube in the lungs.
It's the lube in the lungs. And we'll talk more about surfactant when we get to poll, probably next week. Dr. Tan will talk about it more, but basically that's it. That's it. It officially does what? Maintains the surface tension. So in other words, how well the alveoli is opening and closing. Okay, did you know that there are things in your lungs that ingest particles to help clean and defend the lungs? They're called macrophages. They're not white blood cells. They're actually little beings, like aliens from some other planet that live in your lung and that help protect the lungs by eating things that shouldn't be there. Not in your bloodstream, they live in the alveoli. So I thought that was kind of interesting. All right, we got through the anatomy. Let's talk about gas exchange. So this is where the magic happens, and this is where we're going to concentrate today. It's just on this little tiny alveoli. We know that air comes in and air goes out. But where the magic happens is right here. And this is called the alveolar capillary membrane. Okay? So there's a wall to the alveoli, would you know? And there's a wall to the capillary. But they're so thin that O2 is able to pass through. And CO2 is able to pass through. Those are our pulmonary capillaries. That's where the magic happens. But we have to understand, and when we get to hemodynamics, we'll talk about a lot more, that the pulmonary arterial system, in other words, the blood pressure in those pulmonary arteries, are very low. If I would crawl down into my lung and go to a pulmonary capillary, put a bleed P cuff on it, I would get 25/10. And that's enough to do blood flow through the lung. But it's a low pressure system. Low pressure system. When we get to hemodynamics, we'll talk more about that. But the lungs and the pulmonary circuit is a low pressure system. Compared to our systolic blood pressure, 120/80. Factors that can inhibit gas exchange. I would know this list. 1, we can have damage to the alveoli, right? That's obvious. If the alveoli aren't working right, we're not going to have good gas exchange. What about collection of fluid in the alveoli? What does that sound like? What kind of medical condition does that sound like? Like a pneumonia, yeah? What'd you say? CHF, like a pulmonary edema kind of situation? Yeah, anything that'll collect in the alveoli. What about collection of fluid in the interstitial space? Where is that at? What do I mean by interstitial space? Where's that at? Who can tell me where that is? Where am I talking about? Am I talking about this space right here? The potential space between both capillaries? Yeah. See how that's white right there? That's a potential space. That's a space that allows transfers of the CO2 and the O2 molecule, but it's still a space. So what can a potential space do? Be filled up with crap. And so we're going to see that you can have collection of fluid and all kinds of gross crap that fills in there. That's going to cause what? Problems with gas exchange. CO2 can't move through, or O2 can't move through, or both. And then finally, collapse of the alveoli. If my alveoli is collapsed, then how well is gas exchange occurring? Not well at all. And by the way, what would you call that? Alveoli collapsed. Atelectasis. What'd you say? Close to that. Good enough. I like it. If any of those four things occur, we have a problem with oxygenation, and we have some kind of VQ mismatch, which we'll talk about here in a minute. All right, blood goes in, blood goes out. We talked about surfactant. For surfactant, it reduces that surface tension, and it prevents the alveoli from collapsing completely. If it did, it would harm them, and it would cause more energy to open. What we want our body to do is expend as least energy as possible to do what physiologically it needs to do. Where we're going to run into problems is when the body is demanding more energy to fix whatever condition is occurring. As a critical care paramedic, it's your job to understand why the body's requiring more energy. Maybe it's requiring more O2, or maybe it's using up more O2, right? It's demanding more than it should, and you have to understand why that's occurring. Not only how we measure it, but why it's occurring so we can ultimately do what? Know how to fix it. And that's what separates a paramedic from a critical care paramedic, is understanding that pathophysiology and what's going on. So we have to understand that gas exchange occurs through a process called diffusion. Okay? Diffusion is how gases move. Gases move by diffusion. If I said it 3 times in a row, that's probably pretty important. Gases move by diffusion. Okay? Now, you may have heard of this thing called osmosis. Osmosis only refers to water, the movement of water. So don't confuse those two terms. Diffusion is talking about the movement of gases. Osmosis is talking about the movement of water. Okay? But the gas exchange in diffusion is dependent on a certain law. And you may remember this law, Fick's law. Do you remember that from medical school? I think we touched upon it in medical school every now and then. But Fick's law really refers to the law of diffusion. So when we have a gas, or really any substance in a medium, it's going to want to go from what? Low to high, or high to low pressure? From high to low. And that's true. So if I had an O2 tank here, and I turned it on, that O2 is going to come rushing out, right? Why does it want to rush out? Because I turn the valve on? Critical care paramedics tell me why it comes out. Because there's a concentration gradient. Exactly right. So we need to understand that when it comes to oxygenation and ventilation, there are concentration gradients that exist in the lungs, so we need to be very aware of and how that works. And so when we talk about diffusion, that's how it works. Gases want to go from high to low. If I open up that tank, it's a big tank, and I fill this room up, is it going to stop in this room because there's walls? No, it's going to spread and spread and spread to this whole building if it could, because it wants to find the low pressure areas and fill it. And that's what diffusion is. So we see here of a substance, they put it into the glass, it starts diffusing, and eventually that substance, whether it be red dye or what, it's going to be distributed evenly in that medium, as far as it can go. I know. Well, no, it's not moving water, it's moving a particle.
Well, but it looks like water.
It kind of does, yeah. But that's still diffusing because it's moving a particle, not necessarily moving the water around. Lungs, now it's in red, so every time I see something in red on my slides, again, probably pretty important. I'm like, ooh, see me, see me. Lungs are dependent on what? They're dependent on the chemical nature of the membrane. So in other words, how well gases move between the membrane. How permeable gases move, right? We know permeability in sepsis, right? How is permeability affected in sepsis? Well, what happens in sepsis to our blood vessels? And then what happens to permeability? Right, become more permeable, so we lose things, right? And so that's what's going on. We want the lungs to be permeable now. We want them to be. because we want gas exchange to occur, right? So they have to be permeable. Lungs are also dependent on the surface area, right? So if I've got one lung down for pneumonia and one lung that's good, how well am I oxygenating and ventilating? Not as well if I had both. So it's dependent on both my lungs having all the surface area we need, and that's why PEEP is so beneficial, right? What's PEEP doing? It's increasing surface area, ultimately, right? What about the partial pressure of gas across the membrane? We're going to talk a lot about partial pressures later. Thickness of the membrane. Can our lungs, the tissue, the AC membrane themselves become thicker? What's that condition called? Emphysema will cause that. What about pulmonary fibrosis, right? Different conditions that'll cause a thickening of the AC membrane. And if the CO2 molecule comes to the lungs, like, well, wait a minute, that's a wall, and it used to be a fence that I can get through, and now it's a wall, right? I'm having a hard time passing through the wall when I'm used to going through the fence, right? And so it's not going to be able to pass through, and that's going to affect how molecules transfer as well. So the lung is dependent on those four things being good, and if one of those things are broken, then we have a problem. Did you know that if you laid out your lung per alveoli, it would stretch out and cover a whole tennis court? Isn't that amazing? So 300 million alveoli stacked or spaced next to each other would cover a tennis court. In this area, craziness, right? Craziness. And so that's pretty cool. So why are we ever short of breath, right? I mean, my God. But it makes you wonder sometimes. All right, the one thing, well, okay, mostly the one thing I want to get through to you guys today is understanding what the AC membrane is. You must understand the AC membrane. And so what the AC membrane is the alveolar capillary membrane. We call it the AC membrane. The wall to the alveoli is only one cell thick. That means it's only like 200 to 500 micrometers thick, really, really small. The pulmonary capillary is one cell thick too, and it's a little thicker at 750 micrometers. I don't need you to memorize those numbers. That's fine. I'm just trying to give you a reference. Anything greater than 500 micrometers in the lungs slows or inhibits gas exchange. Okay, so it doesn't take much. So if the max size is 500, anything over 500 is going to inhibit, then it's going to be pretty darn easy to cause a problem with oxygenation and ventilation because of the cell thickening. So it's not only the disease processes that can damage the AC membrane, like we talked about, like pneumonia, pulmonary edema, pulmonary fibrosis, but what else can do that? What else can damage our lung alveoli? Barotrauma, high pressures. So when we get to vent class, we're going to talk a lot about lung protective ventilation, right? Because we can. We can really screw our patients up by providing high tidal volumes. And that's going to damage the membrane. And so when you damage the membrane, again, you're reducing gas exchange, so we got to be very careful about that. So, yeah, Elizabeth defined atelectasis for us. It's a partial or complete collapse of the lungs or the entire lung. And this is what's happening here. See this field right here? That's the lung. See this field right here? This line? That's the lung. Anything below that has collapsed. It's no longer participating in gas exchange. It is atelectic for whatever reason. Maybe there is a pleural effusion in there, but something is causing problems to shut down this area of lung, and that area of lung is shut down. Who would define emphysema?
Who would what?
Let's say Jacob. How would you define emphysema?
I know it has something to do with gas trapping inside the lungs.
Okay, good. Gas trapping inside the lungs. But what else happens to the alveoli in emphysema, especially as you get later and later in emphysema?
Doesn't it becomes loose, basically?
Floppy. I like to think of it as floppy. It becomes like very floppy. Why? Because it's overdistended. Why is it overdistended? Because we're trapping gases in there, right? And so that's exactly what it is. It's hyperinflation of the alveoli. Eventually they get to the point where they lose their elasticity, and we're going to find out what the elasticity is later, but basically the lungs are able to spring back to their natural form. And so they become floppy and nasty. And so we're going to talk about it later as well. What about pulmonary fibrosis? How would you define, Kaylee, pulmonary fibrosis? We talked a little bit about it a few minutes ago.
It's like thickened.
Yes, and when you think fibrosis, think thickening. That's hardening and scarring of the alveoli. The sacs lose their compliance, and those are very stiff lungs. Stiff lungs. So if I got a patient with pulmonary fibrosis on the ventilator, what am I concerned about doing? I'm worried about giving too high a pressure, which is going to damage more alveoli. If there's any good ones in there, right, then I'm going to damage them as well. So we're going to be very careful. And there's something called compliance we're going to talk about later that'll help us define it. But this is what lungs look like in emphysema and then fibrosis. So there's a lot, hundreds of conditions and problems that can damage your AC membrane. And we need to know what they are, how to measure for them, and how to fix them, because aren't the treatments different for all three of these? Wouldn't the vent settings be different for all three of these? They would be. There's differences in all three that we need to consider. So you just can't walk into a critical care transfer and go, my patient's intubated, I'm good. You just can't. You can't. You won't be able to manage your patient appropriately, and you may end up hurting them. So we have to be very mindful of what's happening, not just in the lungs, but I want you to get down deep. I want you to go down as deep as you can go, all the way to the very end. And where the very end is that AC membrane. What's happening there? I don't care if air is going in and out of the lungs. That means nothing to me. What's happening at that AC membrane? That's where it all counts. Because that's where perfusion is occurring. Not perfusion, but transfer of gases, oxygenation and ventilation is occurring. So I want you to use your mind's eye. Use your mind's eye and picture yourself in that person's lung. Picture yourself shrunk down, like the little Marvel movie, the Ant-Man. Okay, you're the Ant-Man now. And you're going down into that lung and you're looking around the flashlight and you're trying to find out what's going on in that AC membrane. Okay? And that's how we know how to fix the patient's problem. But we'll get to that. Let's talk about mechanics of ventilation. Adam, how would you define ventilation?
Diaphragm moves, creates a negative pressure.
I love it. Pressure differences. So the diaphragm does what?
Expands.
It goes down. It contracts, right? Diaphragm goes down, it contracts, it creates a negative pressure in the lungs, which helps air be drawn in. So that's ventilation. It's the process of moving air in and out using our respiratory muscles. Diaphragm, intercostals, and accessories. Those are our three, we'll talk about those in a minute, but those are our three respiratory muscles. Process of moving air, right? What about, oh, there they are right there. So well, I already told you, dang it. So we have the diaphragm, which is the main muscle for breathing, obviously. We have the intercostals, which are the muscles that are in between the ribs. Those are next. And finally, we have the accessory muscles that really kick in only in areas and times when we need high metabolic demand, such as exercise, right? How many people think of exercise as increasing metabolic oxygen demand in your body? But it is, right? And so your muscles are screaming out for what? Oxygen, because you're demanding that they work. And so they're saying, I'll do it, but you better be giving me some oxygen to support this work I'm doing. And so what happens? You become, you increase your respiratory effort and you get more oxygen in because you're breathing faster. So it's all planned. It's all planned. All right. What about illnesses? Well, illnesses affect our metabolic demand as well. They'll certainly increase our metabolic demand and cause us to have a high respiratory rate as well. Okay. Let's talk about how we breathe. We breathe not just because we took a breath. That's paramedic, okay? We breathe because of pressure differences. There are pressure differences that occur in our lung fields that cause air to move in and out, okay? So let's talk about negative versus positive pressure ventilation. In positive pressure, well, I should say that inhalation is positive pressure in that your diaphragm contracts and moves down. Your chest wall muscles push out. What this does is, let me ask you, where's the pressure difference? When my diaphragm drops and my muscles go out and my chest wall expands, is it the atmosphere or my lungs have the lower pressure? Good. It's like a vacuum. So that forces air to go in. Now, when I'm ready to breathe out and my lungs are full of air, which is higher pressure, the lungs or the air, atmosphere? The lungs actually have more pressure in that square inch of area, so now air wants to go back out. Now, it's helped with our muscles. Our muscles assist that in delivery and happening, but the gases, and we're going to talk about the gases later, the behavior of gases and why they do what they do, but that's really what's going on. And so that should say negative pressure ventilation. It's negative pressure that's going on. So the air wants to go in and out. At what point, though, during what point during inhalation are the pressures equalized to the lungs and the atmosphere? At what point? Because at some point they actually are equal. But where does that rest? Right in between. Don't you pause? Don't you breathe in, make a slight inspiratory pause, and then breathe out? At that point, generally speaking, the pressures are equalized. There's no air movement. There's a plateau. There's a pause. Okay? What about our exhalation? Okay? What happens now is the diaphragm moves back up. It relaxes. The chest wall comes back in. As a result, it changes pressure gradient, okay? and the ribs assist in this by pushing the lung back in. And now we got a pressure difference where air wants to come back out. And you get the gist. All right. So what exactly is negative pressure ventilation? This is chemically or physiologically how we go about breathing. I want you guys to know this. We start with a physiological need to get rid of CO2. Were you aware of that? We don't start with a physiological need to have O2. We start with a physiological need to get rid of the acid we produced. Okay? And I want you to think about CO2 as acid. It's really acid. It's acid we got to get rid of. It's a byproduct of metabolism. It's got to be there. It's going to be there, but we got to get it out because it's acidic. And so we get it out through the lungs because that's the quickest way of doing them. My heart beats how many times a minute? 60 to 80. So that means I've got all that CO2 that's pumping through that's got to get out. I got to have a fast mechanism to get it out because my heart's not going to stop beating and wait up for my body to get rid of the CO2, will it? So it's got to have a mechanism to get rid of the CO2 as fast as it's being produced. And that's the lungs because the lungs are working along in coordination with my heart. So my heart's beating, moving blood around. I got to get rid of the CO2. It's the lungs. So we go by a drive of CO2 that's much greater than the drive to get O2 in. So what's happening is when the CO2 leaves the tissues, some of it jumps on the hemoglobin, but most of it dissociates into carbonic acid. How does that happen? Didn't Nate show you a formula earlier today? That's that formula. Do you remember on one end was CO2 and the other one was bicarb? Yeah, that happens every heartbeat. Every day, every second of every day. That formula is in action because we got to get the CO2 out. And we can't have that high level of CO2 coursing through our blood as CO2. So what's it do? It actually converts to something else. It converts to, and it dissociates into hydrogen and bicarbonate ions. And as it floats through your blood and gets to your lungs, it is able to change back and then go back out as the CO2 molecule. But this produces acid, which is not a bueno, right? We don't need that kind of acid in us. It's going to make us acidic, and we don't want to be acidic. So our lungs breathe it out. Nate covered this. As acid increases, the pH decreases. Again, because of the acid production, the CO2 production of the cells, the acid causes our body to say, we got to get rid of it. So that's when it stimulates the breathing centers for you to breathe and get rid of that CO2, which is acid. That's the impetus. We got to get rid of that acid, okay? Now, if you have a patient who lives with chronically increased CO2, what kind of patients would those be? Yeah, COPD patients. They live with a CO2 of 50, say, which is higher than normal, maybe even 55, right? Can we use that drive to breathe? We could, but it's going to cause some problems. Well, eventually, what happens if the CO2 gets so high? What's the brain going to say? Yeah, I'm going to go to sleep, right? And so now they switch over to something else. They switch over to O2, right? But going back to this, the chemoreceptors in the aortic arch and carotid arteries act as a backup mechanism. So when they detect O2 dropping now, then they're going to trigger the breathing cycle for the patient. So that's the opposite of what they should be doing, but that is how they go about doing that. Now that takes a long time for them to get there, and I don't know at what CO2 level gets them there, but eventually they're working their way toward that direction, and that's contrary to what they should be doing, right? Now when it comes to COPD, we'll talk more about what's happening in the lungs, but we'll skip that for now. Okay, so let's get to gas exchange and partial pressures. In the air right now, we have oxygen, nitrogen, CO2, and water vapor, right? The FiO2 of oxygen is what in the atmosphere? 21%. If we total all the gases are going to have a total of 760 millimeters of mercury. That's also equal to 1 torr, T-O-R, 1 T-O-R, same measurement. How do we get there? Well, we got to break the gases down. So if there are 760 millimeters of mercury of total gas right now, if FiO2 of oxygen is 21%, then 21% of 760 is what? 160. So the partial pressure of oxygen right now in the air at sea level is 160. But what is the partial pressure of oxygen on Mount Rainier or Mount whatever? Is it lower or higher than at sea level?
17%. Like 18, 17%.
Well, is it lower or higher than at sea level, the partial pressure?
Lower.
It's lower, right? It's much lower. And we're going to talk about that here later, why that is. But at sea level, the partial pressure of oxygen is 160, and that's going to matter for gas exchange. It has to be higher than what's in our body, partial pressure. Because remember, we're talking about gas movement, right? And gases move by what? Diffusion. And gases go from what? A high to low? Concentration? So keep that in mind. Nitrogen is really high. Don't know why. There's like 80% of nitrogen in the air, but it is. It doesn't do anything for our ventilation or oxygenation. It doesn't participate. We breathe it in, but it doesn't do anything for us. Water vapor, we're going to forget about. Who cares? Right? There's water vapor in the air. What I want you to do is remember that there's 1% carbon dioxide. Just use that number. There's 1% carbon dioxide. Far less. That probably means we have a greater partial pressure of carbon dioxide inside of us than there is in the atmosphere. Would you agree with that? Would you? Right? Okay, let me say it this way. If the atmospheric pressure of oxygen, start with oxygen, is 160, then obviously the atmospheric pressure of oxygen in our blood cells are less than 160. Would you agree? Okay. And if the partial pressure of carbon dioxide in the atmosphere is 1%, and I'm breathing carbon dioxide out, then obviously the partial pressure of carbon dioxide in my blood is greater than 1%. Okay, and we're going to discuss that in a minute, but I just want you to know that this is equal to 1 torr or 1 atmosphere or 760 millimeters of mercury. You're going to see those interchangeably in the class and on the boards. The boards will try to trip you up by saying 1 atmosphere is equal to something other than sea level atmosphere, because it is. So don't let the boards trick you. So total partial pressure of atmospheric gases are 760 millimeters of mercury, or 1 atm, or 1 torr. T-O-R-R. I didn't put that in the slide, but you need to write down. 1 T-O-R-R. They're all interchangeable. All right, let's talk about lung gradients. So gases move from a higher to a lower pressure because of a gradient. And if gases go down the pressure gradient, and if diffusion is the thing that drives gases, guess what? How does an oxygen molecule that's floating around in the air right now end up in my bloodstream? Simply because I breathed it in? Nice to meet you, paramedic. But what does a critical care paramedic care about? The pressure differences. Oxygen is in the air, and if it's unlucky to be next to your mouth, you suck it in because it has to. Because it knows as soon as it goes in the lung, there's a pressure gradient. Oh my God, I have an area of low pressure. I've got to go in there. And then in the lung, it goes, oh, there's a pulmonary artery over there. That's a lesser pressure gradient than I have. Slips through the AC membrane and into the pulmonary vasculature. And then it goes to the cells. And because it has to. It has to move down a pulmonary gradient. So in the atmosphere, what did we say the partial pressure of O2 was? 160. I'd make sure you know that. In the alveoli, in your lungs, guess what the partial pressure is? It's about 100. And finally, in your pulmonary capillaries, what's the partial pressure of oxygen in pulmonary capillaries? How do I confirm that? What? In ABG. So what did we learn today? What's the normal range? Well, he didn't really go into it, but we will. What's the normal range for PaO2? 60 to 100 or 70 to 100. It varies where you are, right? It's designed that way. It has to be that way. If the partial pressure of oxygen on your ABG was 500, guess what? We'd all be dead. Because there's no way oxygen is going to want to go there. No way. It's like a magnet with the opposing things, right? It's never going to go. But because the partial pressure of oxygen is much lower than the atmosphere, oxygen has no choice but to go in the pulmonary capillary and be transported to where we need it to go. Conversely, the same is true in our lungs. In our lungs right now for CO2, our partial pressure of our lungs, in the capillaries in our bloodstream is 40. Because what's the ABG PCO2 range? 35 to 45. And then once the CO2 gets the alveoli, it goes, oh wow, look at that. There's an area of low concentration. I need to go there. And it passes the AC membrane to the lungs. And then it says, oh my God, right outside of that big pie hole, there's a big atmosphere with like 1. And I'm in 30? Oh, I'm going. I'm so going. And what's it do? Pops out of your mouth. And so that's how gas exchange occurs, because it has to. It has to. Any questions on that? All right. Well, we all have pie holes. What it is. It is what it is. So this is just a review. Inhalation is an active process. Gases move by diffusion according to pressures. And this is why gases move from the alveoli into the pulmonary capillary. And then also for CO2, exhalation is a passive process. I don't know if I explained that properly. Inhalation is active because we're actively drawing air in. Exhalation is passive because we're not actively pushing air out, are we? Or are we? We're not. We're just resting. Our diaphragm is raising back up, our chest wall is coming back in, and air is being expelled. So it's really considered more of a passive effort. Do we need a break? Is it time for a break? We're almost there. We're almost at a break. All of what I just said is how a lung normally operates. But what can get in the way? What can get in the way of this gas exchange that's working so perfectly right now? Anything, right? And so that's where VQ mismatching comes from. There's a problem in the lung or a problem with the rib cage or a problem with the respiratory system because the brain is off, what have you. But one way of doing it is through VQ mismatching. No. No, 760 millimeters mercury is equal to 1 torr.
Torr and
Yeah.
ATM are.
Yeah, 1 torr is not equal to 1 millimeter of mercury. We don't have 760 torr. Am I wrong, Andy?
You're wrong.
Am I right? Is there 760 millimeters of mercury and 760 torr?
760 torr and like torr is like 0.9999 whatever to 1.
Oh, crap, am I wrong, guys?
I don't know.
And that's 1 atmosphere.
That is 1 atmosphere, yes.
Yeah,
So oh, you know what, he's right.
I don't think one.
I think I goofed.
Yeah, and it threw me off in the quiz, because millimeters of mercury and torr are different measurements, yeah.
But he says 760 torr is same as 760 millimeters of mercury, if they're different measurements. That's what I thought. I almost,
Yeah, 1 torr is 760 millimeters.
yeah, okay, I was right. Whew.
Is 1 torr also equal to 1 atmosphere?
Yes,
Okay.
1 torr is 1 atmosphere.
Which is 760 millimeters of mercury.
I've never seen 760 torr. I've only seen,
760 millimeters of mercury.
1 torr is 760. Yep.
look up an online calculator, like torr to millimeters of mercury.
I got it right.
Oh, you got it right there, okay.
That's exactly what I got. 1 torr equals to 760 millimeters of mercury.
Okay, I was right then. Because I'm bound to be wrong at some point today, because they get 1 a day, right? So,
Only once per class.
once per class.
No, I'm locked in on this, you know?
Yeah. Yeah. There's got to be, I'm going to ask Dr. Tan, there's got to be something I'm missing. But I learned that 760 is 1 torr, but that says something different.
Torr is unit measurement for pressure. So,
Well, leave it the way for now. Let me double check with Dr. Tan. And if you're right, I'll let you know.
With that dive medicine class.
Because you're a diver, right?
Well, no,
Oh.
I can't, but I took the dive.
Oh, you took the class. So you would remember that.
I
Yeah.
can ask squeeze do that.
Oh, do you? Mm.
But we had to have that was part of our IDC stuff. If you're the only person on the ship, they
Yeah.
they're doing better divers and
Yeah,
whatever.
yeah, yeah.
So it's on a dive table, I think, somewhere.
Well, let me ask Dr. Tan, because maybe I'm wrong.
But I do know that 760
Is 1 atmosphere.
is 1
Yeah, for sure. Yeah. Yep.
Hey, Brad, I have a question. Okay, it's not really the idea of it. So, in the cell,
So
like
all
spring
I'm
cell,
saying is if
there's more in the cell than calcium.
No.
But, right?
Yeah, sodium's in the pot. Yes, there's more than in the bloodstream. You mean?
Yes.
Yes.
bloodstream.
Yes.
So, but potassium and calcium are both positive cations.
Yes.
in the bed, we
So,
have no problems
why is
doing all the
potassium more
BLS,
positive
CPR stuff out
inside
of the bed
than
because they
sodium
just
if
take
they're both
fire drills
cations?
out of there.
Or why is it more
Yeah, you
positive
would have to
inside
be
the cell
out
with
there
potassium
on-
in there?
So why are there more potassium molecules than calcium molecules? Is that what you're asking?
No, I'm asking why is it more positive inside the cell? Is it because there's more? Because they're,
Just questioning
I see it as potassium, calcium are both,
some, because they've got some,
okay?
kitchen chairs and stuff like that. that can-
Why is potassium more positively charged?
It's not.
It's not.
Calcium is more positively charged.
Yeah, calcium's
Yeah.
2 plus.
Yeah. I think because there's just more potassium ions in the blood than there compared to calcium.
Makes it more
Yes,
positive inside
yes.
the cell? Okay.
Yes. Now, Dr. Tan's going to cover labs, and he's going to talk potassium, sodium, calcium, all that next week.
Okay.
Which he should have covered week 1, but he didn't get to it. Because we needed you to have that foundation to get to this stuff, but we
Right.
didn't get to it.
Right.
So it's fine.
I was thinking.
Yeah, save that question for Dr. Tan, because that'll be his lecture.
Gotcha.
He'll be able to answer more better than I could, probably. Because honestly, I don't know why there's more potassium than calcium in the body, but there is. Yeah, there is. I'm sure he knows. And that's the good thing with having a doctor be an instructor, because we can just turn to him for questions like that. He knows, you know he knows.
Yeah, so if we chose to be indoor, I think we all survived.
1 atmosphere is equal to 760 torr.
What?
1 atmosphere.
He found a paper that showed that where 760 torr equals 760 millimeters of mercury. So we have 2 conflicting
So this
sources.
says 1 ATM is equal to 760 torr.
That's true. But does millimeters of mercury and torr, are they equivalent measurements or not? That's the question.
1 torr is equal to 0.00132 atmospheres.
So that didn't answer the question.
So then,
Yeah, torr, millimeters of mercury.
right, so it's 760.
They're equivalent?
Yeah.
See, there's other places where it says they're not. So I got to ask Dr. Tan. I'm sure there's something different between the two. There's a difference between the two. There's got to be, but I don't know what it could be. Just go with my slide because probably I'm right because I'm
760 torr.
It's me. I mean, come on, it's me. Seriously, come on.
Google says
So-
760 score equals 760 millimeters of mercury, or one, God, what is this? 1 million.
We'll figure it out. I'll tell you what. We'll get you guys an answer. Let's put it that way.
Tell me about.
And I'm not going to claim that as a mistake for the day, though, just so you know.
That was very hard.
Says torus equal to 1 millimeter, 33.3.
Oh, that's trouble. We just need to do that all better.
So yeah,
Well, I don't care about Pascals.
so it's 1 and 1. 1 is equal to 1 millimeter.
Okay. Okay. Okay.
But it's Google, so I'm not into that.
Google's got it. Come on, man. Hey, at least he didn't put it in the chat GPT.
Right. Right. You probably should have, but all right. Everybody back? No, wait, 2 more. All right. Is everybody's head still attached to their neck? That's the question. Is anybody's head exploded yet?
It exploded a long time ago.
It's there. I see it. We haven't got into the big stuff yet. This is all. I'm kidding. No, we're in there. We're in the meat of it. We're getting there. We're getting there.
My grandson.
I like learning this stuff first.
Yeah. If you love this stuff, wait till hemodynamics. It's a lot of fun. You'll learn a lot of good stuff in hemodynamics.
Wow.
Yeah.
It's like a firefighter, talking about gases and fires and water.
So when do we spread water?
Yeah. Oh, we'll get to water. Don't worry. That's Dr. Tan's lecture, actually. Movement of water around, huh?
I like turtles.
You like turtles? They like water too.
That's where I'm at right now.
All right. What's your team name? I need a team name.
Insomniac.
Oh, you got it already. Never mind. Insomniacs. You're right. You're right.
You even wrote it down, Brian.
I'm 54. I don't know where I am half the time anyway. You got to remind me of certain things.
My call sign's Ursa.
All right. Sooner we get back, the sooner we get out of here. I'm just saying. Yeah. Everybody floating around the hallway, still missing someone. It is. It's like Freddy Cats. It really is. All right. I hate to start with that, and we'll wait a few more minutes. And I get to play with my slinky on this slide. This is exciting.
Oh, there you go. New from Hasbro.
Maybe he's pooping.
Dropping the kids off the water park.
Yes, maybe. Maybe so. Oh, there he is.
Everything about okay.
Were you pooping? All right. Yeah?
There you go.
I can't go? All right. So now it's all that leads us to problems in the lungs and what they look like and how we go about treating. Remember, I told you I want you to live in that patient's lung, right? I want you to see all the way down. So let's see all the way down. Let's see what kind of problems can occur way down deep at that AC membrane. And that's what perfusion, ventilation, mismatching is. So V is the ventilation and Q is the perfusion. Now that's funny. Why isn't it a P? It isn't. It's a Q. So Q stands for perfusion and the VQ matching or mismatching. When you look at a normal lung, here in red, you got to understand that as we stand upright and move about our day, gravity is affecting our lung fields, okay? So what's happening is, kind of what's happening to the slinky here. If I take this slinky and do this to it, if they look at the rungs on the top, they're further spaced apart, are they not? But look at the rungs at the bottom. They're closely spaced together. Why would that happen that way? Gravity, weight and gravity. This is what your lungs looks like. The top of your lungs are able to aerate better and ventilate better because guess what? The alveoli are bigger. But the alveoli in the bottom of your lungs are what? They're there, but what are they doing? They're a little squished. So does ventilation, which one is greater? Ventilation at the top or the ventilation at the bottom? There you go. You just understood VQ mismatching. That's it, honestly. So if we know that, then if we look at our top of our lungs, ventilation, the big V, is going to be greater than the ventilation in the bottom lungs. We know that, okay? Well, guess what? That means the opposite is true for perfusion. If the alveoli are bigger, right, then the capillaries are smaller because of space. There's only so much space. So they're a little bit smaller. So perfusion is less at the top and more on the bottom. Less on the top and more on the bottom. And you must understand that concept. They're reversed to understand VQ mismatching, okay? Because that's going to lead into the types of problems we're going to discover. So in the upper lungs, ventilation is always greater than perfusion. It's just a rule. So the V is greater than the Q. So we would say we have an increased VQ ratio. Have you ever heard that term before? An increased or DQ-VQ ratio? It's not confusing. What we're saying really is that the V is increased. An increased V to Q. So it's increased ventilation over perfusion. Okay? So when we say increased VQ ratio, we're really saying it's an increased V. Do you understand that? In the middle, well, the VQ ratio is equal. It's right in the middle. So the middle lungs have the best, really, oxygenation and ventilation because they are perfect. It's like my porch is too hot or my porch is too cold. No, it's just right. In the middle, it's just right. Okay, the space in the alveoli is good. The perfusion's good. And that's what we want. We want the VQ ratio to be equal at a 0.8. If we had to give it a number, 0.8. You need to know that. If normal VQ ratio is 0.8. If it's a high VQ ratio, then it's a 1. It's elevated, it's high, 1. Conversely, when we get down to the lower lungs, perfusion is now greater than ventilation. Okay? So that gives us a decreased V, right? Decreased ventilation. So that's why we call it a decreased VQ ratio, because the ventilation is decreased. And that gives us numbers like 0.06. How many times have you listened to lung sounds and go, well, they're good, but they're diminishing the bases? Do this. Go ahead. Because you've said it. If you said that, do that. Seriously. You've all said it. Like, oh my God, there's something wrong with that. Guess what? That's normal. Why would lung sounds always be diminishing the bases? Because of this. Look at the air movement. Look at the air movement from the top and the bottom. So it's a natural occurrence for lung sounds to be diminishing the bases. That's normal. So stop saying, what's the lung sounds? Oh, I'm listening. Well, they're diminishing the bases. Next time someone says that, you go over and you go to do that to them. Because you're like, no duh. No duh, they're diminishing the bases, friend. But do you hear wheezing? Do you hear rails? Do you hear something down there? I mean, they're diminished. They should be. That's a normal thing. So the proper balance of ventilation, or V, movement of air, and the proper perfusion, the movement of blood, is what's essential for oxygenation and ventilation. We got to have those two working together and properly without any problems. But guess what? Life is not a bed of roses, right? So there are problems. We're going to have problems with the VQ ratio, right? How do we get to 0.8, you ask? What happens is for every 4 liters of air, your blood's actually pumping 5 liters of blood through the same area. When you make that division, it comes out to 0.8. And that's where the 0.8 comes from. So if I'm pumping less air through, but the same amount of blood, doesn't that affect my VQ numbers? Yes. And that's where those numbers come from, just so you know.
That's for like a normal person. Like someone's chronically supine, it's not going to be like that.
Yeah, it's going to be different. Yeah. But again, they're going to have lung issues because they're supine a lot and whatever.
Okay, I'm still just a little confused why the perfusion is greater at the bottom.
You know what? The only way I can explain it to you is the only way I know it is that perfusion is greater down there because, I don't know. Honestly, I don't know why.
There's ventilation getting to that.
There's less ventilation, but why would you get more blood flow is the question. And so honestly, I don't know the answer to that. No, it's not gravity.
It's the ratio. There's not more blood flow, there's just.
Okay, that's what it is. Thank you. Explain that. That's the answer.
So there's the same amount of perfusion at the middle lungs, but the ventilation is equal. You have the same amount of perfusion in the lower lungs, you just have less ventilation, so the ratio is skewed.
So we have a small VQ mismatch normally between the top of the lungs and the bottom lungs. Because perfectly we want to be in the middle, but that's not the way our lungs work. So they're going to have less ventilation, which throws out the VQ ratio. But it's not because there's a disease process, it's just because there's less ventilation in the base. Do you understand that?
The thing that changes is the ventilation.
The numbers. Yeah, the numbers.
The perfusion stays the same ratio, so it's not ratio, but the perfusion stays the same. So up here in the upper lungs, you have more ventilation, so you're gonna have more V than you have. As it's harder to expand, that middle low, it's equalized, and then we get down low, the air can't get there as well, but you have the same amount of perfusion.
Okay, so are you saying like really,
Hang on.
so little Q, big Q, like equal Qs?
So we got the same amount of Q in each area of the lung. We just have a different amount of ventilation in each
So
area.
it's the ventilation.
Yeah, you know what? Do that. Make the Q's equal. Make the Q's equal. Because that makes more sense. Yeah. So fix your slides. The Q's are equal, and what's changing is the ventilation. Yes. Okay, that makes sense. Sorry about that. That's better explained. Okay. All right, moving on. Are we caught up? What?
I was just saying, the National Library of Medicine says that perfusion in the lungs is higher at the base because gravity is pulling blood down because there is more alveoli and pulmonary blood vessels in the lower.
So gravity plays a role too. Okay. So gravity plays a role too. So you can leave it equal or leave it as it is, but understand it's the ventilation that's the issue. That changes.
The gravity's pulling
The blood, more blood down to the bottom. So there could be increased perfusion, slightly. But when we talk about VQ mismatching, we're seeing big changes. This is just normal physiological changes. Okay, I understand that. All right, we're caught up, right? Are we caught up? Okay, so this is matching. this is VQ matching, right? This is a normal physiological thing. We just learned that there's differences in ventilation according to where area of the lung you're in, but that's normal. So now let's talk about what not normal looks like, and that's what's called VQ mismatching. So again, to review, if we have a low VQ, right, we have less ventilation, right, which means a disruption of airflow, agreed? That's going to decrease your V, right, and that means that there are areas of the lung that are not being ventilated well, right, which is be the bottom. And that's okay. They're not being ventilated as well as the lungs on the top. That's going to give you a VQ ratio of 0.6 or less if there's a problem. In green, it's the other way. We have a disruption of blood flow, right? So if we have any disruption of blood flow, we have a decreased Q now, decreased perfusion, right? Blood flow is decreased, which gives us a high VQ ratio because there's a lot of ventilation with a decreased perfusion. Everybody understand that? I'm just repeating the slide previous so we can wrap our brain around it. If we have disruptions on both, this is new. This gives us a very low VQ ratio because we have a shutoff of ventilation and we have a shutoff of perfusion, right? So a total lung shutdown. That decreases both V and Q. We're going to talk about the specifics about later, conditions that cause these things. I just want to get this out. So both the lungs and the vessels are affected, obviously. If there's no ventilation, no perfusion. There's something going on with both. Or something in the middle of both that could be causing disruptions. All of these, though, result in poor oxygenation and ventilation, so your patient's going to become what? Hypoxic. This is the impetus where hypoxia is coming from, right? Or one of the reasons. There's several reasons for hypoxia, but when you talk about hypoxia, this is it. It's VQ mismatching. All right. There are 3 types. I will test you heavily on VQ mismatching. I'm sorry, friends. You must know these next dozen slides. There are 3 types of VQ mismatching. There are hundreds of conditions, but they really fall into these 3 types of VQ mismatching. Okay. The first one is a pulmonary shunt, and we mean right to left. Now, who can tell me what I mean by right to left shunting? What right and left of what? Not the ratio. Well, you know what? Hold that question. We'll get to it. Okay, so let's talk about a pulmonary shunt. What does a pulmonary shunt mean, and what exactly is being shunted away, right? So the shunting means to bypass something, right, or to transfer it away from something, to shunt it away. Okay, that ain't good when it comes to the lungs, my friends. The lungs need the oxygen to come in, the CO2 to go out, and the blood to go round and round. But something's being shunted out from that equation, right? What's happening in pulmonary shunt is that the alveoli are not working, okay? The blood that's going to the alveoli is not getting oxygenated. Why not? Because there's an obstruction in the alveoli. Air can get in, which means oxygen, right? But can oxygen get to the capillary? Nope, because there's gunk in the alveoli, okay? There's gunk, like what? What kind of conditions of that? CHF, atelectasis, pneumonias, cystic fibrosis, okay? Because it just clogs up the alveoli. So what's happening is whatever part of the lung is affected, hopefully not all of it, but in a pneumonia, it's isolated to one side usually. So say I've got pneumonia on my left lung is shut down because I can't get oxygen in, and that's the key. Oh, hang on, I went too fast. I can't oxygenate. This is a problem of oxygenation. So what do you think that lung is going to do? What's going to do is the lung's going to realize this alveoli ain't working no more. So the shunting part comes from what? Not the air, but the blood. So what does the body do to this capillary? If the body says this alveoli is not working no more, what's it going to do to that bloodstream, that blood flow? It's going to vasoconstrict that capillary, which is doing what? It's shunting blood away from the bad alveoli and feeding it to the good alveoli. So the alveoli and the capillaries in the good alveoli are now dilated because they're receiving the shunted blood from this bad alveoli. That is what a pulmonary shunt is. Now, it will not happen immediately. The body will try to fight off the infection, pneumonia, and will compensate for it. But eventually it's going to get to the point where the body says, I can't use that lung anymore, that side of the part of the lung. I can't use those alveoli. So it shunts them. It shuts down the alveoli. Air is still going in and out. The alveoli is not affected. You're still breathing air in, but there's no gas exchange. So this capillary says, I recognize there's no gas exchange. I'm going to vasoconstrict. And so the blood shunts somewhere else, and that's what's being shunted. What's being shunted is unoxygenated blood. This is very important. because the blood that should be going there is being shunted, but is this completely shut off? No. So what's going through? Unoxygenated blood. So that means, guess what's getting to the heart? Some unoxygenated blood. So is that going to cause hypoxia? Yep. And is that shunting as well? That's another form of shunting, right? So it's trying to shunt as much good blood as it can away from this bad alveoli, but it can't shunt at all, otherwise everything would die. So some blood flow still goes through and bypasses this lung, but some still gets through, and it will cause problems downstream. Now, just a 20% of your lung being shunted like this will cause a severe hypoxia. Just 1/5 of your lung fields will cause a severe hypoxia. Normal shunting is about 5%. But they think we always have some gunk in our lungs to one degree or another, or there's some part of your lungs that have atelectasis for one reason or another. And so normal shunting is about 5% or less. Our lungs don't work at 100% capacity all the time, I guess. Okay?
So is pulmonary shunting more of just the physiology of the capillary closing, or is it?
It's the physiology of the capillary closing because what's going on? Is this a high or low VQ ratio? Is it? It's a low VQ ratio because the air could get in just fine. Air movement is occurring in the alveoli. So it's not a problem with ventilation. It's a problem with the perfusion shutting down because the perfusion can't get the oxygen from the ventilation. So this is a high VQ ratio, right, Brett? What would you say? It's a high VQ ratio, right? I'm sorry, what did I just say? It's a low VQ ratio. Okay, God.
You said low first.
I did? Okay, I'm sorry, guys. A low VQ ratio. All right, because we have decreased transfer of the oxygen, okay, and gas exchange. So perfusion here is exceeding ventilation until the capillary shuts down, and then we have a different ratio. So initially, we have a low VQ ratio, all right, which will worsen with vasoconstriction later. Okay, so O2 can get in, but it can't get through. All right, so what are some conditions that would cause this? Like we said, atelectasis, pneumonia, pulmonary edema, COPD, asthma, ARDS, all those things. Who wants to answer this question?
No, you need
Will the copious amounts, if I threw all the oxygen in the world at a pulmonary shunt, will it fix it? Why? It's just not getting through. I don't care if I increase FiO2 to the lungs to 1,000%. I just can't get through this gunk. So the answer is no, especially in the larger shunts. Right? So good. That used to be a board question. That used to be a board question. I don't know if it still is, so mark that. Will oxygen fix large pulmonary shunts was the board question, and the answer is no, it won't. We still put oxygen on though, don't we? Then why do we even bother with oxygen then? Because not all the lung is being shunted, right? We still have perfusing tissue and lung that we can hyperoxygenate to fix the situation. So that brings us to a question. Is oxygen a pulmonary vasodilator or a pulmonary vasoconstrictor? Why? Or why is it a good idea that oxygen is a pulmonary vasodilator?
If you dilate blood vessels with good oxygen, more oxygen goes there.
Yeah. So the act of breathing in oxygen dilates our pulmonary capillaries by just a normal mechanism. That's good. That's a good thing because it allows better perfusion, right? So O2 is a pulmonary vasodilator, right? So as a result, what if I said that this drug is a vasodilator? What does that do to pressures? It lowers it, right? And so remember we talked about the pulmonary circuit as a low pressure system? This is part of that, okay? So what it's doing is dilating it. It's a pulmonary vasodilator, and so it lowers PVR, which is pulmonary vascular resistance. Remember with the vasopressors, when we constrict, we talk about SVR, systemic vascular resistance, and we dilate an artery, we open it, the vasodilator. So what does that do to SVR? We said that it lowers it. Same thing with pulmonary circuits. So because these capillaries are in the lungs, they're under the PVR, the pulmonary vascular resistance, okay? SVR is consistent with the major blood vessels throughout the body, systemic vascular resistance. But these capillaries in the lungs fall under the PVR, pulmonary vascular resistance, okay? So just understand that. It's going to have a low system, right? Also, the reason why oxygen is a pulmonary vasodilator because it improves any VQ mismatching. It's the body's way of saying, okay, I have pneumonia and I'm shutting down those arteries, those capillaries there eventually, but before that happens, I want to dilate those arteries to get more oxygen there, right? So initially, to prevent that shunting from occurring later, right? Now, this could also be a problem though, couldn't it? If oxygen is a pulmonary vasodilator and I give a COPD patient high amounts of oxygen, is that a problem or no? How is that a problem? Something reverses. What reverses?
Instead of being like carbon dioxide driven, aren't they oxygen driven?
what happens is physiologically on these end-stage COPD patients, which is why we want them pulse oximetry to live where? 90 to 95, right? And that's why I ask my COPD patients, hey, where's your SpO2 normally live at? And they go, I'm 93. Great, that's where I want you. Even if they're on the vent, even if they're on BiPAP, I want you to live in the 93. Because if we blow them full of oxygen, and they've got areas of the lung that are shunting, which is okay, right? And we give them a pulmonary vasodilator in high concentrations, and we open up the pulmonary capillaries that were normally closed, what's that going to do? Is that going to improve the patient's condition? No. What's it going to do instead? The alveoli are still shut down. It's going to open up blood flow to that area, and now more unoxygenated blood is going where? And guess what's in that unoxygenated blood? CO2. And guess what happens when your body has more CO2 than it should? What does your pH do? And so now we go into a respiratory what? Acidosis. We go into a respiratory acidosis simply because we gave a COPD patient too much oxygen for far too long. Okay, this is why. This is what physically, that's the hypoxic drive. That's the better definition of hypoxic drive, is when we cause the body to have way too much acid, way too much CO2, and the body needs to rely on what? The peripheral chemoreceptors to use oxygen to stimulate breathing, right? So just something to keep in mind. So that's why, again, high flow oxygen in a pulmonary shunt is not going to be beneficial. Simply, not only because the alveoli are shut down. That sounds like a really good test question too. If I asked you something like, oh, hey, why would giving high flow O2 for a long term to a COPD patient not be beneficial? Sounds like a pretty good test question to me, right? Well, because the alveoli are shut down and they're not going to participate because it's a right to left pulmonary shunt, right? And also because if the patient is shunting, then I don't want to reopen those capillaries because the shunting is doing a good thing at this time until we can fix the underlying physiology, if we could. Of course, if it's end-stage COPD, there's probably not much we can do for them. But if it's a pneumonia, then we can clear the pneumonia, the alveoli becomes happy, then those pulmonary capillaries become happy, and then the body becomes happy, right? Make sense? Make sense? Okay, all right. All right, so that's pulmonary shunting. Does everybody understand pulmonary shunting? If you have a question, please ask me, because we're going to move on. A lot going on in pulmonary shunting in there. A lot going on.
Would that be, when you say ultimately going to hypercarbia, is that respiratory acidosis?
Mm-hmm. Exactly right. It's going to cause a worsening of their already present respiratory acidosis because most COPDers are going to be living with a high CO2, we learned earlier, so they're going to be in a minor respiratory acidosis, and we're not helping matters by causing CO2 to be retained in their body. We're not causing any good things there because now the body's got to work harder to do what? How's the body mitigating increased CO2? Well, we're going to talk about that in the lecture later on, but bicarb, right? It's not making bicarb, it's retaining bicarb. The kidneys are going to retain more bicarb than they should, so it can be used in the bloodstream to mitigate the acid, right? But we'll talk about that. Okay, let's go into dead space ventilation. Dead space, deep space, whatever. All right, what's happening in dead space ventilation? What's dead space?
Air we don't use.
Say it again.
So air we don't use, it just kind of sits there.
Air we don't use. Very good. And so air that's participating in a breathing circuit that's not participating in gas exchange, right? So air can get in just fine, thank you very much. There's not a problem with the air getting into the alveoli, right? This is a problem with the capillary. Flow is disrupted to the capillary, which makes that alveoli dead space. Now, the good thing is oxygen can get through, but CO2 can't get out. CO2 can't get out. Conversely, on the pulmonary shunt, O2 couldn't get in, but CO2 can get out. Now we have a situation where CO2 can't get out, but O2 really doesn't have that much of a problem. So what does dead space ventilation mean and what exactly is dead? Again, it's referring to an area of the lung that's not participating in gas exchange. And we know about anatomical dead space. That's our trachea, that's our pharynx, right? That's our bronchi and some of the bronchioles. They don't participate in gas exchange, but air goes there. Physiological, though, is what we need to really be concerned about. Those are areas of the lungs that should be perfusing, but now cannot. They cannot because blood flow is decreased. Blood flow is absent in some cases. Late-stage COPD is your big one, right? What happens in late-stage COPD, we talked about with the emphysema question earlier. The alveoli are way distended. They're floppy. I mean, they're just, they're distended. They can take in larger volumes than they should. There is no elasticity to them. What's that doing, though, to the pulmonary capillaries? Same space. Yeah, it's compressing them. And so it's contributing to poor perfusion through those alveoli, and as a result, dead space ventilation. Because this thing now is twice the size. Can you imagine? Right? This alveoli is enlarged. It's twice the size, so we're getting air in, but if it's twice the size, then that's half the size. And so ventilation is occurring, but perfusion is not. And so that makes it well, that also explains your barrel chest and your COPD, right? Reason why a patient with end-stage COPD has a barrel chest is why? Because the respiratory muscles have conformed to the fact that the lungs have been so overinflated for so long. And they will conform themselves around the lung. And then the patient becomes a barrel-chested individual. So this results in a what? This results in a high VQ ratio because we have plenty of oxygen going in. High ventilation, but there's still a problem. So we have good ventilation, good air movement, but perfusion is bad, so that's a high VQ ratio. CO2 can't get out. So what would cause that? Well, wouldn't a PE? A PE definitely would. If it's big enough, it would cause a lot of alveoli to become dead space. Because you've seen PE patients, they're breathing just fine, thank you very much. Their lung sounds are just as clear as can be. But what's happening? There's no perfusion because the bloodstream is shut off. What about hypovolemic shock? What if my blood volume is low? That's going to be a play factor here too, isn't it? What about cardiogenic shock? The pump is broken, and I just can't get the stroke volume through the body, right? Reduced blood flow. And of course, late-stage COPD. What would cause a situation where a patient would have no ventilation and normal perfusion to the left lung only, besides a pneumo? Whoever gets this gets an extra credit point on the next test. No, yes, but that's what I'm looking for. I'm not looking for the answer. No, it's got to be the answer that's on this slide. It's got to be the answer. What? Is it on it? Is it on the slide? Well, I can't give you a point for that if it's on the slide. I didn't know I put it on the slide. I can't give. Let me think about it. Okay, inverted right mainstem intubation, right? If I put the tube in the right lung, right, that's obviously going to cause a situation where there's no ventilation with perfusion occurring to the left lung, right? So I thought it would be a trick question, but I gave you the answer, so not very tricky. Huh? She didn't phrase it right either. Okay. Any questions on dead space? That's easier, I think, isn't it?
But if you only have one lung, does that count?
No, come on. No. All right. Any questions on dead space?
Like, can I just
Yes, review it. Yes. Yes.
Not necessarily perfusion problem.
No.
Then they still can't get out.
It's a perfusion problem because there's air getting in just fine. And so that air becomes what? Dead space.
Correct.
Dead air becomes dead air. Because it's not trapped, it's just not participating in gas exchange. Because we need a capillary to work for there to be gas exchange of the tissues.
Right.
So there's no oxygen getting to that capillary. I'm sorry, there's no CO2 getting out of that capillary because the capillary shut off. Yeah. So it's a problem with perfusion. There's a problem with the capillary. Got it?
Yeah.
Versus pulmonary shunting is a problem initially with the alveoli that's going to eventually translate to the capillary, right?
Right.
It will.
The dead space starts with the capillary.
Dead space starts with the capillary. And that's why it's these conditions that are the primary culprits for dead space. PE, that's all blood flow. Hypovolemic, that's all blood flow. Cardiogenic shock, all blood flow issues. And the only exception is late-stage COPD. That's only because the over-enlargement of alveoli is now hindering capillary blood flow. So again, another blood flow problem, but because of a pulmonary issue. But these top three are nothing but pulmonary blood flow issues.
I guess the only thing I'm still stuck on is it's a blood flow issue, but why does that cause, like, the air to be trapped in the alveoli?
It doesn't. There's no trapping of air yet. No air is being trapped. It's just that there's no gas exchange through the AC membrane. Remember, we're living in the AC membrane.
Right.
That's where all of the shuntings I need you to think about. I'm looking at the AC membrane, and if I look at the AC membrane in dead space, if I can stand there and be a spectator, I can see O2 molecules go through, but I don't see too many CO2 molecules coming out. It's a reduced amount, if at all. That's what I see when I'm standing there.
And the reduced CO2 molecules going out is because...
Yeah, I need blood flow. I need blood to get there in order to release the CO2, but guess what? There's an obstruction. There's an obstruction of some kind. Versus the pulmonary shunt one, where there's plenty of blood flow, so the obstruction is up here. So it's just one or the other. Is really what it is. Okay. All right, silent perfusion is a far less common one, but you will see it from time to time. This is a situation where, hey, there's no problem with the alveoli, and there's no problem with the capillary. So where's the disconnect? Where's the problem occurring at? Membrane. Yeah, membrane, but where? Which membrane? I just told you both membranes are working fine. The alveoli membrane and the capillary membrane are working fine. Thank you very much. I told you about the potential space, right? So now we've got gunk in the interstitial space, the space that lives, the potential space that lives between the capillary and the alveoli. Remember, there's a space there. Just like in your lungs, between the pleura, there's a pleural space. There's an interstitial space that lives. And guess what can fill up in there? Yeah, crap. All kinds of crap. Green, ugly looking crap. So now, because of there's crap there, does that make for a very good filter? No, it's a wall. It's a wall. So guess what? Neither now, O2 or CO2 can get through. Neither. It's not one or the other. It's like a complete shutdown, which is why it's called silent space. No movement of a gas exchange occurring at all. It's silent. It does not exist. That's pretty significant. That will hurt you. That'll leave a mark, for sure. So it's less common. It's due to the interstitial space. No gas exchange is occurring. So what are some conditions that would cause this? Some with fluid, but not in the lung.
Infection.
What kind of infection?
Well,
It's talking about effusion?
yeah.
Pleural effusions? What about interstitial lung diseases? There are actually 200 different types of interstitial lung diseases that could cause this. The most common ones being pulmonary fibrosis, asbestos disease will cause this, and severe COVID-ARDS. Severe COVID-ARDS. And we saw a lot of that in the last couple of years. If you were transporting patients in the COVID era, you saw that. And that was a dysfunction right there of the interstitial space. What does that look like in X-ray? Well, here's a normal X-ray. Here's a person with a pneumonia, and tell me where that pneumonia is. The right middle lobe, there you go. The most common spot for pneumonia to occur, that's a right middle lobe consolidation. That's called a consolidation because we can see fluid there where it should not be. It's in the lung field. It's in the right middle lobe. It's a right middle lobe pneumonia. That's nothing compared to the last one. What's the last one look like? White out, right? We use the term white out. There's nothing but white, which means that's nothing but fluid. Where's that fluid living? Is it living in the alveoli? Nope. Where's it at? In the interstitial space. It'll still be on the chest X-ray.
So will they also?
Oh, absolutely. Because guess what? How much of the lung field is affected here? Maybe 5%, 10%, would you say? How much would you say? 10%?
Sure.
So we can oxygenate 90% of the lung.
It was like
But here,
190.
there's homogeneous. See how it's homogeneous? There's some dark areas in there and some light areas. The dark areas signify air. So whatever you can see that's dark is actually being perfused to keep the person alive, but the white, good luck. Very little to no gas exchange occurring. Why can it not occur? Because interstitial blockage. There's a wall between the alveoli and the pulmonary capillary. There's a wall there. And we're seeing it. All those alveoli are walled off from gas exchange. To an extent, I'm not saying it's complete 100% blockage, but to an extent to where it's going to cause this patient to be highly hypoxic, obviously.
Did they do comparison to TCC?
No, because it's not in the pleural space, it's in the interstitial space.
Like infusion?
No, this wouldn't be an effusion. This would be just clogged up interstitial space, and you can't get to it.
And see,
No. Now next week, Dr. Tam will talk about ARDS, and in Vent, we'll go really deep into ARDS and how to manage this patient, but not today. But I just wanted to let you know what it looks like, and that's what it looks like. So can you imagine the AC membrane dysfunctions on the one on the right? Horrible AC membrane dysfunction, right? There's no gas exchange. Compared to the one on the left, all that darkness is good. That means there's air in there. And if there's air in there, then there's gas exchange. There's something that's called a VQ scan. It's not really used anymore. It's kind of outdated. There's better ways of doing this. But a VQ scan, if you ever see it, it's a dual test. It consists of two parts. They're going to inject a radioactive dye in your bloodstream, and they're going to watch for your pulmonary capillaries. I'm sorry, we'll start with the inhalation. They're going to give you a nebulized treatment of a radioactive thing that you breathe in. And when you breathe it into your lungs, they're going to track it on both your lungs. Now, does that look even to you? It does. It looks pretty even. So that's showing that whatever is happening, this VQ mismatch that's happening, is not a high VQ mismatch, is it? Because we have ventilation on both lungs, do we not? Would you agree this is whatever's happening is not a high VQ mismatch, right? Would you agree, Adam? Because there's ventilation present, all right? But what about the one on the right? What's the right one tell us? This is the perfusion where they injected the dye into the bloodstream, and they're looking for the dye to travel throughout both pulmonary arteries on both lungs. One is being perfused, but one is blank, right? So is that side a high or low VQ mismatch?
Low perfusion.
Yeah. What's going on? What's going on to the left lung on that patient? It's not perfusing at all. So it is a what? What type of VQ mismatch is occurring over there? Is it a pulmonary shunt? Is it a dead space? It's a dead space because there's air getting in, but is there any perfusion on that lung? So it's a dead space, right? Would you agree? And that's exactly what's going on. It's a pulmonary embolism of the left lung, and that is dead space ventilation in action.
Nebulizer, you get to pick your superpower.
I know, right? It is radioactive. You actually go through the nuclear medicine clinic to get it done back then. But like I said, they don't do them much anymore. CT scans are good enough now to where they don't have to worry about that kind of stuff. And that's it for VQ mismatching.
So you're trying to understand this? The VQ mismatch, you're doing like 4 liters of air over 5
Yes.
liters of perfusion.
Yes,
So if your perfusion goes down,
yes,
your number is going to go up at the high VQ.
yes. Did you say if your perfusion goes down or your air goes down? Yes, if your perfusion goes down, you're going to have a high VQ mismatch because ventilation is good.
Okay, so if my perfusion goes up,
Yep.
then I'm going to have a low VQ mismatch.
Yes, because ventilation is going to be affected. There's a problem somewhere. It's either ventilation or perfusion or both.
Okay.
So in a low or a low VQ mismatch, it's low ventilation. Perfusion is just fine. Thank you very much. And so that would be what? A dead space, right? Or pulmonary shunting would be a high VQ because you can get air through. I'm sorry, low VQ because you can't get air oxygen through, but you have good perfusion. Until later in the pulmonary shunt, when things shut down and actually shunt, then you have a low perfusion through there, right? So there's 2 parts to pulmonary shunting that you got to consider. One part to the dead space.
So a low mismatch ratio is a ventilation problem or a high mismatch ratio
Yes.
is a perfusion problem?
Yes,
Would that
yes.
always be the case?
No, these aren't absolutes. These are just kind of like, just saying, hey, where's the problem occurring? It's like a theme. It's not an absolute, but it kind of gives you an idea of what's going wrong where. What's going on where. And so then as critical care providers, can recognize that and know what to treat, right? Or know why they're on the certain vent settings that they are, right? Or know how to fix if something crashes or changes. You know that in a PE, I don't need to turn up the FiO2, do I? Is that going to fix anything? Right. So what do I need to do? I need to fix perfusion somehow, right? So they need a thrombolytic, right? I need to show up with that patient in the ER and go, my patient needs a thrombolytic, not high flow O2, right? So if you're in a critical care transfer the patient that had a PE, your first question is going to be what? What thrombolytic did you give them, right? So this is how you treat, identify, and manage these patients and how you recognize the problem. Not that I'm just on a transfer and this is what's going on and I'm done with it. No, you've gotten into the AC membrane if you look to see where the dysfunction is and how management can improve or make sure at least that they're doing the right management for that patient, right? It's important because you're going to have these situations, guys, where on these transfers and it's going to be everything in the book is wrong with this patient. And you've got to be able to look through the mess. You've got to be able to look through the 10 pressors going, the vent settings, the patient intubated, maybe even on a balloon pump. You've got to look through all that and go, what underlying is going on with my patient and how is my patient responding to this therapy? That is what makes a critical care paramedic, is understanding what's going on, okay? So are we ready to move on to types of hypoxia? Do we need a break? Do we need a quick 5 minutes? All right, quick 5 minutes. Quick 5, which means really I mean 3. I mean 3.5. Oh, we have a coup coming up, so that'll break up some things too. We have a coup coming up. It'll be a team cahoot.
Team coup.
Yeah. I love my cahoots. They break things up.
So pulmonary shunt, if you think about it, it's like a ratio.
Yeah, it's a ratio. Yeah, that's all it is. How well perfusion is relating to perfusion and ventilation. Yeah.
So a pulmonary shunt, you're able to ventilate yourself as preferred.
You can get air in, but there's no oxygen moving through. The problem is with the alveoli.
Yeah. So your ventilation is technically fine, your perfusion's bad?
No, ventilation is bad.
Ventilation.
Yeah. In a pulmonary shunt, initially ventilation is bad. It's going to work into where it's going to be a capillary shunt as well. And that's where the shunting is coming from. Unoxygenated blood is able to pass through the alveoli that's shut down. So unoxygenated blood is being shunted through.
Yes, because your top.
So that's a low VQ.
Low V,
So because English is my second language, because the part when it says increased VQ ratio, meaning like 1 to 5.
Yes, yes.
Go to Merrick's out,
Yes.
right? And so 1 to 1 is technically a low VQ ratio.
Well, it's 4 to 5. And it's 4 liters of air to 5 liters of to blood.
And that's considered low.
And that's a 0.8, and that gives you a normal. That's normal. So it's already a little off normally. But if you wanted we say a lower high VQ.
So it says, like for instance, increased VQ ratio.
Okay.
Where's the spread? Or what is it? What is an increase in relation to?
It's increased as relation to perfusion. So perfusion has gone down, which is going to, it's a ratio. So if one goes down, the other one responds by going up, just by ratio numbers.
Yes.
But what's happening is in a low VQ ratio, or sorry, a high VQ ratio, is that the perfusion shut down. So we have something stopping perfusion, right? So air can get in and out of the alveoli just fine, which means oxygen can go through,
Right.
but CO2 can't get out.
So 4 to 0?
No, I wouldn't say, I mean, that would be a severe,
A 4,
yeah, but
Just-
yeah,
just
4 to
so
0,
my-
4 to 0, yep,
Okay.
yep.
So 4 to 0 would technically be an increase because
VQ,
of the
yes,
gap.
increased VQ.
And then the decrease is like 4 to 5, 4 to 2.
Yeah, because now our V is low,
I'm tracking. Okay.
but the perfusion is just fine.
Yeah, I
Yeah.
still understand.
It's opposite. It's kind of opposite of what you think it would be, I
Because
think.
when I think ratio, I think
Yes.
like moving
But that's
to
what a
like
ratio
right?
is.
And so,
Yeah.
like when, in my mind, when I read it and you said increase, I thought, all right, if it's 3 and 6, when it goes up, it was 6 and 12. Like,
Yeah.
That's what I was thinking of.
Yeah. What'd you say?
Dead space is low Q, high V.
Yes.
Okay.
Yes. Now, am I going to test you on V's and Q's? No, I'm not. I'm not.
You understand, like, the
I'm not.
ratio where it's-
Honestly, I'm not going to test you on that. I'm not. There's more better things to test you on than, is this a high V or a high Q? I'm not going to ask you that on the test. But I want you to understand that. I do. You need to understand what's going on physiologically on these conditions because the treatment changes, right? It matters. The treatment matters.
In dead space, CO2 is unable to get out.
On dead space, they can't get out, yeah. Because it's the problem with the capillary, which causes a dead space, right?
Yes, because the top numbers are getting bigger.
An inadvertent dead space.
High VQ, your low VQ, high VQ, and the clock is the last thing. Yes.
What I told the insomniacs, if you weren't in here, I'm not actually going to test you on a high VQ thing. I'm not going to say, is dead space high or low VQ? I'm not going to ask you that. I just want you to know so you're aware of how to look at it as the purpose of it. You have to learn this material, but there's better things to test you on. So don't stress out about high or low. That's not overly concerning. Okay, it's just so you know. Okay, moving on to types of hypoxia. This is pretty heavily on the boards. They will ask you several hypoxia questions. You'll have to identify in 1 or 2 or 3 or 4 questions some of these hypoxias. So we'll start with hypoxic hypoxia. This is obviously a breathing problem, and it is also the most common type of hypoxia. Obviously, breathing problems are top of the list, respiratory stresses. It's defined as insufficient oxygen in the blood, which would translate to what on the ABG? A low PO2, a low partial pressure of oxygen, right? Does that mean the partial pressure in the oxygen is any lower than it should be? No, it's still 160 millimeters of mercury, right? Then why in the ABG is my PO2? There's a mismatch. There you go. There's a VQ mismatch. Remember, you're living in the VAC membrane, and you can see that the patient has pneumonia, and you can see that air is getting alveoli, but there's no gas exchange getting through because of the obstruction in the alveoli, right? So that's one type of hypoxic hypoxia, right? VQ mismatch, most common. What else? Depression of the respiratory center, right? What if they're on fentanyl overdose? That's going to cause them to go apneic and then hypoxic. What about airway suffocation, hypoventilation, obstruction? What about high altitudes? When we get to flight physiology, we're going to talk a lot about high altitude physiology, but just for today, is the FiO2 at room air here at the ground sea level, is that 21%, right? Would you agree with that? If I stand on a high mountain, 25,000 feet high, what's my FiO2? Okay, what's my FiO2? In other words, is the oxygen molecule any less effective at 25,000 feet than it is at sea level? It's not. It's just as effective. So the FiO2, the oxygen molecule, is still 21%. What's different, though? The pressure is lower at higher altitudes, meaning what happens to the oxygen molecules? They spread out. So here at sea level, I could sit here and go and breathe out oxygen all day. But if I'm on the mountain at 25,000 feet, I'm going over here and go, oh, there's one, oh, there's one. Right? I've got to move around because they're less available to me. Until finally you get to 50,000 feet, and in space, how many oxygen molecules are there? None, right? No pressure. It's a vacuum. So you got to get down way down low to sea level to breathe good. And that's what's going on at high altitude. So that qualifies as a hypoxic hypoxia because even though the FiO2, the oxygen molecule, is still just as good, there's far less of them, which means I'm getting less of them as I stand here in one spot. There's no longer 100,000 of them around me. There's only 10,000 around me. and it's going to be harder for me to get them. Okay? Do what?
get
Did you experience this? Did you go high?
Yeah, I had like those cans of like oxygen.
Yes.
Buy in like Colorado, and I had
Did you have to use it?
free.
Yeah, yeah. And you're hypoxic. It's not even your fault. But
I
yeah,
got a question about that. So I've heard of like high altitude training where
Yeah.
people will train high altitudes,
Yeah.
because once they come down, like their body's used to it or something.
we're going to talk about that a little bit later.
Oh, okay.
We are. We're going to talk about how that happens. That's good. Okay, that's it for hypoxia. Just one slide. This is all there is. I mean, it's just pretty easy. It's just a lack of available O2 from whatever reason or another. A VQ mismatch or too high, what have you. That's hypoxia. But the next one is hypemic hypoxia. That's a kind of difficult name. Remember it as anemic hypoxia. And so that helps you to remember a little better. What's anemic hypoxia? It's just a problem with the red blood cells. Anemia, hemoglobin, pretty easy. It's defined as a reduced oxygen carrying capacity of the RBC due to a low level of them, such as what would cause a low level of hemoglobin in your blood? Sickle cell dysfunctions the hemoglobin, or the red blood cells, right? But what would cause a low level of hemoglobin? Hemorrhage, right? Hemorrhage, bleed it out. So if I bleed out half my blood volume, I've got half less hemoglobin carrying oxygen, and so I'm anemic, which is going to cause a hypoxia, right? Or the hemoglobin themselves could be dysfunct. Could have a problem with hemoglobin. There's a lot of diseases that would qualify as that. Or you could have some kind of other dozen anemia that could cause this to happen as well. But generally, it's by hemorrhage, sickle cell, pernicious anemia, which is vitamin 12 deficiency, and then other types of anemias. So that's it. The only thing to remember about hypemic hypoxia is related to the blood. One of the hypoxias are related to the blood, but it's really related to the hemoglobin in the blood, okay? And then we have stagnant hypoxia. And just like you think from the name, stagnant means something is sitting still. Blood should be pumping around your body, but in stagnant hypoxia, something's caused it to not move. It's stagnant. So it's a blood flow problem. So what could cause this? Well, hypotension slows down the amount of available blood. Heart failure, same thing. Blood clot, DVT. The big thing you'll see on the board, which I've seen before, is high G forces. They'll mention high G forces and ask you what kind of hypoxic or what kind of hypoxia that is, and it's stagnant. What happens in high Gs?
Your body, well, it doesn't shunt, but it's gravity.
Right?
The forces are basically pushing the blood by gravity or centrifugal force or whatever is acting on it into your form. It's basically backflow or no flow.
Yes, it's backflow or no flow, right. So it's shunting blood, basically, from vital organs into the lower extremities, right? So away. And then it's keeping it there. So then that blood becomes stagnant. So even though your heart's beating, it's not moving blood because the G forces are overcoming the cardiac output of your heart, causing the blood to leave your brain and you leave your core. Your brain first, obviously, because you pass out before you die, right, in high G forces. And so your brain is very susceptible to these forces, and you're going to pass out because lack of blood flow to your brain, right? So I do remember that being a board question once. I don't know if it's still on the boards or not, but it was a board question. That's stagnant hypoxia. And then we have histotoxic hypoxia. And histotoxic is some kind of poison. So when you think of histotoxic, think poison. And this is an aerobic metabolism problem. It's poisoning in the cells. So it still involves hemoglobin, but to certain different ways that happens. It happens through cyanide poisoning, CO poisoning, right? What's the big deal with CO poisoning? This sometimes will be on the board, CO poisoning. What happens in CO poisoning that causes hypoxia? Yeah. What, CO has a 200 times affinity for the hemoglobin than oxygen does. If a hemoglobin is sitting there and it sees a CO go by or an O2 go by, it'll reach for the CO every time. That's disgusting. I mean, really, seriously. I mean, it should know better, right? It should know better. But it doesn't, right? It doesn't. It grabs for that CO. So when you breathe in CO and eventually breathe in enough, it's going to manually displace oxygen from hemoglobin and occupy that spot. Kind of sounds like a receptor. Kind of sounds like an antagonist, doesn't it? So CO is kind of like a mean bully that's going to go to the receptor on the hemoglobin, on the RBC, which is the hemoglobin, and occupy it and prevent something from occurring. So I guess that's why they like using CO on the board exam, but you'll see it there from time to time. So the big one is CO poisoning. You could also have malfunctioning parts of the bloodstream, blood cells, but that's histotoxic hypoxia. And that's pretty much it for the 4 hypoxias. Done. There's not much to them. Just a matter of you memorizing them. Will I test you on hypoxias? You better believe it, because you're going to see it on the boards. So I will test you heavily on those. Okay, any questions on hypoxias? All right, we're kind of moving on to some bigger things. We're moving on to that dreaded oxyhemoglobin association curve. I know already you're starting to shake a little bit, but don't worry, we're going to get through it. We're going to get through it. Okay, let's start with assessing oxygenation. How do we go about doing that? Well, a paramedic would say what? Put him on the SpO2, right? But you guys are better than that. So there are two ways we can do it. We can use the alveolar arterial gradient. There it is with gradient again. Or we can do something called the PF ratio. Now listen, I will give you a heads up right here now. Am I going to test you on the arterial alveolar gradient? Heck to the no. Heck to the no. I have to teach it though. You have to learn it. So let's go through the next 10 minutes. And just understand, if you don't understand it, it's okay. Okay? It's easy not to get, but I'm going to try to make it as clear as I can. What's going on is basically uses the premise of normal gas exchange, right? So we have pressures in the alveoli, would you agree? And we have pressures in the capillary, would you agree? And it's looking at the differences in pressures. Why we would use it? Because our chest x-ray is broken, or we can't get a CT. Because really what it's doing is it's answering a question. Is the patient hypoxic because of a VQ mismatch or not? We can figure that out with a chest x-ray, could we not? Pretty much. Or a CT scan, or a good patient history and assessment. But this is a tool that they use to rule out one thing or another. It's not used very often. It's only used in the ICU physicians. If you ask any ER doctor this, they're going to look at you like you're crazy. But it's really what it is. It's the difference between the partial pressures in the two spaces. Okay? There it is, my friends. It's a three-part equation. So in the alveolar gas equation, the P capital AO2 is alveolar, and the P little a2 is arterial. We're looking at the pressure gradient between both spaces. Would you agree? Alveoli and artery. Are we good so far? Okay, how do we go about it? First, we got to figure out what the patient's normal is, because it's age dependent. It's age dependent, believe it or not. So, let's use me. I am 50, I was born in 70. I'm 54. Yes, I'm 54. What's 54 divided by 4? Someone give me that number. Is it 13? Close. We'll say 13. Say 13. Add 4 to that. 17. So my normal AA gradient is 17. Just leave it at that. Okay. Now we got to find out if I got a problem. How do I do that? I need to go to the ABG. So I'm going to go to the ABG, and I'm going to get my PCO2. First, I'm going to take 150, and I'm going to divide it by the product of CO2 times 0.108. Let's say my CO2 is 35. So someone take 35 divided by 0.8, and then subtract that from 150. Yeah, what? 106, okay? Take that number and put it in here, then subtract that from the PO2. My PO2 is 80. What's the final value? And what was my normal, what was my we figured out from my age, what was my normal gradient number? 13. Okay, 13 and 26. Are those the two numbers we're looking at? Since they're close together, they're actually, I can prove now, because those numbers are very similar to each other, I don't have a problem right now with my current ABG values. I don't have a VQ mismatch. Of course, I know I'm not even short of breath, so that makes sense. If I gave you other values as someone in distress, like a CO2 of 80 and a PO2 of 40, wouldn't those change the values a lot? It would, and we're going to practice with that. So that's all it's doing. It's looking at the partial pressure of CO2 and the partial pressure of O2, which is measuring what? The partial pressure of gases in my body, right? And it's looking at the differences. So it's determining, do I have a lung problem or something outside the pleural space? If I had something outside the pleural space, then I would have a normal PF, or AA ratio like I just did. So what if my numbers are 17 and 26, but I'm very short of breath right now? What is that telling me? I have a problem other than a VQ mismatch. What other problems could I have that's not a VQ mismatch, but I'm still short of breath? I could have metabolic acidosis. What else? I'm bleeding out, and I've got no more volume, so I'm compensating by, I'm hyperventilating. Dozens of reasons, but I don't have, none of those are VQ mismatches, would you agree? Okay. So if I'm normal, I don't have a lung issue. It doesn't mean I'm not hypoxic. It just means that the issue I'm having is not a VQ mismatch. How do I know that? Again, because I actually looked at the gases in the ABG that's going to tell me that story. I could have a head injury, I could have a drug overdose, I could be on the mountain, right? If it's elevated though, if my number was 17 and he came back at 100, that's a big difference. Now that's proving that I've got some kind of VQ mismatch. I've got one of the 3 types of VQ mismatches. So let's practice again. Different values. Now, I did this all for you, so you don't have to do it here in class. You guys can go back and look at those numbers later. We just did a practice one, so I don't think we need to do any more unless you really want to. But here's an example of a patient with a PCO2 of 65 and a PO2 of 50. Would you say that, first identify the ABG. Who wants to do that? What's going on with this acid-base status? What's he in, according to this ABG? Is he acidotic or alkalotic? He's acidotic, okay? What's his CO2, acid or base? Okay, there's two acids right there, so we're leaning toward what? Respiratory distress. Let's look at the bicarb. Is that acid or, look at the bicarb. Is that acid or base? Is it acid? Okay, I probably should put it, I probably should put it, because now I got it, I should probably make that bigger. Now I've got to do a little order, but disregard that. Look at the O2. The O2 is 50. So am I hypoxic or not? What's the normal value of the PO2? 70 to 100. So I am hypoxic. So I do have a problem, but I don't know, according to this formula, if I have a VQ mismatch or not, right? So let's plug in the numbers. My numbers, we just figured out, was 17.25. 150 minus my PCO2 divided by 8 is 100, minus those, 68.75. Plug that into the bottom formula. 6 at 8.75 minus 50 is 18.75. So is 17 and 18 very similar to each other? I do not have a VQ mismatch. I can't, it's impossible. But I do have a problem. I have DKA. If you check the blood sugar, my blood sugar is super high or super low, whatever it is, and that's why I am the way I am. Okay, let's move on to the next example. So this patient is 66-year-old female who is not intubated but in distress. Her ER vitals are looking pretty good. What's wrong with her vitals here? She's tachypnic. What else? She is tachycardic. She's hypoxic according to the SpO2, and she's febrile. She has a moderate work of breathing. Okay, so she's in trouble. What about her ABG? What does that tell us? What's the pH? Okay, acidotic. What about PCO2? Okay, and the that should be, huh? Okay, we'll say the legal weight is. We'll say the PO2 is 41. So is that hypoxic? Okay, so let's plug her in. What should her normal be? It should be 20.5, and then since her CO2 is 26, we plug that in and we get 117. We take 117 minus 0.2, so we have 76. So now we have a big difference here, right? We have a 20 value and a 76 value. They're not close to each other, so now we have a mismatch. And that's all that it's good for.
So there's no actual, like earlier you said you're normal.
Yeah, there's no defining numbers.
So it's like, oh.
The only defining number is based on your age. So it's very age dependent. And a problem with this is you have to have the patient off of O2. They cannot be on oxygen to do it, which is another reason why you don't see it done very often.
Like in the hospital, and they take them off too to get a base.
Yes, yes. It's kind of like that, which is stupid, right? So is there a better way of doing this other than taking the patient off O2? Yes. So like I said, I've actually asked one ER physician. I said, what's the AA gradient? And he looked at me like I was crazy. And I never did it again. so he didn't know it. So anyway, it's in the curriculum. You've been taught it. Let's move on. All right, so what's better? So we have the P to F ratio. Now this is doing the same thing, but it's doing it, I think, a little bit better. Like I said, the major hurdle to the AA gradient is that it can be complicated to calculate, and the patient's got to be on room air. The PDF ratio, they can be on oxygen. Okay, that's the good news. The PDF ratio is used as a measure of the severity of hypoxia. We know the patient is hypoxic, but it gives us a scale of knowing how hypoxic he is, and also we can trend it. Aren't the best vital signs the vital signs that we trend? Rather than walking in and getting one look at it, that doesn't tell us a picture so much as if we looked at the trending of the vital signs, that gives us a much bigger picture on how the patient is compensating or deteriorating and how effective the treatments are. And so this is one of those as well, right? So we would trend this value. But it's really useful, especially useful, I should say, in ARDS, right? So when the patient is severely systemic hypoxic, and we're debating whether or not we should intubate this patient, this goes a long way to help us make that decision. It's a really useful tool. But we can also use it really for any kind of respiratory distress. But it's, like I said, it's mainly designed for those ARDS and those COVID ARDS patients. All right, so let's just blow up the AA gradient. We don't need it anymore. A normal PF ratio, which I will definitely test you on. The PF ratio I definitely want you to know. I will test you on. If a PF ratio over 300 is normal, we want it to be over 300. Normally, people live in around the 400s. So like I said, anything above 300 is golden. Now we do have a scale we can use to give us more definitive answers, right? Again, on oxygen. Now, that this patient, though, okay, so let's do an example. So let's say this patient here has a PO2 of 70. Is that normal? It's on the low end of normal, right? Okay. But he's on the ventilator at 50% FiO2. What does that tell me? Yeah, but why, if he's needing more than 21% FiO2, which is room air, and he's on 50% FiO2, then why is his PO2 only 70? Is that a problem? Why? Aren't we happy that his PO2 is 70? It's within the normal limits. Why are we concerned for this patient? Because it takes 50% to get him to the low end of normal. That's a problem, right? This patient is hypoxic, and maybe the therapy we're giving him now isn't enough. Maybe we need to consider increasing something to maybe get him more oxygenated. Maybe we need to increase FiO2 above. So we run the score on him to see about where he is, okay? So let's do that. Let's run the score. If his PO2 is 70, we divide by the FiO2. So again, the PO2 is your ABG reading, and the FiO2 is how much O2 you have him on, 50%. If we run those numbers, we get 140. Where in the scale does 140 fit? Moderate. Moderate, right? My patient is moderately hypoxic, even though he is on 50% of FiO2. I'm concerned for this patient. I'm concerned for this patient. Normally, if my PO2 is 80 with FiO2 of 21%, I should be 381. But for this patient, we can figure out if we take him off oxygen where he is. And this is the true value of the PF ratio, is this. So we can use the PF ratio to see what the PO2 would be if we remove the oxygen. If we remove the oxygen from this patient, says, screw it, you get no FiO2, well, 21%, I should say. If we knock him from 50 to 21%, what we would do is we would take his calculated PF ratio, multiply it by room air, and that's going to give you your new, what would your PO2 be if you put him back on room air. So that gives you an indication of really how hypoxic they really are. So throw that in the scale, what do you get? That patient would be severely hypoxic, right? Because all of us right now are in 21% of FiO2, but we're not severely hypoxic, right? But this cat, if we took him from 50 to 21, is going to be severely hypoxic, okay? So that tells us what? Critical care paramedics, what does that tell us? What should we be doing here? Well, if he's on the ventilator, so he's already intubating. Come on. How do we increase oxygenation on the ventilator? Let's increase some FiO2, what else? Let's increase some PEEP as long as PEEP is going to be useful here. And we're going to talk about in cases where PEEP can be useful, but PEEP can also be not so useful. We'll talk about that in vent. But as for now, we'll say we'll increase PEEP, we'll increase FiO2. Very good. And what else? I want to hear one more thing. More minute volume, get more breaths in, more tidal volume, maybe. What about underlying physiology? Let's identify what's wrong and see what we go about fixing it. What if he's having an asthma attack? Isn't that easily fixed? Is it better fixed by giving a breathing treatment than just increasing FiO2 and PEEP? Right? So that's where the critical care thinking comes in, right? What's wrong with my patient? What can I do to improve the condition? What can I do to reverse the physiology of what's happening? Not just increasing PEEP and FiO2, right? Let's get into the AC membrane, let's find out what's going on there, what we can do to fix it. Okay, what about this cat? 85 PO2 with the normal room air, he's 400, he's where he should be. That's a normal patient, that's where you and I are right now. This guy here, he has not ventilated on the ventilator. His PO2 is 70, it's on the low end of normal. He is short of breath. The crew put him on a nasal cannula at 6 liters per minute, and they just transported him. Said, you're good. When they got to the ER, they ran the PF ratio and found that it's 167. Where is he on a 6 liters on cannula on the chart? He's moderately short of breath, according to the PF ratio. Why? Why? You tell me. Why is he moderately short of breath? How do we know that? What's the PF ratio telling me? That 6 liters ain't enough, friend. 6 liters may sound like a lot, but that ain't enough. This guy needs more, and he needs more now, right? Okay, because he should be in the 300s to 400s, right, with he had normal values. So let's run him. If we run him on 167, run it times room air, if we took him off oxygen, we simply removed the nasal cannula from him, his PF ratio would plummet to 35, which would equate to what is a PO2? Definitely less than 70, right? So what do we need to do to this patient? Increase the oxygen, meet his demand. And we're going to talk about workup breathing here in a little bit and how important it is to recognize workup breathing and what it costs our patients. But we'll get there. But just so you know, this is how we can use PF ratio. So I got a homework assignment for you. When you're in the field, this whole next week, everybody needs to come in with the patient that they work the PF ratio on. Just come in and tell me what their PF ratio was and what you did about it to fix it, okay? And if you don't have an ABG, I got an answer for you in a minute. Is that what you're going to ask?
Well, that was a question, but another question. I just want to make sure this is dumb, but PO2
We shorten the PO2 because we know it's coming from the artery. Unless it's specified PVO2, it's arterial.
Okay.
If it's a venous stick, it'll definitely say a PVO2. But we shorthand into this because it's arterial. No reason to put the A in. I'm sorry? A good question. There you go. So you saw my next slide. If you don't have an ABG, you can estimate or approximate your PaO2 by the SpO2. There's caveats to that, obviously, right? Make sure you got an awesome waveform, right? Make sure it's accurate. And the only way we know numbers are accurate is by what? Waveforms. When you get to hemodynamics, we're going to drill that into your head like you wouldn't believe. But yeah, you got to have a very, 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 very good waveform, accurate. And also, your SpO2 is off by 1 to 2% normally anyway, right? So it's not a great estimation. It's a little bit of estimation. But take that chart with you, write it down, take it with you in the field. When you do your patient, you can estimate the PO2 from the SpO2. And you can find that online if you need more numbers in there. We can give you a bucket or something. That would be helpful.
Wait, okay, but to figure out the FiO2, if I give them 6 liters, how do you determine the FiO2 just by giving them just based off of the liters per minute you're administering?
Well, do you need an FiO2 chart? And didn't I give that to you already?
Did I see?
Good question. Here you are. So just so happen to have flow rates. So liters per minute approximation into FiO2. So you probably need that, don't you?
Yeah.
Okay, here you go. I'm glad you asked.
Unless I'm transferring a vent patient.
Yes, if they're not on a vent, you need this chart. So there you go.
Oh, there we go. That makes sense.
You ask and you receive.
We should start using simple math. I don't think you especially for like kiddos.
Yeah, I would not disagree with that. We're getting high flow soon. By next year, we're going to have high flow nasal cannulas for adults and peds. Super excited about that. Yeah, because our vent Hamilton T1s can do it. We just got to get the right circuits, and we're going to order them. And we also are going to order a humidifier and a warmer to go with it.
Oh, that's cool.
It's going to be awesome. We have Hamilton T1s. We're going to order the humidifiers next year. We don't have, but once we do, we can do high flow. Right. It'll be one on 64 and one on 80. And so either one can transport it to your scene if needed until we get more. I just think you guys should have one too in training. When you guys hit the road, have one on your truck. So maybe we should need to get 3.
You asked for it already.
It's in the budget, but nothing's been approved yet for the budget. I asked for 2, but they're cheap enough I can easily get 3.
Yeah.
No problem. They're so cheap. They're like $1,300 for the humidified heater, and the circuits are like $40 each.
Logistically, how does high flow to work straight?
Yes, it does.
Yeah.
And we're going to give you a formula to figure out how much is in your tank and how long it'll last.
Okay.
For sure. You'll learn that formula.
Yeah.
And you'll have to utilize that formula
All right.
to know how much O2 you have. It'll last for your trip. Yeah.
that formula in EMT school?
Now, you taught an EMT school, but I didn't learn an EMT school. I know that. I don't think I learned that in medic school, honestly. All right, are we ready to go? All right, everybody shake it off. Shake it off. Shake it off. Come on, shake it off.
Forget it all.
Seriously, no, don't forget it. Just shake it off because we're really going to get into the meat of things now. All right, guys. This is it. This is the main course. This is the main attraction. This is the final fight of the night. Shake it off. All right, the oxyhemoglobin association curve. It doesn't have to be a nightmare. We're going to get through it. Basically, it's a curve, right? Good start, right? That on the y-axis is measuring the oxygen saturation of hemoglobin. Because doesn't hemoglobin carry oxygen? Yep. And doesn't hemoglobin become saturated with oxygen and then releases oxygen, becomes less saturated as it goes through the body? Yep. So it's the measure of that occurrence and what the partial pressure of oxygen is in the blood. It's a relationship. It measures the relationship between those two values. To find them a little more better here in a minute, but that's what's happening on this axis here. This is not the SpO2. This is the saturation of hemoglobin. Okay? This is the percentage SA hemoglobin. Okay, the saturation. Now that correlates to what we put on the finger and get it as an SpO2. But this is measured through the blood. Okay? Both these values are measured in the blood. Okay? So basically, how much O2 is bound to each of the hemoglobin? Okay? The saturation of each hemoglobin versus the partial pressure of O2. Again, we see that a lot, don't we? Well, we're talking about respiratory, so we're going to see it a lot. So that's the partial pressure of O2 in the plasma, right? Are we good so far? This curve is a sigmoid curve. It's an S curve. Now, normally there would be values here and here, numbers. I don't put them on there yet. We'll get to that. There'll be numbers. but we're going to skip that. On this curve, I plotted 3 points. Let me see if I can explain it to you. On this point here, we have a low saturation of hemoglobin that's going to obviously correspond to a low partial pressure of O2. Would you agree? If my hemoglobin is saturated with like 10% O2, is my ABG PO2 going to be 10% or low? So, okay, that makes sense. Okay, let's move on to the next one. Now, this was the hemoglobin with very low saturation. But now, the hemoglobin has moved up the curve to the second point. What's happened between there and there? The hemoglobin has become more saturated with O2. So it's at the lungs, and it's getting saturated, or it's somewhere getting saturated with O2, right? So now the hemoglobin is 40% filled, which did what to my PO2? Did it raise it? So it raised it to 40. I'm not all the way there yet, but I'm getting there. O2 is continuing to bind to hemoglobin until we get to the final top. Now at that point, the hemoglobin is 100% filled, and if I run an ABG at that moment, my PO2 is 90. Does that sound good? Do you see the difference? The top of the curve, my hemoglobin is completely filled. The bottom of the curve, my hemoglobin is not so happy. Not so happy, it's underfilled. That's the first slide. That's all I need you to know, the first slide. You good? You're halfway there. All right, so again, saturation hemoglobin, PO2. There's a thing I want you to realize about hemoglobin. Hemoglobin wants to be filled with oxygen. Would you agree? That's its job, to carry oxygen to the cells, to the lungs, to the cells, to the lungs. As the hemoglobin is traveling from here to there, this curve becomes steeper. The steepness of the curve is representing the fact that the hemoglobin is attaching to oxygen is attached to the hemoglobin faster and better, because the hemoglobin wants O2 so bad that it's going to open itself up to it. And that's what this curve is representing. From here to there, it's like hungry. It's like grabbing it. Fill me up, because I need to be filled up so I can go to the tissues and unload it. But as it becomes more filler, it's like you when you're eating a big meal. As you get halfway through, you're like, oh, I don't know if I can finish this, but boy, am I ever going to do it. So you kind of have to push yourself a little bit to finish the meal. It's like the hemoglobin. Once they get to a point where they're almost all the way filled, they don't want oxygen as much, and so they're going to fill it a little slowly. But they're still going to fill it. But see how the curve flattens out from here? That curve, that part of the curve, you see the difference? Really wants oxygen to fill me. And then now I'm kind of full, I'm full. Now I'm really full. I can't eat another bite. Okay? So that's what's going on with the hemoglobin. And that's what we want hemoglobin to do. That's the job of hemoglobin, is to be hungry and then be filled and then be hungry and then be filled. Okay? So as the curve gets more steeper, this is representing O2 binding to hemoglobin, which means that word again, affinity. The affinity for oxygen to bind to hemoglobin is high initially, but then it decreases as it goes up. Okay? And that's all that slide is showing. Everybody understand that? Everybody like that? Everybody agree? Okay? The reason for that, it's the reason for the shape. So if you see a question like, why is the oxygen hemoglobin association curve shaped like this, and what does this part of the curve mean versus that part of the curve? Hence, you know why. Because the hemoglobin's affinity for O2, it's high here and less high here because it's already being filled to the max. There's a term called positive cooperability, and that's what that's referring to. The relationship between hemoglobin and O2, it's a positive relationship. They cooperate in that they fill it. But as they get closer to the point, the hemoglobin says, I can't do another bite. Can't have another bite. I'm full. Okay.
On the first slide, the 40%, is that from 0 to 40, is that the fastest? Or is it, you just pick 40%?
Yeah, exactly right.
So
It's going to fill very fast. Yep. But as it starts to fill more and more, the hemoglobin is going to go, I don't know, maybe I can take another one. Okay, I'll take another one, then I'm full.
Does that have anything to do with concentration gradient?
Sure it does.
It does?
Sure it does, yes. I mean, we're not calling it a concentration gradient, but really that's what's happening
Okay.
physiologically to the... Okay, so we talked about all of that. Okay, now let's put numbers in. Okay, here, now we got numbers. So again, this right here is a saturation of hemoglobin. It goes from 0 to 100% saturated, right? Here is the PO2 reading, right? Normal would be what? 70 to 100, would you agree? Okay, so let's say that my hemoglobin is at point A. How would you define that hemoglobin? How much saturation is it at, and then what's its PO2? Point A. So we would say it's 75% saturated, and that corresponds to what PO2? 40. That's what you're saying, right? Okay. Where do we see numbers like that?
The
No?
pressure of the oxygen inside the lung.
Well, of the hemoglobin at the lung, a hemoglobin at the lung is going to be pretty filled with O2. So where do you see 75% saturation of hemoglobin and 40%. Now here's the bad thing. Dr. Tan's lecture should have talked about hemoglobin, so you missed this part. I will cover it in a minute. Hemoglobin can carry 4 oxygen molecules, no more. When it leaves the lungs, if it's functioning properly, it'll have 4 hemoglobin molecules. When it gets to the cells, under normal conditions, it generally just drops 1. It doesn't drop all 4, believe it or not. And there's reasons for that, which we'll explain in hemodynamics a little more clearly. When it comes back to the lung, if it's dropped 1 or 2, sometimes they'll drop 2. The average is 75%, so some will drop 2, some will drop 1, some will drop none. It doesn't matter. When they get back, they'll either take 1 or 2, and they'll go back through, and round and round we go, okay? So what's happening here is that's at that tissues. If I could do an ABG right at the tissue level, that capillary tissue level, I'm going to get a saturation of hemoglobin 75% at an FiO2, I'm sorry, the PO2 of 40 at the tissue. That's good. That's good. It's going to correspond. So that's really where the hemoglobin is living, at those numbers throughout the tissue. When it's at the tissue, you say it both ways. When it's at the tissue, the saturated hemoglobin is roughly 75%, and its PO2 is 40. That's fine. But it jumps up because now it's traveling to where? The lungs. So what's point B? How would you read point B? I would read 99% saturated and a PO2 of what? 99, 100? Pretty darn good numbers, right? And that's where we want the hemoglobin to be. So that's what this curve is representing. It's representing the positive probabilities that we're not only representing how fast and how good oxygen attachment to hemoglobin, which we talked about, but it's also representing, it can be plotted. It can be plotted of what's happening to a functional hemoglobin when it's at the tissues and when it's at the lungs. When it's at the tissues and when it's at the lungs. That's going to matter when we look at acidosis. Because pH problems in the body are going to affect how the hemoglobin oxygenates the cells. But you first got to get this. You got to get the slides and understand what happens where hemoglobin is. Things are happening differently. You see that? Okay. So I'm going to ask Jacob Grayson. At what point shows increased affinity for O2? A or B? Which point has more affinity for O2? Point A? Yep, okay. Next question. Who hasn't answered the question yet? David, Kyle. Which point shows a saturation of 99 and a PO2 of 99? B, good, okay. And Kaylee, what does the steep part of the curve represent? Which is where? This part of the curve, right? That's the steepest part of the curve. What does that represent? Well, if there's increased affinity of O2, then what's it representing? Is it representing maybe that more O2 is binding to the hemoglobin than not binding? And you'd be right. So it has increased affinity and filling of the O2 of hemoglobin. Danielle, what does the flat curve, the top part of the curve, represent? Less affinity. Hemoglobin is being filled, but there's less affinity for O2. In other words, the hemoglobin don't want it as bad because I've already had 10 bites of this dinner and I can maybe get 2 more bites in. It wants it, but it's not as hungry as it was before, right? All right, which point represents hemoglobin leaving the lungs? In other words, at what point is hemoglobin leaving the lungs? And which point represents hemoglobin leaving the cells? Because that's the property values. All right, now the big question. Using the curve, describe for me what is happening when you go from point A to point B and point B to point A. Who wants to take that one on? Brett, you want to take that one on? So when the hemoglobin is traveling between here and there, what's happening to the hemoglobin?
Releasing oxygen throughout the tissues, and then as it goes back, it refills.
Okay, simple as that. That's where the magic is happening. That's where tissue perfusion is taking place. It can drop down here, right? It can drop down here. Why would it drop down there?
So you said tissue perfusion is happening between A and B?
Yep. Well, no. Tissue perfusion is happening at point A, but the hemoglobin is traveling back between point A and B to reload and offload O2, right? And if there's no dysfunctions, if there's no VQ mismatches, it goes no lower than point A. But if there's a problem, guess where it goes? It drops. And it can drop anywhere, all the way down, until finally we get to the point where we got carbon monoxide poisoning, and now we've got no availability of hemoglobin for O2. So what does that tell us? Saturations will be super low, and the PO2 will be super low.
Will it drop when you're like exercising? Will it drop past point?
No, that's shifting. We're going to talk about shifting. Right now we're talking about the points that the hemoglobin is staying on the line, but now we're going to create new lines. But first you need to understand this. Is everybody good? Everybody getting it? Not so bad, right? It's not so bad. All right, everybody say hi to hemoglobin. There he is. Say hi, don't be rude. Okay, there you go. All right, so hemoglobin is a protein that are found living on red blood cells, okay? They function as the transport of O2 to the cells. There are 4 polypeptide bonds, see the different colors, that form one molecule. On each bond, each color has its own iron group, and it's the iron that attaches to the oxygen, or the oxygen attaches to the iron. Does anybody have anybody in the family who needs iron infusions because of hemoglobin problems? My wife did for a while. And iron kept dropping for nothing. She kept going to get iron infusions. Well, when she was really bad for the iron infusion, she would be so short of breath, it was scary. It's like we would have to take her to the ER. And they're like, what do you want us to do with her? She needs iron. And then she'd have to make an appointment and go in to get iron. And so it's scary. She felt like she was suffocating because she was hypoxic because she didn't have the iron on the hemoglobin to take in oxygen enough. And so, yeah, so you got to have that iron group there in each polypeptide bond in the O2 molecule 1. So that's how each hemoglobin carries 4. Now, do you see how some of the irons are hidden and some are out? That's the shaping of it. There's 4 polypeptide bonds because the hemoglobin changes shape. As its affinity for O2 increases, it opens up the shape to allow the molecule to come in. And then when it's in, it closes shape again and kind of closes it in until it gets all 4, and then it becomes a certain state we'll talk about later, and then it's transported to cells. So it goes through shaping and changing. When this hemoglobin has an O2 attached, it's now called an oxyhemoglobin. You need to know that. And hemoglobin that's filled with O2 is now called an oxyhemoglobin. Oxy meaning oxygen. So like I said, each hemoglobin carries up to 4. So check it out. If it's got 3, it's 75% filled, which is why on the last plot I showed you, at the tissues, the saturation of hemoglobin was 75%. Simply saying that of the 4, there's 1 missing. Likely a tissue took it, and it needs to go back to the lung to get refilled. Did you know there are 250 million hemoglobin on each red blood cell? Which means each red blood cell carries how many oxygen molecules? Well, a little more than 1,000. There are 250 million. There are million. Who said 1,000? Was it you or you? Because whoever did loses a point on the test automatically. I thought it was you. I didn't see the lips move, so I'm not going to count it against you. But that's close to losing points. Yeah, math. The numbers are hard. Numbers are hard. 1 million. 1 million. Can you imagine? On each freaking red blood cell, there are 1 million oxygen molecules. It's you know what it is? It's amazing but frightening at the same time, isn't it? It's like there are like billions of oxygen molecules around me. Oh my God, you know, I can't even see them. That's amazing. So what happens is they come in, they inhabit, they move on. Life is good, right? But don't be fooled. Don't forget that carbon dioxide also rides hemoglobin back to the lungs. Carbon dioxide is transported 3 different ways, and Dr. Tanner talked about it when he goes through labs during his lecture. On the hemoglobin, like 10 to 20%. The rest of it gets dissolved in the plasma and is transported and attached to different things, and he'll talk about more. But carbon dioxide does ride hemoglobin back to the lungs. Some of it does. Okay? Now, this is what I talk about the shape shifting. So what I mean is infinity. I like to think of it as blowing up a balloon. So when you first start to blow up a balloon, is it easy or hard? It's hard, right? And so that's kind of what happens. Is as more, what affinity means is easier to ride on, I think of. So when I first, say my hemoglobin is empty, the balloon is empty, I got to push real hard to get air going. But once I get air going, right, that's what hemoglobin does. That's how it shape shifts. The first one getting on, it may be a little hard to get on, but once the hemoglobin recognizes that it's got a molecule on it, it's going to open up and go, and just open up that freely. And so, so it would be less harder for oxygen to bind to the hemoglobin because the hemoglobin molecule says, I want you, I want you, I want you. In other words, the balloon's going, which takes far less pressure to do that, right, than the initial push. So that's how the hemoglobin shapeshifts, okay? So it shapeshifts, it opens up basically to allowing more oxygen to hit it like you would be blowing up a balloon, okay? All right, that's the first part. You got through the first part? Pat yourself on the back. Pat yourself on the back. That was the easy part. The hard part is shifting. The hard part is shifting. If you think that was easy, you're right, that was easy. Hard part is shifting. Okay, so now we have to understand is that line is not static. It's going to move right and it's going to move left throughout your day. It just is. You know, if you're sick one day versus the other, you may be more acidotic than other times, whatever. It will move slightly. But when we talk about shape, we're talking about shifting, we're talking about major shifts. like major acidotic shift or major alkalotic shifts, to the point where now hemoglobin is affected, because hemoglobin, they're awesome people. You met one today, but they're so super sensitive. They wear their feelings on their sleeves, okay? Little things can really mess them up. And so this is what happens, is they get messed up with these shifts. So when we have a change in our pH, we know it can either be alkalotic or acidotic, right? If it's an acidotic shift, it's always a right shift, always. Acidosis is going to cause the shift to go right. We'll tell you what that means in a minute, but an acidosis is always going to make a right shift. An alkalosis is always going to make a left shift. It's going to shift the curve left. Again, it's going to matter what happens to the hemoglobin, but it's going to go right or left. Ultimately, the problem is that it affects the affinity of hemoglobin for O2. Remember, hemoglobin is in love with O2. I want it, ride with me all day long. I'm a little hobby horse. Get on me, we ride, we'll go see tissues, we'll go back to the lungs, it'll be a fun time. But in acidosis and alkalosis, the hemoglobin changes. Hemoglobin says, whoa, I don't know about you. Or he says, ooh, I want even more. So it changes. The pH, remember in Nate's lecture, pH is king? This is why pH is king. Right here. Right here. Because where's the magic happen? Tissue perfusion. With no tissue perfusion, we don't have a life. Okay, so this is a lot of information. It's a big slide, I know, but we'll talk carefully, slowly through it. Again, over here, this is your oxygen saturation of hemoglobin, and that's your partial pressure in the blood. The blue line is the normal curve, one we talked about all day. That's good, that's normal. What would the pH be in a normal curve? 7.35 to 7.45, so let's say 7.4. Your pH is normal, like us today. If I've got a pH of 7, would that shift my curve to the right? Yep, because that's acidotic pH. That means I've got hypercapnia, right? That means I've got a lot of acid. Acid in the form of CO2. If you don't know that, write that down. The shift is right because of acidosis, because of an acid. What's the acid? CO2 and hydrogen ions, but CO2. Write that down. I've got more acid in my blood than I need, or that I want even, and it's causing problems. I'm acidotic. For whatever reason, I'm acidotic. So guess what happens to the curve? Look at the red lettering. Red curve, red lettering. I've got a flattened curve. It flattens the curve out. What does that do to my hemoglobin and my oxygen? They're so in love with each other? Not anymore. What happens now is the hemoglobin have a lower affinity for O2, and O2 does not want to bind. It doesn't. The O2 says, you know what, I'm going to wait for the next hemoglobin. Next hemoglobin, you know what, I'm going to wait for the next hemoglobin. Next hemoglobin, I'm going to wait for the next hemoglobin. I'm going to wait for it has a hard time binding. It becomes really selective, I guess you could say. But conversely, it offloads easier at the cells. So it's hard to bind at the lungs, but offloads better at the cells. Now, why would that be a good thing in acidosis? Think about the types of reasons why we would be acidotic.
Too much CO2.
Okay, well, I'm talking about like what conditions would present us in this case? DKA. Or what about, I don't know, what about like a hypoxia, right? Where I need O2 at my cells. Or let's just say, to make it even easier, I'm exercising. I'm going through CrossFit. I'm exercising really hard. What are my tissues producing? Which is an acid, right? Which is doing what to the pH? And producing more CO2 as a result of the metabolism. It's anaerobic metabolism. It's going to throw off a lot more CO2. It's going to make me acidotic to a certain degree, right? It's going to shift my curve to the right to some point, right? But what do I really need at the muscle? Oxygen. So even though in acidosis, the lungs are saying, I'm not going to give you as much oxygen, or the hemoglobin's not taking at the lungs, good thing is, at the cells, it's unloading it freely, very freely, because the cells are hungry for it. I want it. So I'm not going to take one, I'm taking 2 or 3, because by God, he's making me do jumping jacks, and I need it, right? So I'm going to take it. And so that's what acidosis does. It does a good and a bad. Now, what about alkalosis? What about the green line? What if I'm alkalotic for whatever reason? My pH now is super high, 7.8. What happens there? The opposite. The opposite is the opposite side of the line, the opposite happens. At the lungs, it binds pretty easily, really easily. You start off pretty good, but when it gets to the cells, it says, no, you really don't need this. No, I'm telling you, you really don't need this oxygen molecule. No, you don't. No, I'm not going to give it to you, and it passes on by. It offloads less freely at the cells. That's a problem. That's a problem. Now, we can measure that. When we get to hemodynamics, we're going to talk about it in detail. We can take a catheter, put it in your lung, or in your heart, or just outside your heart, pull a blood sample out, and look at the saturation of hemoglobin right then and there. And we can see exactly where you are. And the lower you are, what does that tell you? What does that tell me? If I do a central venous O2 sample, and I'm reading coming back at 30%, or say 25%, well, what does it mean? That means my hemoglobin have returned to the lungs with how much oxygen? 25%, which is 1 out of 4. So that means the cells grabbed 3, right? What does that mean?
You're using a lot of oxygen.
Yes, there's a high demand for oxygen, right? Conversely, if it comes back high, then there's a low demand for oxygen, right? So we can actually measure this. We'll talk about more of that in hemodynamics. Okay, here's a point. Tell me what the plot on that is. It's on the blue line. What's the plot on it? Jacob, what's the plot on this? It's the red point on the blue line. What's the plot?
So your hemoglobin saturation is 99%.
Yep.
Saturation of VO2 is 110.
Is that good? That's really good. We're happy. Okay, next, what's this plot? What's the saturation on the acidotic plot? 90%. We're getting a little bit lower. And what's our saturation of oxygen? Okay, 100. Okay. What about this line, the green? Do you see what's happening? Do you see what's happening? What is that? What am I trying to demonstrate to you as far as the affinity of O2 to hemoglobin? So the green line is going to reach a higher saturation at a much lower partial pressure, right? Because of the high affinity for it. It's pulling it like crazy. That's what it's showing you. The red line compared to the normal is showing you that it has far less affinity for O2. And that's why the point is behind the blue line point. Is because there's far less affinity for O2, so the saturation is only going to be even less high, 90% saturation or about 85%. It's not going to get any higher, partly because it's not taking it on at the lungs, and also because it's giving out more at the cells. Do you see that?
Yeah, I thought the affinity was more based on the curvature. I thought like the more it slopes up,
It is. The steep part of the curve is infinity. I'm just saying at those particular points. I could have moved the points down lower. I could, I'm sorry, but I just wanted to let you know that you can see it in the curve, the affinity of the hemoglobin. That's what the points are trying to demonstrate, what I just told you. I went over like lead balloon. All right, moving on. So hemoglobin is severely affected by shifts. It literally alters the structure of hemoglobin. And we see evidence of that on the curves. The green curve is going to be more hyperdynamic because it has a greater affinity for O2. At the lungs, it's going to take on O2 because that's where O2 transfer happens, is at the lungs, right? And at the tissues, it has a greater affinity to offload, or greater possibility to offload it. Okay, now let's talk in detail about right shifts. Right shift is something called the Bohr effect. Now, I don't know if the board still has Bohr Haldane questions. I don't know if they do or not, that they may. You do need to know that the Bohr effect is how, we're going to define it clearly here, but the Bohr effect is what's happening on a right shift. Okay, this relates to the enhanced transfer of O2, because remember, in acidosis, remember this is the acidotic line, at the cells, the hemoglobin is doing what? It's offloading a bunch of O2. Okay? It's doing that, right, at the tissues because of the CO2 and the hydrogen, because of the acidosis. Because when the hemoglobin gets to that tissue, he finds himself in a highly acidotic state. Okay, when he left the lungs, he wasn't as acidotic. When he gets down to the tissues, due to the increased production of CO2, right, there was more acidosis there. Let's just say, right? So since he's there, then he's going to be affected by it, the hemoglobin, right? And so that's what causes, the name of the procedure that causes the hemoglobin to give off the O2 is called the Bohr effect. That's all that's saying. So we see this in acidosis conditions, in strenuous exercise, lactic acid production is an acid, high fevers, but what you will see on the board for sure is pregnancy. In pregnancy, mothers are already in a right shift. They're already in a right shift. I don't know how, doesn't mean their pH drops to 7.2, I'm not saying that. But their pH drops and they're in a right shift. Well, that and a million other things. And when we get to pregnancy, we'll talk about all that. So the pH is low, which increases offloading of oxygen at the cells. And this is why. And we'll talk about more in detail about pregnancy and mothers when we get to pregnancy. We'll wait till then to go dive deep into it. But it is a board question that mothers in pregnancy have a right shift. I have seen that question on the boards. It's a right shift. Know that for sure. Conversely, it's not the Bohr effect. When they're acidotic, though, it's called the Haldane effect. It's called the Haldane effect. And this is what happens. Now, this relates more to CO2, right? This is what happens when the CO2 release The way the CO2 releases is because the way the O2 is binded. And also the pH at the lungs is as alkalotic. So this is due to a high pH. So you see this in alkalotic states. What are alkalotic states you would see it in? Vomiting, diarrhea, hyperventilation, CO poisoning. And this is a board question as well. Fetal hemoglobin have a left shift. Fetal hemoglobin have a left shift. And we'll talk about that more in detail later. But just note today, fetal hemoglobin have a left shift. Why? There are 3 reasons why for Haldane. The pH is high, which increases offloading of CO2 at the lungs. We haven't mentioned much about CO2 in all this, but CO2 still plays a factor. And in alkalotic, we release more CO2, but we hold off on giving the O2 at the tissues. So there's 3 things out there I want you to remember on the Haldane. CO2 plays effect in alkalosis, not so much in the acidosis. So highlight that, circle it, put a star next to it, mark it with a B and whatever, okay? So this is just an overview. Let's say the hemoglobin starts at the lungs, right? He's going to go down. My hemoglobin is going to be filled with 4 oxygen molecules. It's going to then go to the cells. It's going to drop 1 or 2 of them off. Hemoglobin is going to go around and go to the lungs. Okay? So let's start with this part here, with the lung to the tissue. The hemoglobin are in a relaxed state. You need to know that. Hemoglobin are in a relaxed state. Relaxed meaning open, right? Because they're going to the tissues. They just left the lungs. So they're in a relaxed state. They've been filled up. They're in a relaxed state. There's a high affinity for O2 because the hemoglobin started in the lung, has a high affinity for O2. It's being filled, so why would it be all clamped up? It's going to be open and relaxed because it's trying to be filled. It's shifting. It's shifting its shape to fill it, but it's in a relaxed state because it's taking on O2. And as it travels to the lung or to the tissues, it's going to be like that, right? So the Bohr effect refers to the shift in the curve caused by changes in the concentration of CO2 and the pH, basically acidosis. And since a low pH encourages O2 release, the hemoglobin will release the O2. Okay, so all that basically says. Conversely, as the hemoglobin drops off 1 or 2 oxygen and it travels back to the lungs, it's more in a tense state, has a low affinity. Now, why would that be important? Why would we want hemoglobin to be in a tense state at the cells and not want to give off O2? Why would that be a good thing? I mean, I'm sorry, not take on O2. It gives off O2, but now why would we want it to be tense and not to take on O2 at the cells? Why would that be a good? Because isn't there O2 in the plasma at the cells? It's floating around. So it just released O2. Why would it be a good thing for the hemoglobin to say, I don't want that O2 back on me? So it can remove CO2 and?
So does it take from a cell?
Yes. So if a hemoglobin travels down to the cell filled with 4, it releases 1, then it jumps back on. Is that doing any good? No. So the hemoglobin says, get off and don't come back on. This was a one-way ticket. That's good. We don't want hemoglobin to say, whoever wants to come can come whenever you want. That's not what hemoglobin does. And so that's the point I'm trying to make. It's in a tense state at the cells, so it repels oxygen. Says, you came on once already, Tiggai, now go home. See that cell right there? That's home. Go home. Right? So it doesn't jump on the hemoglobin again. Okay? That's the Haldane effect. Okay? And that also facilitates what? To jump on the hemoglobin now? CO2. And that's why, when we go back to the previous slide, Haldane effect includes CO2 because the hemoglobin is at the cell and needs to take on the CO2. Now the hemoglobin says, ooh, I see a CO2 over there that looks like I think is cute, or she's cute, whatever. Come on the hemoglobin, right? And it does. Okay, so am I going to test you on Bohr Haldane? I don't know, maybe not, we'll see. But do you understand how it works? We're halfway there. Do we need a break? Do we need a brain decompression, or are you guys doing good? Okay, go pee. Decompress your brain. We'll get through it. I promise you we'll get through it. How you doing, dude? All right, you doing good?
Yeah, I'm trying.
All right. If I got to go back through a slide, let me know, and I'm happy to do so. We got to understand it, because we won't go through this again.
My one question is, maybe I missed it in the first day. How do you go to find like the recordings?
I'm going to give you that information at the end of class. Yeah, there's a website.
I think that would help if
Yeah.
I could just go ahead and
Yeah. I don't think anybody's ever done this before. It's actually pull a hemoglobin in the room, and it's interview them. Okay? So spotlights are on. The tapes are rolling. Let's ask hemoglobin. I do a poor job explaining this. Let's see what he would say. Okay, if we asked him, hemoglobin, what's a right shift? And hemoglobin is going to say a right shift is due to acidosis, which is simply going to cause me to shun O2 at the lungs, but really extra special unloaded to the tissues. That's the basic gist of a right shift. The more the shift is, the more that's going to happen. The lower the pH is, the more that's going to happen. So finally, we're so acidotic we die for a lot of different reasons. One of them is because we're hypoxic. Because of a right shift is going to cause O2 eventually not to be loaded at the lungs. I don't care how much you're giving away at the tissues. Eventually, something's going to break. What about, okay, this is how I remember it. This is how I remember a right shift. R for right, R, they're in a relaxed state, and R, they're releasing O2. So to me, that's how I remember the difference between a right and left shift, the R's. R for right, R for relaxed, R for relaxed and release. Now, what about a left shift hemoglobin? Well, that's from alkalosis. That's going to cause me to eagerly accept O2 at the lungs, but at the tissues, very stingy. I don't want to give it up. I got my bling. I'm going to pass on by with it. I'm not going to give it up. It's as simple as that. That's the Haldane effect, including CO2, though. I add CO2 to that slide. I forgot to do that. Haldane effect is the offloading of CO2 at the lungs as well. There's increased offloading of CO2 at the lungs. Oh, is it? I said it? Yeah. Oh, okay, never mind. There it is. Okay. So this is left is a very tense state. Release the CO2, but holds on to O2 at the tissues. Just memorize those two slides and you'll be good. Okay, let's review a right shift. So right shift is acidotic. Would you agree? What else is a right shift? Well, it decreases the affinity for O2 at the lungs. We said that already. It's a giver. So I like to think of it as when you give somebody something, use your right hand. Right hand is like the symbol of giving. So I used to think to give O2 to the cells is a right shift, right hand. Another way to remember it. So giver of O2. Some things we have not talked about yet, which are very, very important. On a right shift, we're going to have a low pH. We know that, right? It's acidosis. But as a result of that, we're going to have high CO2, obviously, but also high temperature, and we're going to have high levels of the molecule 2,3-DPG. We'll talk about that here in a few minutes. Just know you have to memorize that. You have to know that. So low pH equates to high CO2, high temperature, and high levels of 2,3-DPG molecule. And then finally, pregnant moms have a right shift. Okay, this is a normal occurrence because of the placenta. She's got to share oxygen with the placenta. Okay, and so that's primarily why. But we'll talk more about that in pregnancy when we get there. Are there any questions on right shift? Because we're done with shifting, right shifting. Your head's still there. You're checking, I know.
No,
Oh, I'm sorry. Okay, what about left shift? Left shift is always alkalotic. When we get to pH of 7.60, then we're really alkalotic and we're going to have serious issues. Again, we know all that. It's O2 stingy at the cells. It doesn't want to give it up. Very stingy at the cells. It's opposite. It's got a high but low levels of CO2, low temperature, and low levels of 2,3-DPG molecule. And you see this in fetal hemoglobin. That's it. That's it. That's right and left shift. Is everybody good? Sort of. I know I don't expect you to get all of it like right now. But, okay, the review slides? Okay. Okay, so let's talk about 2,3-DPG. DPG is the diphosphoglycerate molecule. It's produced by your RBCs for a specific reason, and that's to assist in oxygenation, okay, because we need every little bit of help we can get, right? It helps hemoglobin to give more oxygen to the cells in a right shift. So in a right shift, that's why the body makes more of it. It's made on demand. The body knows the recipe, and it just whips out the recipe and makes more as it needs to. It's a good thing. It helps the cells get more O2. Okay, it's useful in higher environments when there's no acidosis, because remember, in high environments, there's no acidosis, but they're hypoxic. Would you agree? So they're not in a right shift, are they? So it's still going to release. The body will still release 2,3-DPG in these environments to assist the body, because it recognizes, even though it's not acidotic, it is hypoxic. And the body will release 2,3-DPG to allow the hemoglobin to release more O2 as if it's in a right shift. You understand that? So that's part of helping your body compensate for these high altitudes or states of low oxygen in the air, whatever that may be. Okay, it is released in pregnancy to help mom out, again, to the placenta, so mom will release it as well because she has a lot of almost said love to share, a lot of O2 to share, right? She's got a lot of O2 to share. She's got to feed her own body, and she's got to feed the placenta, right? Now, the body, maternal mother makes 20% more blood, which is 20% more hemoglobin, which is 20% more oxygen carrying capacity, but still, the body releases more 2,3-DPG and to help out for that. All right, so let's practice labeling a curve. Shall we? I think we shall, because I said so.
I think we should.
So here's a curve. Well, that's a personal problem. And I'm going to tell you what's a label on it, but I don't want these back. These are yours to study from. All right. So to find the x and y axis of the curve, what is supposed to be on the axis? What is the term? Define them, the x and y axis. What is it measuring on the x and y axis? Yeah, right linear curve. Yeah. This is a group activity, kind of like in preschool. Don't look at your notes. I just told you. Okay, isn't the y-axis the percentage of saturation of hemoglobin? So that's the percent HGB, which is the percent saturation of hemoglobin. That's your y-axis. Your x-axis is the PO2, which is the partial pressure of oxygen in the blood that's measured through the ABG. Okay? The next one. Write high affinity for the side that has a higher affinity for O2. Is that the acidotic side or the alkalotic side? Yep. So write it on the left or the right side of the curve. What is it, a right shift or a left shift? You look at your notes, that gives a higher affinity for O2. Okay, left shift, okay. Okay, what side has the lower affinity for O2? The right, okay, put that down. Right, lower affinity on the right side. Everybody caught up? The first three? Okay, write low pH for the side that has the lower pH. Is that acid or alkalotic? That'd be right, yep, because that's the acidotic side. Good. And then write low 2pG on the side that has a lower 2pG. Would that be acid or alkalotic? Remember, 2pG is giving oxygen to the cells. If it's lower, would that be acid or alkalotic? That'd be left, that'd be alkalotic. Remember, the alkalosis wants to hold on to the oxygen at the cells. Everybody caught up? I don't think you are. Okay, I'll wait. We'll go through them again. We'll go through them once and we'll go through them a second time. Okay, write Bohr and Haldane on the respective sides. So which side is the Bohr effect and which side is the Haldane effect? Bohr is right, which is the acid side, and no, right, which is at the lower side. A right shift is lower. A left shift is higher. So a Bohr is your acid side, the lower side, the right side. Haldane is the left side or the higher side of the curve. And then finally, write less offloading on the side that offloads less in a severe shift. No, not the left. Offloads less. I'm sorry, you're right, it is left. Whatever. Someone said right, I know. All right, do we need to go through this one more time? Make sure you guys got them right? Yes? No? Are we good? Can we move on, or you guys want to go through it again? I need an answer. Move on, all right. Okay, so let's play a game. Let's diagnose the shift, okay? We have a 74-year-old female who presents to the ER with a 4-day history of SOB, productive cough and fever, okay? Here are her labs. Now, someone tell me, who haven't I called on yet? Elizabeth, have I called on you yet? Yeah. Okay, who haven't I called on yet? Tell me, because I know, I'm just pretending I don't know.
No, I do have.
Elizabeth?
Yeah.
Well, we haven't had labs yet. Who knows what labs are off here? Russ, tell us what labs are off. No, wait a minute. Platelets are within normal limits.
Well, I actually the ABG is on the acid side there.
No, just the labs. So are the red blood cells within normal limits? 5.5, yes. Yes. Is the potassium normal? Yes. Is the white blood cells normal? No, they're high. Okay, so we have a fever and increased white blood cells. What about sodium? Is that good? That's okay. The platelets are good, but the lactate is high. Okay, so we'll fast forward to that. What about the ABG? Who wants to take on the ABG? Russ, tell me what's going on with the ABG.
So their pH is on the acid side, PCO2 is on the acid side, so it's a metabolic acidosis. It's not being compensated, or partial compensation.
It's not being compensated or it's partially compensated?
Sorry, no, not compensated, I'm sorry.
Yeah, so,
it's not compensated.
okay. So Kaylee, he called this a uncompensated respiratory acidosis. Is that what you said? What'd you call it?
Yeah, I'm sorry.
Okay, Kaylee, is that correct?
Honestly, I was trying.
I said, was everybody done? Okay, well, wait, go ahead. Sorry. Tyler, is he right or wrong? He's right. You're absolutely right. So that is an uncompensated respiratory acidosis. Uncompensated because the bicarb's not helping. Is it helping? No. No, it's not helping because the range of normal is what? 22 to 26. So it hasn't moved an inch. It's right in the middle, matter of fact, to add insult to injury. So it's not helping out at all. But the pH is still low, so nothing's compensating. So it's an uncompensated respiratory acidosis. Why? Probably because this is an acute situation, right? If this patient has had pneumonia for 2 weeks, would we see the bicarb change?
Yes.
We would. Which way would we expect the bicarb to go?
Up, low.
Low, because we're burning bicarb. So we would expect the bicarb to be 16, 17, right? Because we're burning bicarb. All right, what about the vital signs? What's wrong with the vital signs? SpO2 is low. What else? They're tachycardic a little bit. They've got a fever. Okay, okay. All right, so no giving this information here. What shift do we have? What tells you that it's at a right shift? What else? What, CO2 being high. Good. What else? Temperature being high. What else? And that's pretty much it. So what's happening? Why do I hear a conversation? Who's talking? Why? Okay. Why? What's happening at the cellular level here with hemoglobin?
It's not getting gassy.
Well, tell me exactly what's happening with hemoglobin.
It's not grabbing up to
Okay. It's giving it away. However, is that fixing the hypoxia? It's trying to, but is it ever enough? No, because we put a lot of patients on. So what does this patient need?
Oxygen, antibiotics.
Oxygen, antibiotics, right? We have to identify the underlying problem and fix it. So antibiotics and oxygen help hypoxia to help out the acidosis, right? To help reverse the acidosis. Even though the right shift is giving more oxygen at the cells, the lungs are holding it back. So whatever oxygen we can get on the hemoglobin at the lungs needs to be what? Hyperoxygenated, right? So that's why we provide oxygen, right? To get those oxygen cells hyperoxygenated, more of them there, right? More oxygen molecules there to jump on the hemoglobin that are having a hard time taking on oxygen, right? So that's really how we're helping the patient there. And then, of course, we're underlyingly fixing the pneumonia with antibiotics.
We're basically saying you're getting oxygen at the lungs, but not enough, even though it's offloading that to the tissues.
Yeah. So we're helping the problem. The problem is the lungs aren't taking on the oxygen, hemoglobin at the lungs. So we're helping that by increasing FiO2, right? So we're providing a lot more oxygen than you used to see in there, so some will get on the hemoglobin after all, because of the high concentrations of O2. So that's how they're getting the oxygen to the cells from the lungs, even though they're in a right shift. So without oxygen, though, is the patient going to get better or worse? Right. So maybe with antibiotics they'll recover, but we still need to provide oxygen at this time for that reason, because they're in a right shift. So just understand that pathophysiology. And then I think that's what I put here. So here are the clues. Yep. Low fever, high CO2, elevated lactate. And we just talked about all that stuff. Okay, good. We already took a break. Let's do a Kahoot. Oh, I'm sorry. You don't see what I'm doing. I'm on the wrong slide. Yeah, we talked about all that. Okay. All right, let's do a Kahoot. You want to do a Kahoot? Who wants to do a Kahoot? Let's do a Kahoot. Come on. This is a team Kahoot.
So we have one person on our team?
No, one person for every team will log in. And the team that wins, oh, I'm on the wrong computer. Sorry. The team that wins gets an extra point in the final, on their next test. Oh, I keep doing that. And so far, the only person that's done that is Team Insomniacs last week. So we're looking for the other teams to step it up, all right?
We win twice, it's over, yeah.
All right, there you go. There's your code. One per team.
Next time you spell sanctuary.
Can you put your name in? I'll let you put your name in there. Will it?
Yeah, you put your nickname.
You can put your name in there? Okay. Yeah, put your team name in. There you are. Cool glasses, dude. I like it. Waiting on the other teams. Not like we got all day.
We're almost there.
Oh, come on, other team.
There you are. All right, underpressors and training officers. Oh, you guys are playing too? All right, all right. That's cool. All right.
Our team name is too long, so
Still waiting on underpressors. No, we're waiting on mitochondrias. Mitos. We'll call you Mitos for short.
Mido, yeah, Mido's gonna have to work.
All right. Come on, Mitos. There you go. All right, you ready? There we go. All right, get together as a team, collaborate. Don't let the other team hear you. All right, good job. That was quick, too. Insomniacs are the fastest. Good job, size. All right.
I think I was last, though.
Training officers. Flexing some muscle back there. I got somebody. All right. Yeah, that's true. That's true. All right. All right, good. Very severe, right? Pretty severe. All right. That changed nothing. All right, moving on. Wait on somebody. Oh, there you go. All right, fluctuation in hydrogen ion, which is pH, right? Remember, hydrogen ions are, all right. Under pressures, lead is increasing, very good.
When at the cell.
Oh, true, right? They're tense at the cells, why? Because we don't want them to take on O2, right? So they're going to be a little resistant, they're going to be tense. That may have changed things. Yes, it did. Do you guys know how the phone works? I'm just wondering. Is it an issue with the phone? Okay, it is decreased, yep. All right, doesn't want to take it on at the lungs. Okay, changed a little bit there. We are, I think we're halfway through, almost over halfway through.
Yeah, how am I supposed to read that? I am sorry. You said see, I don't think it was see.
It goes by colors, yeah. All right, everybody got that, very good, very good. All right. Okay, so true, right? Yeah, in a pulmonary shunt, perfusion is exceeding ventilation, right? There's a low VQ ratio, and that in asthma would be associated with that as well. Well, really, insomniacs are in the lead because they can't get extra credit on their test. So, just want to say that. So there's a really tight race. The mitochondria need help with using a phone, I think. I know you're smarter than this, but
Technology issue.
it's a technology issue.
That's why.
All right, didn't you get anybody there? Good job.
If they get one wrong, we can still beat them.
2 more.
You're right.
All right, yeah. So in high ventilation, that means perfusion is decreased, right? Someone did increase Q, that's perfusion. All right, last question, I believe. Definitely, I thought I'd get you there, but everybody did it. All right. There's no points for consistency, unfortunately. So it looks like insomniacs, who are you guys, right? Again. Wow. There's no half points, sorry. All right, good job. Everybody did well, though. Everybody did real good.
We get the easiest version of the test, right?
I don't know if I know how to answer that. All right, we got, how many slides we got left? Maybe another 30 minutes? All right, so we're done with my lesson for today. I'm going to try to eke into Dr. Tan's lecture and kind of set him up for what he's going to be talking about tomorrow or next week. So how would you define respiratory failure? Well, it doesn't matter because the answer is on the board, okay? So there's a lot of good answers for it, but really, technically, they're really looking at a PaO2 less than 60 with a corresponding SpO2 of 90. And look, this is important because there's going to be times in a critical care transfer, and these two can agree. You'll walk in there like, why the F isn't this patient intubated right now? I mean, seriously. They look like crap. They should have been intubated an hour ago. What is going on? And for you to go to the doctor and go, just intubate them, when you can have some more information to back that up. And so this is what that is. This is what they go by, and this is what you should know and go by too. And you can walk in and go, I'm looking at the last ABG, and this is this, and this is that, and this is this. Then let's intubate the patient. Let's get this done. So this is generally the parameters, and hopefully Dr. Tan agrees with this because he's seen the slide. If he doesn't, he'll change it when he sees you tomorrow. But my parameters are PO2 less than 60 with a corresponding low SpO2, a PCO2 greater than 50 with an acidotic state, pH less than 7.35, and a PF ratio less than 300 with a patient on oxygen. If any of those criteria are present, you're pending respiratory failure if not already in respiratory failure. At that point, we need advanced adjuncts like BiPAP, intubation, something.
Did you say any or all three?
All three.
All three?
Oh, no. It could be anyone. It could be anyone. But the more you have, the better. The more, the better. Now, if you need to estimate the PaO2 and you don't have an ABG, you can do that. You can take the FiO2 that they're on and multiply by 5. Has anybody heard that equation before? So here's an example. Patient number 1 is on a nasal cannula at 20% of FiO2. Times that by the 20% times 5 gives you a possible PaO2 of 100. How accurate is that? How accurate is that, guys? Do you know? I don't think it's very accurate, but it's something I got to teach you.
I do have a question on the PF ratio. That you're saying this patient needs higher intervention, not necessarily innovation, right?
Higher intervention.
Okay.
Yes.
Yeah.
Yes. Not necessarily intubation.
Just
Yes.
to be clear on that.
Yes. Like BiPAP, CPAP, intubation. Don't have to be intubated, but the worse they are on this scale, then we're getting there. So it's also going to be used as a trending thing. But I'm going to walk in, I'm looking for these things. If I feel like my patient needs to be intubated, I'm looking at these criteria. And so that's how I can prove to you my patient needs to be intubated. Not just, my patient needs to be intubated because their SpO2 is 90%. Right? We're critical care paramedics. This is our standard. So put a star, put a flag. You're raising a standard. This is what you go by. I want you to know this by heart. I need you to memorize this. That's what I'm saying. Okay, let's talk about workup breathing. Okay, we learn about workup breathing, right? PALS talks about workup breathing a lot with the little kiddos. Why? Is it because it really, everybody say really matters. Workup breathing costs something. When a patient has an increased workup breathing, there's a price they are paying. Now, whether the price is big or small, we don't know that yet, but the idea is that they're paying a price that eventually they won't be able to afford. You remember that old Top Gun movie, Top Gun 1, where they're standing in front of the man's office and he tells Maverick, son, your ego's writing a check your body can't cash? That's what workup breathing is. They're working until finally they just can't do it anymore. So you may think that they're compensating for whatever condition they're in. They have increased workup breathing. I'm okay with that. They're compensating. Well, yeah, they're compensating, but they're also paying a price. A paramedic would say, I'm just going to put them on O2. I get their pulse oximetry up to 95%. I'm happy. A critical care paramedic would say, let's put them on O2, but we need to really figure out what's going on because this is costing them. And eventually the price is going to run out. And they're going to run out of money to pay for it. And then I got a bigger problem. Okay, there's the difference I need you guys to know. So workup breathing is energy, the amount of energy that the body exerts, and the rate of O2 consumption that's needed by the respiratory muscles to produce enough energy for ventilation and oxygenation, right? So workup breathing is really the product of several factors, respiratory factors. Compliance, we're going to talk about these in a minute, resistance, and elastance in the respiratory system, okay? These are very important terms. Compliance is referencing to lung expansion. If I say my patient has high compliance, that means what as far as expansion goes? They have great expansion. If I say my patient has low compliance, what do I mean by that? They have poor chest expansion. Resistance. What I mean by resistance is airflow. Airflow resistance. There are several types of resistance. We're going to go into detail here in a minute, but generally talking about airway resistance. So something's impeding airflow. Elastance. Elastance is lung bounce back or spring back. It's important to get lungs to inflate, but it's just as important to get lungs to come back. And if a patient has high elastance, does that mean that we're having a hard time getting them back or easy time getting them back? If they have high elastance, it's going to be harder to get them back. Versus someone with normal elastance, then it's going to be a little easier to get them back. Okay, so a normal workup breathing has an oxygen muscle requirement of 2%. So right now, your respiratory muscles are eating 2% of the oxygen you ingest. Just 2% in normal workup breathing. However, a severely increased workup breathing can demand up to 50% of your total oxygen consumption. Remember, your lungs are one component of a body system where every piece of the body needs oxygen. And now if you're in severe shortness of breath and a severe workup breathing and you're taking half of that demand or half of that being given to you, what is that doing to your body? Depriving the rest of it of some oxygen, right? So that's how you become systemically hypoxic, right? That workup breathing costs the patient something. It costs them the O2 that should be going somewhere else. But now it's going straight to the respiratory muscles, the diaphragm, the intercostal, and the accessory muscles, to sustain that the rate that they're breathing and the depth of what they're breathing at. So in restrictive lung diseases, it's a little different, such as ARDS, pneumonia, fibrosis. The workup breathing is increased because of decreased lung elasticity, right? That's compliance. In obstructive lung diseases like asthma, we see more workup breathing is because of increased airway resistance. Or we could have non-lung involved diseases like DKA, which is asking for a high metabolic breathing rate, right? So there's a lot of different reasons why this would happen. So basically, workup breathing is defined as the ability of the lungs to overcome the resistance and compliance issues of the lungs. So we have compliance, resistance, which could be pulmonary and airway, and elastance. Okay, so if an increased workup breathing increases O2 demand in the body, then which parts of the body are demanding more oxygen to keep up with the consumption, right? And so we're talking about the respiratory muscles here, the diaphragm, the intercostals, the accessories. So a paramedic would say, well, my patient has respiratory distress, right? So that's a term I want you to stop. It's okay to think that, but I don't want you to say it, right? I want you to say they have an increased workup breathing because it's a difference. They're in a fight, respiratory distress and increased work of breathing. They're in a fight, okay? They're supposed to mean the same thing, but they don't. To me, respiratory distress is an observation. If I look at you and I go, you're in respiratory distress, doesn't matter why you're in respiratory distress, I'll put you on oxygen and transport you. And now you're breathing better, I've done my job. Versus an observation and an understanding, using the mind's eye. So work of breathing is using understanding of getting that little guy down the AC membrane and seeing what's going on down there and understanding what's going wrong. We think we do that in the field with like an asthma attack. We give them albuterol. That's doing that. But I'm talking about on critical care transfers, when your patient's been in the ICU for 3 weeks, and now they're being transferred to ECMO or something, right? And we have to manage that person on a vent until they get to ECMO. Okay, it takes a little more than just saying, well, they're on the vent at 50% of I2, let's go. We have got to understand these things. And so work of breathing costs something. We have to understand that. So what's the cost? A normal patient with a respiratory rate of 16 and tidal volume of 450 has a minute volume or a minute ventilation of 7 liters a minute. Do you guys know what the normal rate or range of minute ventilation is for a normal patient is? Is it 6 to 8 liters per minute? Does that sound about right? We'll go over that in a vent, but it is. So that's right down the middle. That's perfect. But did you know that the demand can be as high as 30 to 50 liters per minute in a patient with severe work of breathing? 30 liters a minute. If I put the patient on 6 liters by nasal cannula, have I met their demand? Is 30 and 6 the same? Nope. If I put my patient on a non-rebreather, 15 liters per minute, and they're demanding 30 liters a minute, am I meeting their demand? Not necessarily. So there are a lot of ways some people can get, their work of breathing could be so hard and so heavy that we're going to have a hard time meeting their demand. But we'll talk more about that. Okay. So let's break down these terms. What is airway compliance? Airway compliance, again, is the ease at which the lungs and the thorax, let's not forget about our chest wall. We can have a problem with the chest wall compliance too, can't we? Right? What kind of problems? What can be wrong with our chest wall that would affect compliance? No, our chest wall, our physical chest wall. A burn, a circumferential burn. We're not going to get no compliance there. What else? Flail chest, broken ribs. Ever break a rib? Or see someone break a rib? It's very painful. The poor compliance as a result of it. They get pneumonia sometimes because they just can't get air in and out of that area. So we got to keep that in mind. Compliance is related to both the lung and the thorax, right? So we can't expand. Can't expand. Compliance is defined as the relationship between volume and pressure. We're going to get more into that later. Don't overstress that. But it's looking at the relationship of how much volume can get in and how much pressure it takes to get that volume in. That's compliance. So in other words, if I can get a breath of 500 cc's in and I get a peak inspiratory pressure of 35, if I do that ratio, then I've got a good airway compliance. And we'll go over those numbers when it comes to vent. We'll talk about ranges of compliance and numbers of compliance, but just overall. So restrictive lung diseases, there are maybe 3 major types, but what restrictive airway problems are is that I cannot get air in, okay? So we got a low compliance. The problems with low compliant lungs are that they're stiff, right? So we're talking about ARDS, right? Can't get air in because it's full of gunk, pulmonary fibrosis, all kinds of stuff like that. We could have a rigid thorax, again with injuries, medications can cause that, disease processes, neuromuscular diseases, all kinds of things can cause a problem with the thorax and getting compliance issues. Or we can use a too small of an ET tube, right? Or we can have airway edema, something that's going to cause an obstruction of air getting to that lung. That would be a low compliance problem. A very high compliance problem would be, as we said before, end-stage COPD, right? Again, because their alveoli are so overdistended, right, that we're going to get a lot of air in there just to oxygenate those alveoli. And so that's low compliance. We can get tons of air in there. So we don't have a compliance issue there as much. We have an elastance issue. They're overstretched. Okay, there are 2 types of compliance. One's dynamic and one is static. But we're going to talk about, when we get to vent, we'll talk about more of that when we get to vent. Now, elastance. So think of a rubber band. If I've got a rubber band here, it's brand new out of the bag, and I pull it back. Right? If it's a brand new rubber band, is it going to pull back pretty good? It will. It'll pull back pretty good. If I let it go, it'll shoot you in the eye. Right? So that would be good compliance. What would a rubber band look like if I had poor compliance? Very floppy, right? So if I pulled it back, I keep pulling it back, pull it back, because it's been pulled back so many times, it's very floppy. And when I let it go, it kind of goes, like that, right? And so that's a good analogy to me. Now, what happens if I want to pull it, what if I pull it back, and then when I let it go, if I don't let it go, I pull it back and just spring it. And then the rubber band shape, does it go back to its original shape? Or since I pulled it back one time, now I can't use it again. Yeah, you can use rubber band several times before it stretches out, and that's the elastance. So if I take it one time and I pull it back and I shoot Kaylee, and she throws it back to me and I do it again, it's going to spring back the same way to the first time. That's elastance, the way that the rubber band springs back. But eventually, elastance is going to go bad there too. So that's why I think of compliance and elastance, is to think of the rubber band. And that analogy is going to be good when we get to hemodynamics too, when it comes to cardiac output and things like that. Starling's law. Never heard about that. We'll talk more about the rubber band then. But that's how I see it. I don't know if you see it that way, but that's how I see compliance, is the pulling back, and the elastance is the fact that it goes back to its original shape, even though I pulled it back once. It's going to go back to its original shape. And that's what our lungs are doing every time we take a breath. It goes out and goes back to its original shape. And it goes out, goes back to its original shape. Goes out. So we have good compliance and good elastance. Okay, because our lungs don't go bad after one breath. They last for a lifetime. So unless we mess them up with COPD or something, right? So, all right, so here's a chart where I documented tidal volume on the y-axis and peak inspiratory pressure on the one. So I'm looking at what term? What airway term am I looking at here? I'm looking at volume and pressure. So compliance, right? The relationship of compliance. Since the patient's breathing, this is dynamic compliance, okay? So say I've got a normal patient and I give them 450 cc's of air, okay? And where does that correspond on the peak inspiratory pressure? Say 18? That'd be a normal value. That'd be a normal lung. Those are healthy lungs with good compliance and elastic lungs. That's how I would describe that. You need to know that because I will test you on different patients with different numbers of PIP and volumes. And you'll have to interpret for me, does that patient have good compliance or bad compliance? What do you think about the elastance on this patient? So you're going to see something like this on a test. Now, the yellow line is a sick patient. These are sick lungs. I gave the same pressure, but what happened to the volume? Okay, why? Bad compliance. So I've got no compliance, which means the lungs did not inflate as much as the first one did, right? So under the same pressure, I've got the same compliance, okay? So these is a poor compliant lung because they're stiff, okay? Do you guys see that? So compliance, see how the relationship of volume and pressure now? There's a relationship between volume and pressure when you're looking at compliance. And in the healthy lungs, if I set it on pressure ventilation, I could get in a good tidal volume because the lungs allow it, or my rib cage allows it. But if I go to a sick lung, say with ARDS, and I do the pressure ventilation at that pressure, I'm only going to get far less volumes because the lungs just won't take the volume, right? Well, is that volume enough to oxygenate and ventilate? I don't know. I got to evaluate that, don't I? But understand just basically that compliance means that a high compliant lung or a normal compliant lung is good, low compliance is bad. Okay, talk about resistance. Resistance can be pulmonary and airway. Resistance is simply talking about the amount of force that's needed to move a gas through a tube, right? So it could be the bronchiole we're talking about. It could be the trachea or the alveoli. The respiratory system is normally resistant to gases. It just is. Gases create friction when they move through something. They just do. Their molecules are going to bump along the trachea and do all those things. It's a normal physiological occurrence because of friction, right? Tissue resistance will increase with the application of pressures. This is defined as the opposite of pressure divided by volume. It's the opposite. Again, we'll talk more about that when we get to vent. We're talking about obstructive lung diseases here, where air cannot get out. Remember the last one was resistive air diseases, where air can't get in. You need to know the difference between resistive air diseases and obstructive air diseases. Resistant air diseases, I can't get air in. Pneumonia, pulmonary edema. Obstructive lung diseases, I can't get air out. COPD, asthma, breath stacking, volume retaining, however you want to say it. High pulmonary resistance, asthma, because of the bronchoconstriction. COPD, same thing. Remember Dr. Tan talked about Bousillot's law, however you say that, you mentioned a little bit. So we're going to talk about a little more detail. That's related to the flow of gas. Now, I do not want you to memorize this chart, okay? It's not in red. But the more important thing I want you to know is the radius of the tube is the most important part of resistance. The radius of the tube, you'll see this on a board exam, because I've seen it on a board exam. The radius of a tube, doesn't matter if it's a water hose, fire hose, your water lines at home, your alveoli, your capillaries, the radius of the tube is the most important part of flow. These other things matter. The length of the tube matters, of course, and other things like that, but radius by far is the most important. 2 is the 4th power of 16. That sounds confusing, but we'll get to it. So radius of the tube, okay.
And say that again, it's the most?
is the most important part of Poiseuille's law. Basically, the reason why is because if you take a radius, just whatever it is, you put it in half, it reduces flow by 16 times. It reduces flow by 16 times simply by halving the radius. From a 2-inch pipe to a 1-inch pipe, you would think the flow would be halved. No. The reason why is because this. The formula for resistance is radius to the 4th power. To the 4th power. So every time you go down in a radius, you lose 4 times flow. Write that down. Every time you go down a power in radius, you lose 4 times flow or more. Here's an example. I have a radius that's 4. Because resistance is radius to the 4th power, that means my flow is 256, my volume. Whatever that is measured in, doesn't matter, it's 256. If I take that 4 radius and half it, my flow is what? 16. In half. That matters. Why does that matter? What conditions does that matter in? Asthma. Have you ever seen anybody die from an asthma attack?
Yes.
Yes, I have too. Right in front of me from an asthma attack. Why? What killed them? Did their heart just stop arbitrarily? What killed them? Plugged. What's plugging up? Bronchioles and alveoli. And the more plug occurs, it drastically drops flow. And we're talking about airflow now. Oxygenated air, because you put them on a 9er breather. Did it do good? No, because we can't get it in. We can't get it in or out. So a small change in radius will create a huge change in flow. You know this already because you're paramedics and you have IVs, right? Have you ever pulled up a 16 gauge IV next to a 22 and hold them up to each other and looked at the lumens? By eye, does it look like there's much difference in size? It doesn't. I mean, one's bigger than the other, but would you imagine that the flow would be an 80% drop in flow from a 16 to a 22? 80% drop in flow if you went from a 16 to 22. Because you're going to see now how important the radius of something is. How does this matter to us? Well, friends, size matters. I'm telling you right now, okay? This is how it matters to us. How many people have intubated someone before? Okay. Do you know that the normal glottic opening of an adult male is 10 centimeters? 10 centimeters. 9 to 10. We'll say 10. Glottic opening. Given the formula, that's 625 units of flow, whatever it is. If I would intubate that patient, an adult male, with a 10 millimeter, should be centimeter, opening, and I put a 7.5 in them. And that's generally what we use to intubate adult male, do we not? Be honest. Be honest. Yeah. What did we do to flow?
By 68%.
We cut it by 68%. Why is it not a big deal? On the surface, isn't a big deal because they're receiving positive pressure through the tube, right? So we're pushing air in. We're overcoming that flow. But what if I intubated myself right now with a 7.5 ET tube and started walking around with it? How long could I last with that tube in my throat? Honestly, I wouldn't last very long because it'd be very uncomfortable. Why would it be uncomfortable? Because I'm slowly suffocating myself. I'm not getting the volume and the flow that I'm used to. Like right now, I'm getting 10 through my pie hole, right? Through my opening. I'm narrowing that to a 7.5. And I'm using negative pressure breathing to breathe. I'm going to have a problem soon because I've got to overcome the resistance of the tube, I've got to overcome the length of the tube, and now I've got to overcome the radius of the tube that's shortened, that's smalled, right? So I'm not going to last long until I'm going, screw it, I don't want it no more, right? Huh?
You also took out your PEEP.
And I took out my PEEP. Yeah, anyway. You see what I'm saying? So what's the moral of the story? Don't intubate an adult male with a 7.5. Right, got training officers, do you agree or disagree? Okay, they agree. Don't do it. Just don't do it. Again, you're putting in positive pressure, so you're overcoming a lot of that problem. But at the same time, let's get some flow in. Let's go with an 8.0. If we put a 9.0 in, we're only reducing flow by 35%. That's much happier. That's much happier. But I'm not here to tell you what to do. I'm just telling you to be mindful. No, I'm here to teach you, not tell you. Tyler, stop looking like that. I'm not telling you. I'm just saying. That the higher lumen ET tubes are better, and this is why. Because of flow, okay? All right, that's it. I got nothing more to tell you, okay? I got nothing more. I'm done. We're not done for the day, though. We're not done for the day. No, we're not. No, okay. So homework, let's just cover it now. We need to read chapter 6, chapter 8, and chapter 9. Chapter 9 you may have already read. That's the lab chapter. Your ABG practice I gave you is due by the test day, which the test day is August 22nd. Remember the sheet I gave you this morning, the ABG homework? It says homework on it. If you return that, you get 1 point on the test. The websites we told you about, the practice ABGs, are there. The ABG Ninja and the ABG Interpreter. Those are two separate websites. Next week, we're going to do a reverse classroom. Does anybody know what that is? Exactly. So there are 3 topics up for grabs. I can either do it, well, I'm going to do it random, just make it fair. So one group is going to get diffusion gradient of gases. The other is going to get VQ mismatching and matching. The other one's going to get oxyhemoglobin curve. You will have 15 minutes, or 15 to 20 minutes each group to teach the class. So then we're going to score this. We're going to score this. So if you guys have oxyhemoglobin association curve, you get to teach as a team the class. Then you get points for that. Then you guys get points by asking them questions they can't answer. Okay? So if you can answer a question that they can't answer, then you get a point. If you ask a stupid question like, is a right shift red line or something, then they can answer it. You get no point for that. So part of your homework is to come up with some really snazzy questions for the groups that the other groups have. And then prepare your PowerPoint. It could be a PowerPoint. One group last year did a skit and we rolled on the floor laughing. It was hilarious. So do a skit, do a PowerPoint, do something. That's got to be at least 5-10 minutes in length. It can't just be 2 minutes and you're done. To a max of 20 minutes. I doubt anybody go that long. Okay? I'm going to randomize them. Yeah, so let's do it now. All right, let's do, let me just write them on a piece of paper and let's randomize them. All right. All right, so team, I'm still learning your teams. Team Mido, pick a number between 1 and 100. All right, team under pressers, pick a number between 1 and 100.
77.
And you guys get what's left. Because you guys won the, you guys get what left because you guys won the Kahoot. So you picked a 12. Yes, for the Kahoot to do. All right, you guys get diffusion gradient of gases. You guys get VQ matching, mismatching, and you guys get oxyhemoglobin association curve.
That's a fun one.
All right? All right, so let me write this down. So Midos, I gave you that one. VQ, I gave that to. Under pressers, oxy. Okay. All right, are you clear on the homework assignment, guys? Listen. Hey, we're not done yet. Not done yet. Listen, get together as a team. Come up with something to present first thing tomorrow morning. That's in place of your quiz. There's no quiz next week. It's this. There's no quiz next week. It's this. First thing. Okay, so be ready first thing in the morning to present and then have questions. One question each group to ask the other group, and we'll see if you score points on it. You don't lose points. You never lose points. So if you ask a question they answer, you don't lose points. But you have a way of gaining points.
So none of us can answer it, we all get a point?
No, they get a point. If you ask them and they can't answer it, then you get that point.
So I'm saying, if we all ask a question, we should answer it.
No, you don't get a point. No, you don't. Now, you should get a point, but no. Their job is try to take a point, basically, but they're not really taking a point. Okay, that's all I got for you. However, I do have another presentation to give you. I'm going to make it, what time is it? I'm going to make it optional. What I'm going to do is I have another PowerPoint that is an ABG continuation that talks really good about compensation. If you don't understand ABG compensation, stay for it. If you don't, just take your PowerPoint and go if you want. I suggest you stay for it. It'll only take another 30 minutes of your time. And it will hopefully give you more understanding about ABG compensation. But you don't have to stay. I won't think bad about you if you decide you want to go. One question is enough. Unless, you know what, I'll tell you this. If you want to ask more, you're welcome to. More you ask, more possibility questions, up to a max of 3 or 4.
What?
I think we should do a skit. Yeah.
There you go.
I love it. A musical. You didn't say no to a musical, Tyler.
You said no to a skit.
Yeah, he says there gets all the boys not doing anything.
The lights are behind you. You want to I'm still figures and stuff like that.
What movie?
All right. What's for dinner? Roast?
We got some roast, yeah, potatoes.
Potatoes and broccoli. Got everybody? Enough for everybody? No. Sorry.
Good. Oh, I still be rocking them.
If you guys haven't formed study groups yet, that would be a good idea. Start studying now on your second week until waiting until your 4th or 5th week to finally get a study group together. If you want to. Some people like studying alone. But if you like studying together, start forming them now. That's why you're in teams, quite honestly, to help facilitate study groups, you know. But it's up to you if you want to do them, you know. And then plus it's easier to laugh against a group of people than individually. So when you guys make a mistake or something, we can laugh at you as a team. Okay, ABG continuation. So it's all about acid, guys. If you haven't figured that out already, our body produces acid and we got to get rid of it. That's the gist of it. It's the acid is the problem. So the body must equal out the acid production and the acid elimination. That's what the pH is telling us. When the pH is normal, your body's doing a good job of relieving itself of acid. That's as simple as that. When it's off, your body's doing a bad job of relieving acid. So acid elimination occurs through CO2, right? That's the CO2 is the problem. We got to get rid of it through the lungs, and it happens in minutes because the heart is beating, the lungs are breathing. It's the easiest way to get rid of acid. So it's not the fastest is through the blood, obviously, but the lungs are the second fastest. Happens in minutes. The kidneys, though, take hours to days, and the reason why is because they got to play with bicarbonate, right? So the kidneys buffer acid by retaining bicarbonate or excreting bicarbonate. And it takes a while to do that. It doesn't happen within minutes. It takes hours for the kidneys to catch up to an acid-base disturbance. That's easy. Now, when you look at an ABG versus VBG, did anyone have any questions on the values? Was everybody clear? So your pH will be just about the same, no problem. Your PCO2 be very similar. Your bicarbonate will be very similar. Base excess the same. The only thing that's really going to be different is your O2, right? Because obviously, as we saw earlier, the hemoglobin is only filled partly way at the tissues because it's released O2. So if I do a VBG, which is a venous blood gas, I access a vein to get my blood gas, which I can do, they can do, then obviously I would expect my O2 to be lower. Don't make that mistake. When you look at an ABG and there's a O2 of 40, and you go to the doctor and go, hey, O2 is 40. No, it should say venous on there. And that's why we put a V, right? That's what the V stands for. These are venous values or A, arterial values. So look at that chart. Obviously, if we did an SpO2 on the venous side, it's going to be lower. Okay, compensation. We know that formula. You need to memorize that formula. You need to realize that cardiac anhydrase is the thing that makes this compound. That compound has got to be made by the body so that transfer can take place, right? Cardiac anhydrase is the enzyme that facilitates that transfer. So make sure you know that carbonic anhydrase does what it does. How do we define a respiratory acidosis? Well, it's high CO2 and low pH. The body has to increase bicarbonate to compensate. Would you agree? How does the body increase bicarbonate? Well, it doesn't actually produce bicarbonate necessarily. What the kidneys do is they retain a lot more of it than they excrete it. Okay, there is some bicarbonate production, but generally the kidneys are going to retain it, right? So the kidneys are told by the brain to keep more base because we're acidotic. And that's how the body initially starts to fight this acidosis. That's how it increases the bicarbonate to deal with this respiratory acidosis. If it's a respiratory problem, it's up to the body's kidneys to compensate. If it's a metabolic problem, it's up to the lungs to compensate, right? So that takes hours to days. In respiratory alkalosis, our PCO2 is low, our pH is high. We have a decreased amount of bicarbonate, or we need to decrease the bicarbonate. So how does the body decrease it? Well, the kidneys excrete it. So the kidneys play a big role in acid base. How do we know when that's happening? When we see compensation, right? We have to see the compensation occurring, right? In a respiratory alkalosis or acidosis, right? The bicarbonate's got to move. It can't stay within normal limits, 22 to 26. The kidneys aren't doing anything. Or maybe they're doing something, we haven't seen the effect of it yet. Remember, it takes hours to start seeing the effect. So if my patient goes in immediate respiratory acidosis from a drug overdose, and they're hypoxic for a while, and now they're in respiratory acidosis, how long will it take for the bicarbonate to start moving? It may take hours to finally get it moving. So that was part of the equation you guys were missing when you guys were going over the numbers, is you got to look at the caveat of what's going on with the patient to understand the numbers, what they mean. And why isn't the patient compensated or not? It's because it takes a while sometimes to get there, especially if it's metabolic compensation the body's needing. It's going to take a little bit to get there. Conversely, if the patient is in a metabolic, they have a low bicarb and a low, okay, we need to decrease the CO2, right? So how does the body do that? How does the body decrease it? Well, that's a much faster way. The lungs can handle that. So the lung respiratory rate increases. We increase our minute ventilation, and that takes minutes now. The bad part is that metabolic acidosis are so much worse than respiratory acidosis, so much worse. And so it still takes a while to compensate for a metabolic acidosis. And especially if it's a toxic alcohol metabolic acidosis, the lungs can't do that alone. It's just not going to happen. So we need extra help to do that. And we'll talk about more of that compensation later, but generally, that's how the body's compensating. And in metabolic alkalosis, we have a high bicarb, a high pH. We need to increase the PCO2 to compensate. How do we do that? Against the lungs. They decrease the minute ventilation, hold back more CO2, and that takes, again, minutes. It can go into hours as well. Okay, pretty simple. Talking about the carbonic acid buffer formula, there it is in the middle. That's cardiac anhydrase, creates that compound there. Compensation first starts in the blood. Did you know the red blood cells help with compensation? They actually have an ability to clean the blood to a very limited degree. It doesn't last very long, and don't expect it to save anybody, but its process starts in the blood. Then the pulmonary system and the renal system. Also proteins, like albumin, are a big help with dealing with acid-base disturbances. Phosphates, hemoglobin. Even hemoglobin will help out. They'll accept hydrogen at the cells. They'll accept hydrogen at the cells and move it to the lungs so it can be breathed out in CO2. It can combine with CO2 and it can be breathed out. Or, I'm sorry, it can be excreted out. What am I saying? You can't breathe out hydrogen. It'll be excreted out through the kidneys. Okay. So the relationship of, now someone had a question earlier about PCO2 and entitle. Was that you, Elizabeth? Or, okay. So he says there is no relationship, and that's true, but not necessarily all the way true. ETCO2 can be a good surrogate for entitle CO2 or PCO2, and we're generally looking at 5 points or less. So if we have an ETCO2 of 45, then probably your PCO2 is 40 to 50, 45 to 50. If our ETCO2 is high at 70, probably your PCO2 is 70, 75, but only if we have a pulmonary problem. If we have a problem of perfusion, right, then they're going to be vastly different. And that's one way of looking at that. You know, if I have an entitle, I drop off a patient at the ER and they have an entitle of 40, but they run PCO2 and it's 80, that's a big difference. That's not a pulmonary problem, that's a problem of perfusion down the road. So there's a way of doing it, but you got to make sure that the problem is only primary pulmonary problem, and then they'll be pretty much the same. Now you guys, there's 3 formulas that he showed you. Compensation formulas about pH. You have to know those 3. They will be on your boards, they'll be on the tests. You got to know them. And so when the PCO2 rises by 10, the pH is always going to drop by 0.8. That just makes sense. More CO is acid, drops the pH. When the PCO2 drops by 10, that's more alkalotic. The pH rises by 0.8. That's a hard, fast rule that will never change. That's one of the 3 rules that you must memorize and know. Has an inverse relationship. How do we know this? Well, if my patient has a PCO2 45 and an entitle 35 and their pH is 7.4, that's all normal, right? Would you say? But what if we intubate them and hyperventilate them? Are we going to throw their values off? We are. Say we hyperventilate them and we get their PCO2 to 20. Well, according to this formula, every 10 raises or lowers the pH by 0.8. So if I started with a 40, that means I lowered it by 10, by 20. Would you agree? I went from 40 to 20. Would you agree? Okay. What did that do to my pH? That raised it by 0.8 each 10. So I raised it twice. My pH was 7.40. It's now plus 0.16. I now have a pH of 7.56. Now I'm severely alkalotic. Sorry?
Would it increase about 1.6 or no?
No, it's point, no, that should be point, maybe that should be 0.08. That should be 0.08, shouldn't it? It only does increase by 1.6. That would, there's no way. Yeah, I think I got my math. These should be 0.08. Look at the chart he showed you this morning. Does anybody have that out? Double check me. I think I got that wrong. Sorry. Go ahead and write it in your slide. It should be 0.08 because the total is up to 0.16, which gives us 7.56. So I was wrong there. So just fix your slide. Okay. So base excess. What is base excess? Base excess normally is -2 to 2. What is base excess? What does this mean, right? It means that there's either too much base or not enough base in the plasma, right? So when BE is a positive number, like we'll see it as a base excess of 4, that means what? What does that mean? That we have, what does that mean? What is that telling us? A base excess of 4. Yeah, because the range is -2 to 2. So if our base excess is 4, we have too much base, right? We have an excess amount of base, or we have a deficit of acid, right? That's allowing the base to be there. So we can look at it either way. If it's a negative value, a base excess of -4, that's the opposite. That means we have a deficit of base or an excess of acid, okay? So the base excess is a magnitude of the direction of the, if you have not figured this out yet, I'm sure you have by now, that in a metabolic disturbance, look at the BE. If your BE is highly negative, that's a metabolic measure. So likely your disturbance is metabolic or respiratory. Which one? Metabolic. It's likely metabolic. And so that's a good indication because really it's pointing to our metabolic disturbance, this BE. It's the magnitude of a metabolic condition that's showing you how much base is present in the body at that time. There's either an excess of it or there's a negative base. Really, it's called base deficit, but we'll talk about that later. But it's a negative number for the base excess. So here's an example. So what's the first one? What's going on the first one here on the left? So they're acidotic. They're in respiratory acidosis. Would you agree? Oh, no, wait a minute. Is the CO2 acidotic or alkalotic? Normal range. Okay, metabolic. So look at the BE, negative 12. That should kind of clue you in. So what is the BE telling me at negative 12? What is it saying? I have a deficit of 12 units of base, right? And so what would I need to make things right? I would need probably 12 units of base to get up, or about 10 units of base to get within the range of negative 2 to 2 to compensate. So I have a negative base, which means I have an acidosis, and it's probably metabolic in nature. This is a metabolic acidosis, right? The bicarb is super, super low, and that's base. It is uncompensated because, well, no, the PCO2 has moved a little bit. No, it's not. It's with the normal range, so it's uncompensated. There's a large deficit of base in the plasma. Where's the compensation? None's occurring right now. What's the cause? We don't know, but the patient has had diarrhea. So now we kind of know, right? Don't we poop out our base? When you have diarrhea, you poop out a lot of bicarb. So you can, have you ever heard of someone taking like a lot of laxatives and killing themselves? That happens. Happened here in St. Charles County years ago, where you take so many laxatives and poop out all your base and die from metabolic acidosis. No kidding. No kidding. What about the one on the other side? Yeah. But this one took some kind of, he drank like antifreeze, right? How would we fix this guy who just has a base deficit from diarrhea? How would we fix him? Could we just give him bicarb? Yeah. Because this is the patient where you need to know the bicarb replacement formula because, they probably wouldn't straightly give it, and we wouldn't give it in the field, but all he's missing is bicarb. He's pooped out his bicarb, right? That's why he's acidotic. So replacing bicarb would probably help this guy a lot, by theory. Fluids and bicarb. What's that? Yes, exactly, yeah. But this cat on the right, though, he drank antifreeze, or whatever he drank, that caused him to have a toxic alcohol ingestion, which is going to throw him into an anion gap metabolic acidosis, we talked about a little bit earlier. You can't fix that with bicarb, right? That's not the case when we get bicarb. So that's why in the field we don't get bicarb, because we just don't know what the cause is, and we don't know what the values are, and we wouldn't even know how much to give to fix it anyway. Because there's a formula. You look at the base x-axis, I'm going to show you the formula again, and it tells you exactly how much bicarb to give, according to the formula, okay? So there's something to realize, to think about there. Now, in metabolic acidosis, those are split, just metabolic acidosis, those are split into a non-ion gap and an ion gap acidosis. So remember, Nate showed you this earlier? So the way he did it, I would like to simplify it, okay? The only thing you really need to know, and when you figure out the strong ion difference, and what the strong ion difference is looking at how many positive charge there are in the body versus how many negative there are in the body. It kind of gives us an idea of what's going on in the blood, right? So the positive ones are sodium and potassium all day long. On the other side, all we need to really worry about is the chloride for now, for the strong ion difference, because that's the most prominent negative anion. So the strong ion difference, we're just going to measure the sodium and the potassium and minus the chloride. If that number is under 36, then we're good. So we're going to talk more about this later in the course when we get to kidneys, but I just want to just confirm that with you. Same as the anion gap. Let's simplify that as well. So on the anion gap side, we're going to measure just the predominantly positives, which is the sodium, and he said the potassium's kind of iffy. Most people don't include the calculation because it's such a small value. The value of sodium is what, 135 to 145, right, in the body? Potassium is 3 to 5. So is 3 to 5 going to make a huge difference in the calculation? No. So a lot of people just ignore it. Over here, though, we need to know about bicarbonate because we're talking about an anion gap metabolic acidosis. So we take chloride, brown plus the blue, and that gives us the negative side. When we subtract the two sides, it should be around 12. If it goes over 20, then we know we have a significant problem, okay? So use that formula. Now, what if we have a non-anion gap metabolic acidosis? What does that mean? So over here on the right is where we're looking. See, there's 3 blocks of chloride, 2 blocks of bicarb, 1 block of unmeasured acids. The unmeasured acids are not in the formula because they're unmeasured. We don't know how many are in there. But we know how many there are in there, don't we? Because this side will never be bigger than that side. See, the blocks are equal in height. One will never be taller than the other. Never, never. The body will compensate and fix it. This is the magic of this, okay? So how does it do it? Bicarb. Adjust the level of bicarb, okay? So right now, we have our normal. We have the right amount of chloride and the right amount of bicarb, okay? But now, we're in a metabolic acidosis that's not ion gap. So in other words, the diarrhea patient, okay? What happened to the bicarb box? It was 2, now it's 1. The patient pooped out his bicarb. His bicarb level was low. He's in metabolic acidosis, right? If his bicarb level is low, okay. Well, what filled the gap? Chloride. Chloride fills the gap. And it's going to do that to make sure the boxes stay similar in height. One will never be taller than the other. So because we're missing bicarbonate, chloride steps in and fills the gap. Okay, that's a non-anion gap because the unmeasured acids did not change. Did not change. So the anion gap is still, if you run the numbers, the anion gap is still going to be good, okay? Because the same amount of negative is still there versus the same amount of positive. It's just a different electrolyte, but the numbers are still good. You understand that? But what if we get, okay, let's talk about non-anion gap real quick. So how does this happen? We simply lost bicarb through GI losses, or we can increase chloride. If we increase chloride, it's got to go somewhere. So what's it going to do? It's going to fill in that brown block, and it's going to kick out bicarb because it can't kick nothing else out. All right, so we have an increased chloride, and we can do that with over-administration of sodium chloride. Now, it takes a lot to do that, but it can happen. We can over-administer sodium chloride and get a problem there. How does it treated? We fix the underlying problem, and this is the kind of patient where sodium bicarb replacement is considered. Not something we would do in the field, but this is where sodium bicarb will be beneficial to the patient. Okay, what's the formula? This is the most simple formula I know. Take the patient's weight in kilogram, times it by the base deficit, and that's how much you get. So how do we do that? Okay, say we have a 100 kilogram patient divided by 4. According to our ABG, we have a base deficit of -9. So that's always a positive number in the equation because it's the opposite. So 100 divided by 4 is 25, times 9 is 225 milliequivalents of sodium bicarb. So we would take our vial of sodium bicarb, which how many milliequivalents in a vial? 500? No, it's more. How many is in a vial? How many milliequivalents in a vial of sodium bicarb? An amp. Is it 50? Okay, well, whatever it is, we would put 250 milliequivalents of sodium bicarb in a bag of saline in a liter and then run that over 20 to 30 minutes. And that's it. So I need you to know that slide. You will have a test question on a patient that needs sodium bicarb replacement, and that's the information I'm going to give you, and that's how you're going to figure it out. You need to know that slide for sure. If you want to use Nate's other slide with his other formulas, feel free to. Just use whatever formula you're comfortable with. I like the easier the better. The KISS method, right?
No, I just answered my own question.
Okay. Any question on that? So like I said, it's the base exit, but you reverse the sign. So this is always a positive number.
Yeah, it's 50 milliequivalents.
50, okay, so I would need how many vials? 5 or so. Mix it in a liter bag and run that in over 20, 30 minutes. But I'm down how much sodium bicarb? 9 something, 9 units, whatever you want to say, or 7, because of the -2, +2. So 7 to 9, I'm down sodium bicarb. The body is going to retain it, but how long is that going to take? Hours, days to do. So we can leave the patient for 3 days or give him sodium bicarb to help him out. Now here's a high anion gap metabolic acidosis. What's changed in the right box? We lost blue, but we gained red. So something happened to the body. The patient, somehow, inside the body now, we have more unmeasured acid. The only way that can happen is what? Someone put it there, right? You drank something you shouldn't have. You were injected with something. I don't know. There's a lot of ways it could happen. We have an acronym called mud piles we'll talk about later. But the body has too much unmeasured acids. That knocks bicarb out. So they're in a metabolic acidosis, right? But now they're in an anion gap metabolic acidosis. Where's the problem? The problem is when you run these numbers, you have a number higher than 20. Because we have a big positive versus a small negative. Because some of these unmeasured acids are taking part of the negative side, right? So now I have a big number, more than 20. And that's how I know I've got a high anion gap metabolic acidosis. How does this happen? Well, it can happen through lactic acidosis, ketoacidosis, renal failure, and of course toxins and alcohols are most common. I think I saw a board question once related to toxic alcohols and high anion gap metabolic acidosis. That's why it's in red. How do we treat it? Well, you got to find what the problem is, right? If it's lactic acidosis, it'll be oxygenate, keto, and so on. Okay, we won't cover that, and we won't do that. You guys shouldn't have those slides. You guys have those slides? You do? You shouldn't. You shouldn't have those slides there, because we changed it. You don't, right? Okay, that's just a review. I hope that helped you a little bit in understanding compensation and what we mean by got metabolic acidosis. We're going to talk more about it when we get to renal with Dr. Tan in a couple of weeks. All right? Good job. Week 2 is down. Week 2 is down. You guys did it. 20 more to go. We'll get there. Well, it's 22 weeks total, but there's only like 15 lecture days, actually. 15 or 16 lecture days out of the 22 weeks. Because remember, every test week is just testing. So there's no lecture those days. So you guys are almost an eighth. I guess I don't know. You're getting there. You're getting there. Math is hard, all right? Don't make me do math.